in Queensland, the main patient group was set up by someone who's whereas the group that never comes, although they never need to localised amyloid, which yeah, so I think it depends on I think TTRs Wales just staying the same, but TTRs is our biggest referral. I mean, hereditary is the same, secondary going down, senile amyloid, we're actually moving on now in Queensland. We've got our amyloid centre, but we're setting up because of TTR. We're not calling them subject. That sort of implies some sort of inferior status. But centres where we're going to include a monthly teleconference that will try and trials be able to get them there. Because there are, like in my hospitals, you've got cardiac centres, but the transplant unit is in a different place. And they've got a group of highly interested cardiologists. And then we've got places like Gibbs that are 50 kilometres away that patients can't come down. And then we've got private medicine in Queensland and and so there's a group of private cardiologists that are sort of separate again, trying to get a little coordinating network to try and we can't deal with the there's just too many. So trying to just diffuse expertise, if you like, in a sort of ordered fashion. So we've all got a similar database. Suggest these sites for trials.
At some point when
you had a bit of sleep tonight.
Look, I think because there's that overlap, it's always hard to sort out. In some places, cardiac device is not too big a deal. Like I'm lucky I'm a cardiologist in a lot of places. So it's very difficult to get these patients out that facility. It's partly different. They can't biopsy other people's body and really nowhere and time marches on. For an AL, you haven't got that time. For an ATTR, you do. For an AL, you're going to have a bit of a feel for these patients and try and guess what they are, a bit of the speed of your workup.
Patients and first and foremost, our motto is we are better together. And what we do, there's a lot of information out there for somebody that's just been diagnosed with the disease, so it's important that you get the most up-to-date and correct information on the disease. So we provide that. We provide treatment information as well. There's a lot of treatment currently being done in the market globally, which is fantastic for patients that, especially for the wild type and the hereditary, which at this point in time, as we know, is not cure. So providing correct treatment advice and information is very, very important. And further to that, once you think that you're not feeling well and you go to the doctors, generally you will not be able to get a proper diagnosis at that point. So what we try to do is to connect patients with the correct specialists that know what this disease is about. So we connect patients with the specialists either locally or overseas. Further to that as well, which is equally important, is we connect patients to patients, because at the end of the day, I think supporting one another is so important. Even carers, because I myself am a carer, and initially when my husband was first diagnosed, it was very, very difficult to come to terms with what was happening. And I remember wishing almost that I had somebody there that I could talk to and get advice from. So taking into account what we have gone through as a couple, we want to be able to provide this sort of connection between patients and carers with other patients and carers, because, you know, again, as I said, support is really, really important. So what have we achieved since the start of NZAPA? We have placed New Zealand on the treatment map for a lot of pharmaceutical companies. Prior to us starting the association, New Zealand almost is not on the radar for a lot of these treatment entities. So now that we have this association, we are really, really proud, because we are now on the world map. And clinicians overseas and pharmaceutical companies now realize that, hey, you know, we do have Kiwis who are suffering from this disease, so we need to also extend our support and treatment to this country. So we've done that, which is great. We also advocate for disease awareness. As I mentioned, a lot of doctors actually are not aware when they diagnose patients to take into account amyloidosis. So advocating for disease awareness and education is very, very important, not only to the patients themselves, but I think equally important to the practitioners, pharmacy people, even students in the medical profession. You know, I think it's important that they learn the features of this disease, so that when they eventually see a patient who has it, they won't waste time trying to figure out what it is. Right away, they'll take into account that, hey, it may be amyloidosis. I'm also proud that we're able to conduct workshops and conferences that will be held annually.
Good morning, everybody. Morning. Can you hear me? Yes. Welcome this morning back to our session, and I'll just tell you, my name is Lewis Randall. I used to be a doctor, and then I had to become a patient. And I can tell you, I think I'd much rather be a doctor than a patient, but there we are. But one thing you like as a patient is it's good to have good doctors. And our problem in New Zealand, being a small place at the end of the world, is having enough expertise in this disease, which is very rare. And one thing that we're fortunate to have is we have a couple of cardiologists here who have expertise in amyloidosis, which is really good. So I'd like to introduce, first up is Tim Sutton. And Tim is a cardiologist at Middlemore, as well as working in private in the Auckland Heart Group. He's got an interest in heart failure, and he's found that he's diagnosing amyloidosis with increasing frequency over recent years. And he's also spent time at the National Amyloidosis Centre in London, where he's learned a lot about amyloidosis. And we've also worked at other places as well, I won't say that. And also Nezar Amir, who similarly is a cardiologist. He's working on the North Shore as well as for the Auckland Heart Group. And he's also developed an interest in heart failure, and as such in amyloidosis. He's got a fellowship in with an interest in echocardiography as well as adult congenital heart disease. And he's also had a sabbatical working at the National Amyloidosis Centre in London, I think. Is that right? So I'll let you two guys talk to yourselves, and hopefully we'll have a little time for some questions at the end of the session.
Thanks, Lee. So I guess first thing to say is thanks to Jamie for organising this. It's a huge effort to organise a meeting like this. We're glad to support it. It's I guess it's the first time we've been to a patient support group. So thank you guys for coming and showing interest as well. So we're going to talk about cardiac amyloidosis because we're cardiologists. We know it affects other bits of the body, but for us that's our thing. So I think Nezar is going to lead off.
Yeah, good morning. So first I'd like to thank NZAPA for the invitation, and very glad to see that we have interest and support to our patients. And without any further ado, so I think my interest in amyloidosis started actually through my connection to hematology at the North Shore Hospital. I'm going to speak about the other amyloid, which is caused by plasma cell disease, or it's a form of blood cancer, in which the immunological cells start producing lots of protein that deposit in the heart. So about 5 years ago, my colleague and hematologist David Simpson started sending me these patients, and it was such an experience. They're complex patients, they're sick, you don't have a big window of opportunity to treat. They have multi-system disorder. If they have a myeloma type of cancer, some of them transform into more malignant forms, and the chemotherapy is horrible. And I started to evolve that interest, and then gradually started to see the other side of amyloidosis, which is becoming increasingly prevalent, which is the transthyretin amyloidosis, which is becoming the dominant figure in our practice. But it's always the complex part of, in the diagnostic algorithm, how to exclude the AL amyloidosis. This is the bit that we have to take away before we come to a transthyretin amyloidosis diagnosis or other type of amyloidosis. Can you have the next slide, please? Oh, sorry. No, I can do that from here. So, as you all know, amyloid is a deposition of extracellular proteinaceous material, and the word is from the word amylum, which is a starch-like material. This is a section in the heart, and it's stained to show what this thing looked like. Under microscopy, using immunofluorescent technique, which is designed to color the protein itself, we see that sort of green color on it. And that is the diagnostic Congo red birefringence. So this is the diagnostic test for any amyloid. They all look the same under the microscope with this special stain. The disease can deposit in any part in the body, as you know. The heart is an unprivileged organ in this area, unprivileged in a way. But other organs, the nervous system, the kidneys specifically, and many other organs can be the culprits for this. So just a sort of a summary, the types of amyloidoses are the immunoglobulin, which is the light chain, which is the purpose of this presentation. There's the wild type, in which you have a normal protein called transthyretin, which is potentially amyloidogenic when it changes in its shape and turns into a protein that deposits in various body organs, predominantly the heart. There are the hereditary forms of amyloidosis, in which there is a mutant protein that will be predisposed to become amyloidogenic and deposit in various organs. And there is the vanishingly reduced but still present AA amyloidosis, which is caused by chronic inflammation. We used to see it more frequently in the days of rheumatoid diseases and chronic tuberculosis and things like that. We no longer see it, or we see it much rarely. Actually, I bumped into a patient a couple of weeks ago who has chronic skin disease, who had this condition. So the focus of today is, for my talk, is the AL amyloidosis, which is the immunological part of amyloidosis. And for us, this is a very uncomfortable area for a cardiologist. This is really uncomfortable because this is the bit in which it is a cancerous process. It will require a different approach. It will require chemotherapy, and it has a small window of opportunity. So it is really a squeeze when we see these patients who have hearts that look abnormal, and they could have the AL amyloidosis. It is really critical. I think it was made more complicated by the fact that the age groups are the same, as you will see. and the presence of another condition in which you have slightly increased immunoglobulins in the blood, but not cancer, called MGUS. I think Dr. Mullen might talk about this later. So the fibrils, which are forming the amyloid, are made of fragments of monoclonal light chain. I'll come to this in a second. It can be an isolation in 50% of cases, and other 50% of cases is in association with other plasma cell disease, and I'll explain what a plasma cell in a second, and they're monoclonal light chains. So I was telling my colleagues, my wife is a hematologist, and she looked over my slides yesterday and she nearly fell off her chair. She said, this is too simple. So, so this is what an immunoglobulin is. It's made of two heavy chains, and there are 5 of them, 5 types. And there is the light chain here. And this light chain is the one responsible for the AL amyloidosis. So the immune system is, just in a sort of a brief, once again, cardiologist viewpoint, divided into 2 broad categories. There's the innate and the adaptive. Not to make it complicated, the innate are the cells that attack the invaders immediately without any targeting. And the adaptive system is made of cells that analyze and target the invader in a more appropriate way. And these are the lymphocytes. So the lymphocytes are T and B lymphocytes, and T lymphocytes turn into plasma cell, and the plasma cell produce these proteins. And these proteins, in excess, if they are cancerous cells, and they have a single clone of cells, so they are one clone of cells that they all look the same, and they produce the same amount of protein. They probably generate from a single cell with single mutation in the genes. And these produce the same protein. That protein deposits in the heart muscle and causes the amyloidosis. The transthyretin is a very different path, and it's produced by the liver. And it's a normal protein. So this is the pathway of the AL amyloidosis. I think the condition is really not common, and quote is about 1 to 100,000 cases of primary amyloidosis per year in New Zealand. I quoted this from my colleague Hugh Goodman from Hamilton. There are delays in diagnosis. You need to see few doctors, and I think most of you who suffer this condition would have been through this path, through the transthyretin type. Unfortunately, it does happen as well with the AL amyloidosis. So this is an older study now from 2015, and the biggest offenders are usually the cardiologists. We don't pick it that quick. It's a disease of older adults. The median age is about 64, mainly males, and it occurs in all races and all geographic locations. And it can be isolated, or it can be a member of a bigger condition. So it can be part of what's called myeloma, in which you have the heavy chains produced, and then it changes and becomes more and more of a light chain disease as well. Or it can be isolated. So for the purpose of today's, just what you just need to know that this is just could be a part of a bigger group, or could be in isolation. I'll show you a case at the end of this that I'm working with at the moment for my patients. So the clinical presentation is very non-specific. Remember, this is a form of malignancy, cancer. So most of the symptoms are actually non-specific. Tired, fatigue, shortness of breath. So shortness of breath is common. Renal involvement is common, especially when you're dealing with the myeloma type of light chain disease. Cardiac involvement can be the only presentation in patients with primary amyloidosis, in which you have only light chains without heavy chains. It's a very tricky disease to treat and to diagnose. Not difficult to treat, they tell me. You can have neuropathy, arthropathy, you can have skin disease, large tongue, large liver, bleeding disorders. Now, index of suspicion should be high in these contexts, but if you find a patient who developed heart failure with thick walls, basically, of the heart on echo, I think one should suspect that. And we'll discuss this later, how the overlap between transthyretin and AL amyloidosis can play out in a situation like this. Hence, it's important for us to remember that there are other features of the disease. So these are ugly photos of what you can see in patients with primary amyloidosis. A large tongue, where you can see how the teeth are attached to, sort of caused an imprint on the side of the tongue, purpura, or the skin diseases, and the eye manifestations and the depositions. How do we suspect it? Well, in many cases, they come from the hematology doctors, and they tell us this is a myeloma that turned bad. Come and look at this for us. In the other 50% of cases, they can walk in your office like this. They have heart failure, thick hearts, abnormal ECGs, and abnormal biomarkers. So they have elevated proteins that come from the heart itself. And it's a primary heart condition. It is very, very, very important to remember that this can present as easy as it does. Echocardiography, these are the images that I thought I'll sort of share with you here, is very helpful. It's generally non-specific, but once you put it in the context, it's incredibly useful as a first imaging step. And I think Tim will go through the other side of it. Cardiac MRI is very important, with very specific findings of the position of the amyloid in the heart, in this area, right under the surface of the heart. And this is the diagnostic criteria, which is just a glance over, but it does require a biopsy. So this is a different disease from transthyretin, which you can diagnose without the need for biopsy. So the myeloma docs tell us all the time that you can't move this without showing that there is amyloidosis in a tissue. So the diagnosis depends on finding the amyloid from tissue, fat aspirate, Congo red stain, and then we send it for a special test called mass spectrometry, where we basically explode the protein, and then we analyze the amino acids and match them to a database, and from there we can find what type of amyloid we have. I'm sure whoever here in this room who had a biopsy would have had this test. Hematologists love bone marrow examination, and I think it is a critical test in this case. It can show the amyloid. It will show these cells to be clonal. They're all the same. They are not sisters. They are actually fraternal twins. They are very, very close. Very, very close. Now, this is a slide to show how this mass spectrometry works. So I don't want to bore you with this. The treatment, from our point of view, is really supportive for this condition, and the outcome depends on how quick we get to the amyloid or how far we can get rid of it. About a third get very good cure, about a third are left with some cardiac disease, and a third will be stuck with some cardiac, some long-term important cardiac disability like heart failure or arrhythmia. So the sooner you get to it, the better. So you can see here that's the ATTR have a 5 to 10% chance of overlapping with this monoclonal gammopathy, which I believe will be covered by Dr. Molly later in this morning. So it is important to get this right. And I'm not going to go any further than that. So this is the patient I met with about 6 weeks ago, who was referred for symptoms of shortness of breath and a slightly elevated NT-BNP, 47-year-old. And he'd been short of breath for about a year. I did his echo, and it was just very concerning to see that the ventricle was very thick. This is quite a thick ventricle and very restricted in movement, and my immediate diagnosis was highly likely to be cardiac amyloidosis. I admitted him to hospital. He was seen by 2 physicians and 2 cardiologists and was discharged home without the basic tests for AL amyloidosis. Came back to my office about 3 weeks later for me to follow up on the diagnosis. We have very high light chain, and he undergone a bone marrow biopsy that showed a clonal population of cells, and he's going to go undergo chemotherapy, but he's going to get a cardiac biopsy before he gets his chemotherapy. So this is a relatively speedy diagnosis. This guy would have probably not had this diagnosis that quick, but it was interesting to see the process that, to see what happened to this patient. Oops. Sorry. Okay. So just a final slide on this condition called MGUS, monoclonal gammopathy of unknown origin, and you see how high it is in the older population. This is American data. And thank you very much. So I'll leave you with Tim, who's a cardiologist with interest in heart failure and run the amyloidosis clinical trials in New Zealand for a while now. Thank you, Tim.
That's the trial. Thanks, Nezar. So, hopefully. So I've sort of been seeing patients with amyloid, I guess, for 10, 15 years now. And I'll talk through why we're seeing it more and why it's getting more common. That's my talk, sorry, finished. I can't go forwards. Oh, there we go. So this is how amyloid is generated. So I'm going to talk about TTR amyloid. There's about 60 different types, but really as a cardiologist, the main one I see is the TTR, and all TTR means is it's to transport thyroxine and retinol. So we need it to carry the thyroid hormone around our body and vitamin A. So if you get some of the more advanced treatments, you do need vitamin A supplementation. And we all generate TTR amyloid, so we've all got it in our bodies and we need it there. And it's normally this tetramer, so there's 4 proteins all bound together. And along the binding sites, you've got different proteins that will connect with each other. And that's where, if you have a genetic mutation, you have a problem, because the glue that holds your TTR together isn't quite perfect, and it'll start to become unfolded, and then it starts to fold up in a skewy pattern rather than like it should do, and that's when it starts to deposit in the organs in the body. And the wild type TTR, once again, you've got the same process going on, but for some reason the natural glue that holds your TTR together isn't so effective. That tends to occur later in life. And if you take men's hearts, and they've looked at a series of 80-year-olds who've had postmortems, 25% of males will have amyloid in their heart. It may not have caused a problem, but if you look for it under the microscope, it's there. So it's a natural part of the aging process. And with all things in life, there's a sort of a bell curve. So some people get disease at an earlier age. A lot of people, naturally you may find that all males who reach 130 get TTR amyloid. We just don't know because we don't live that long. But it is a natural part of the aging process. But the TTR can also deposit in the nerves, which gives you the peripheral neuropathy with it. It can go to the gut. So if you've got the genetic form, it can deposit in other places. But the wild type TTR, which is the non-genetically determined one, has a tendency to go for tissues. So I guess what I'll talk to you about first is how does a normal heart work? Because I think most of you are not doctors. So to understand how a disease affects the heart, you've got to know how a heart normally works. And these are the phrases that we use. So the heart has got muscle. And that's all that myopathy is. It's a disease of a muscle. And the way our heart works, it's a pump. So everyone in their head can imagine a pump has to squeeze to empty. And that's an easy concept to get your head around, and that's systole. But TTR amyloid tends not to cause systolic dysfunction. The AL amyloid, light chains are actually toxic to heart muscle. So if you have really high light chains, that can affect the function of the heart. And the bit that people don't necessarily appreciate, if you don't prime a pump properly, it won't empty properly. And the analogy I use, rightly or wrongly, is firing a gun or a cannon. If you don't prime a cannon or a gun properly, it won't fire. And that's what the problem is with the heart. So it's diastole, which is the filling of the heart, is where TTR amyloid causes a problem. And in the heart, I guess if you remember back at school, there's two chambers. There's the atrium, so that's the collecting chamber, and the ventricle is the pumping chamber. And amyloid can affect both of those, but how a ventricle works, it's normally elastic. So if you imagine you've got a balloon and you pour 50 mils of water into the balloon will expand. You pour 100 mils in, the balloon will get bigger, and when you stop pouring water in, the balloon will squeeze and squirt the water out, and that's how a normal heart works. It's elastic, so you put more volume in it, it contracts to the volume that you've stretched it to. Now, if you've got TTR amyloid, the volume of your heart is restricted because, as I'll talk about in a minute, the amyloid builds up in the muscle. So you can pour 50 mils in and the heart can cope with that. But if you imagine that it's like having a cup, or an egg cup, say I pour 50 mils into an egg cup, it'll be fine. If I put 75 mils into an egg cup, it'll overflow. If I put 75 mils into a balloon, it'll expand and accommodate it. And that is how amyloid affects the heart. So your heart just can't fill as much as it should do. And because the heart's a bit stiffer, your pumping chamber, the atrium, has to squeeze a bit harder. And we'll come back to what that does to you over time. So that's the dynamics of a normal heart. And the other bits of a heart, I'm doing very well here, it's organised. So there's the electrical system. So amyloid can build up in the electrical system. It can cause issues with the conducting tissues and abnormalities of the heart rhythm. It can deposit in the heart valves and make the heart valves thicker, and sometimes they don't open properly or they'll leak. Or it can build up in the lining of the heart, and it's not uncommon to see builds up of fluid in the pericardium or a pericardial effusion in people with amyloid. And also it can build up in the blood vessels, not so much with the TTR, but with the AL. One of the ways that people present is they have angina, or symptoms like angina, so they get tight in the chest when they walk, but their heart arteries are widely patent. So they've had an angiogram, their troponin test, which is a heart muscle protein, is slightly elevated, and they say, oh, there's nothing wrong with your heart. But it's actually the heart arteries have trouble with the microcirculation, so it can cause symptoms that way. So how does TTR affect the heart? It's what we call a deposition disease. So if you think about heart muscle, hopefully I've got a picture of it here we go. So heart muscle is these sheets, and they all interlock, and heart muscle works by contracting. So you just get these fibres that overlap, and this is what normal heart muscle looks like. Now, ignore the fibroblast thing, this came from an article talking about both. But what happens is the amyloid builds up in the spaces between your muscles called the interstitial space. And what that does is your heart muscle gets spread out, so it just can't shorten as effectively as it should do. Now, it can still maintain the output of the heart, but it just can't increase it as much. So the cardiac output will drop off, but the ejection fraction often stays preserved. And over time, you can see the muscle gradually gets spread out as more TTR sort of deposits over the years. Cool. Yeah, and it affects the heart, the ventricle more than the atrium. So the atrium can get TTR in it, but there's not a lot of muscle in your atrium, but the ventricle is a big chunky thing. And interestingly, TTR amyloid causes more thickening of the heart than AL will. So AL tends to present earlier in its deposition because it's more toxic for the heart. Sorry about this. Here we go. I'll whiz through that. That's good. Cool. Great. Cool. If we go forward again. Yeah, so like I say, so in systole, the squeezing function, amyloid will impact on the ability of the heart to squeeze, but usually the ejection fraction, which is one of the measures we use, is preserved. But you may have read ultrasound reports or doctor's reports, and it talks about LV strain, and that's the way the heart thickens and shortens. So you can maintain your ejection fraction, which is how much blood you squirt out, but the strain's disrupted. But really what it does is it reduces elasticity of the heart, and that's the whole business about filling. You can only get so much blood in. And as time passes, the heart gets stiffer, causing more symptoms of breathlessness. And that's more of an issue when you walk, because when you walk, your heart goes faster and your heart has less time to fill. And that's why people get breathless with amyloid. And gradually the pressures go up, and that predisposes to fluid retention, basically. I'm cool with that. Here we go. So how do we diagnose TTR amyloid? Well, as Nezar said, it often takes a little while to be picked up. It's what we call the index of suspicion. So you've got to think about it. And I guess as a cardiologist who sees people with heart failure, it does come across my mind when I see people with heart failure. But what are the things we think of? There's this business of a preserved EF. So that's people who present with symptoms of heart failure, so they get breathless or they get swollen, they may get abdominal distension. But the heart works normally when we measure it by ejection fraction. And if you look at a population with heart failure with a preserved EF, about 15% of males will have TTR amyloid as the cause. So it's being under-recognised. Often what used to happen, I guess if you went 10 or 15 years ago, the problem was we had no treatments. We didn't have good investigations and say the heart's a bit thick, you've got heart failure with preserved EF, this is how we treat it. But we didn't go looking more for the cause. People have had non-cardiac symptoms. Now, I'm suspecting the vast majority of your TTR amyloid that's wild type have had carpal tunnel syndrome. That happens about 5 to 10 years before you actually present with your cardiac symptoms. And 10% of people who have carpal tunnel syndrome release, which is the little tendons in the wrist, actually have amyloid, TTR amyloid in their carpal tunnels. People can present with spinal stenosis, so the TTR can build up in the lining of the spinal cord and cause symptoms in the legs. And I don't know how many of you have got biceps muscle ruptures. It makes you look like Popeye. So what will happen is you get a ping in the arm and the bicep suddenly looks super buff, basically. But what's happened is the amyloid is built up in the tendon and it'll snap. So I can see a few of you showing off there. So, but it's something that, you know, it's under-recognised, but when you see it, well, yeah, that's quite obvious. The other thing is if people have high blood pressure makes your heart thicken. Now, as a rule, as we get older, all our blood pressures go up. But some people with amyloid, because the heart is a bit stiffer and not working so well, your blood pressure actually comes down because you can't generate high blood pressure anymore. So someone who you see with heart failure, who's previously had high blood pressure that starts to need less medication, you've got to have going through your mind, could it be amyloid? And of course there's the family history, because some people will have genetically determined TTR amyloid. And then we do examination looking for signs of venous congestion, so that's swelling can be in the abdomen. We look at the veins in the neck, we listen for the murmurs, listen to the lungs. And it's important to check the postural drop as well for reasons I'll come back, because often people feel dizzy when they stand up, especially if you've got nerve involvement, because you get what's called an autonomic neuropathy, and that's the system that controls our day-to-day functions like the bowels, the heart rate, your breathing. It's not something you have control of, but when it gets affected, it causes all sorts of mayhem that you may not realise will occur. And then we get on to doing investigations, like Nezar said. We do an ECG, hopefully. We do blood tests first, sorry. We do cardiac biomarkers. Those are the troponin T and BNP. The troponin is a heart muscle protein. That gets released when the heart's unhappy for a whole group of reasons. The commonest one is a heart attack. But not every elevation of the troponin is a heart attack, but it's often how the pathway is set off. BNP is essentially a hormone produced when the heart's under stress. And the more stressed you are, the more you produce. So if the BNP is high, it's a marker of how the heart's coping. We check on the kidney function, because that gives you an idea of what might lie ahead in the future. We check on the albumin, that gives you an idea of how nutritional status is. Because if you're not getting enough energy in, when you have heart failure, you burn off energy, this will drop down. And like Nezar said, these are the tests we do, ruling out AL amyloidosis. And then we'll go on and do an ECG, hopefully. So the ECG as a cardiologist is our basic test, which hopefully you'll see. And what we look for on an ECG, normally when a heart is thick or hypertrophied, the ECG has a typical pattern and the complexes on the ECG are big. But with amyloid, there's not hypertrophy, there's replacement. So if you see an ECG as a doctor that you've got an echo that says a thick heart and an ECG that doesn't say a thick heart, that should raise the index of suspicion that someone has TTR amyloid. And often you'll see change over time. We can see patterns that suggest someone might have had a heart attack before. We can see the heart can be going slower. So there's a whole heap of things you can see on ECG, and change is the important thing as well. And as a cardiologist, our other, here we go, oops, can you go back one? Our other go-to investigation is an echo. Hopefully it'll play. So like Nezar showed you, if you read there's this LV strain plot with a cherry on top or apical sparing, and that's because amyloid typically builds up and affects more the base of the heart than the apex of the heart. And if you look at this bit is the apex, and it's squeezing more than the base of the heart, and that's all we're seeing on this thing. It just shows that the speed at which the heart's moving, and it moves better at the apex than the base. The other things we can see on echo, you can see the thickness of the heart function. We measure heart elasticity, we can look at the heart valves, we can look at pressures inside the lungs, and that all gives us useful information about thinking what's going on and what may lie ahead in the future. And with serial echoes, you can assess people's response to treatment as well. And then once you've got someone who you've got a suspicion they may have TTR amyloid, this was really a game changer in terms of enhancing diagnosis. So a DPD scan, initially they used to be done for people with cancer, and you were looking for metastases, or people with arthritis looking for infected joints. But what people started to see was there was this tracer uptake in the heart. And then someone said, oh wait a minute, we've got someone with uptake in the heart who's breathless and they've got a thick heart. And that's how DPD scans grew from being something that's used primarily looking for bony disease to something that as a cardiologist we use to look for TTR amyloid. And there's different phases. There's grade 1, which is where the heart doesn't look too impressive and the bones take up more, but the heart takes up a little. There's grade 2, that's the heart there, but the heart and the bones are pretty similar. And a grade 3 one, you can see the heart takes up most of the tracer and the rest of the body doesn't take up so much. These are the kidneys and bladder, that's the other bits you see there. But the DPD scan is now the go-to test. So if someone has a thick heart, you've got a suspicion of amyloid, this is the test you should do. But what used to happen, if we went back 10 years ago, MRI was taking off. And we used MRI when people had thick hearts, looking for scarring in the heart as part of a condition called hypertrophic cardiomyopathy. And that's really how I started to see amyloid, because you'd suddenly get this result showing the patient had amyloid. And the DPD scans were only available through the private sector of New Zealand Medical Imaging, but now we can get them done at Auckland, so there's much easier access. And we're doing them a lot more. And the guys at Auckland are just looking at their outcomes. MRI produces beautiful pictures, and it's a very good way of assessing heart muscle tissue. And what you can see is there's lots of expansion of the extracellular volume, and that's because you've got that deposition. It spreads out. The heart muscle and the extracellular volume figures go up, which is here, so normal's down around 30. So MRI is a useful tool, but not the main one. And really, you don't need an MRI to diagnose TTR amyloid. And the guys in the Amyloid Centre, combined with the guys in the US, have come up with this pathway to help us diagnose TTR without actually doing a biopsy if we can. So essentially, as we've talked about, if you've got symptoms, an ECG or an echo, and if you've even had an MRI, then you can make sure there's not excess light chains. And about 30% of people will have an abnormal blood test for this, and it takes us down a different pathway. Bone scintigraphy has suddenly become so much more widely available. If the bone scan is abnormal, you've got no light chains, you have ATTR amyloid. So it saves people having a biopsy of some tissue. And from a cardiac perspective, really the biopsy you need is heart. If you've had a biopsy from another site, then you can always get that looked at for amyloid and assessed, like Nezar talked about. But really we want to get heart tissue if there's light chains. And if you've been told you've got ATTR amyloid, you must have gene testing, because the question is whether it's wild type. So if you as an individual, that's important, but you can't pass it on to your family, or whether you've got a genetically determined type. Now, the incidence of the genetically determined TTR amyloid in the population is about 1 in 50,000. But as I've talked about, the wild type is much more common. So in the heart failure population, it's about 15%, and people with narrow heart valves, aortic stenosis, 15 or 20% of them will have, or 15 or 20% of males will have TTR amyloid as well. Patients who've been told they've got hypertrophic cardiomyopathy, just thick heart muscle, about 5% of them actually have TTR amyloid. So it's out there, And because DPD scans are being done more, it's being picked up more easily, basically. And I'm sure over time we'll see more people being diagnosed. If you have a biopsy and it gets its mass spectrometry done and it's abnormal, you go down this pathway, but if the mass spectrometry is negative, then you should be looking at other causes. And the DPD scan has about a 90-95% sensitivity and specificity. In other words, it's pretty accurate, basically. And that's the pathway we should be going down, and it saves having a biopsy, which to me is usually a good thing. So the gene testing, like I say, it either tells you don't have a gene or you do. There's about 120 genes that have been shown to cause TTR amyloid. There's some that present with more neurological symptoms, and there's some that present with more cardiac type symptoms. Now the commonest one, I guess, on a global level is this one here, which is the valine 122-isoleucine. So that produces a change where your amyloid tends to unfold. It's not something we see in New Zealand, but this is common in people from the African subcontinent. So in the UK and in America, it's blood flows. If they present heart failure with thick heart, it's the first thing we think. And about 3% of the population actually carry that gene from Africa. This one is the valine 30, I can't remember what the M means, methionine mutation. That tends to present earlier. That's the Portuguese variant. This is a slightly different group than everyone else because they respond really well to liver transplant. And the others are sort of in the middle. There's a T60, this one here, is an Irish variant. So you can map where your genetic history comes from by if you carry the gene, because the genes come from different parts of the world. There's a Scandinavian one as well, which I can't remember. But like I say, at a global level, this will be the most common one. At an English level, at a New Zealand level, genetic variations are uncommon. Next one. But it is important to get the gene testing done. And then if you do carry a gene, you link into a genetic counselling service. Because testing for having a genetic test, for those of you that have had it, if you know you carry the gene, then it links you into a pathway for the future. If you don't carry the gene, it's great, but that's where genetic counselling is really important. And this gives you an idea of why there's been a delay in diagnosis. So if you look at what testings we've got, orthopaedic surgeons, with all due respect, expecting them to think about amyloid is not necessarily at the front of their radar. But that's often where they present first. And they present, like I said, with these sort of things. But then we often start up here, and you can see this is where the disease is at its most progressed. And this is where the disease is beginning, down here. If you could do a biopsy of tissue, but obviously you can't biopsy everyone, you can do these fancy tests, PET scans. This fluke beta here, that if you have that in your heart, it's really sensitive for TTR amyloid and AL amyloid. But the problem is you need a cyclotron, which generates the contrast that they use. So this is available only in small numbers at the moment. DPD scans have only more recently become available, and this is probably in New Zealand the earliest we can pick it up. But this is where we've been before. So the diseases are often presenting when things are quite advanced. And what we need to do is shift it this way so you can pick people up earlier, because the earlier you treat people, as I'll talk about, the better the response you get. But this just shows you here, it can take up to 3 years for people to be diagnosed just because of this and access to these. Like where I work at Middlemore, it'll take a year to get an echo. So there's a year to delay to diagnosis. So trying to get around these things is a challenge. Cool. And this is the impact DPD scans have had. So this is data from the Amyloid Centre in London. So this is when I started as a cardiologist. You can see mainly the people that were seen with the others, which is the ALs, and there was people with genetic disease. MRI came out 2005, and suddenly we were doing MRIs and finding more people had amyloid who didn't have hypertrophic cardiomyopathy. Then DPD scans suddenly took off in 2010, which was about the first time I went to the Amyloid Centre, and you can see suddenly there's this exponential increase almost in diagnosis of wild type TTR amyloid, and that's a function of the DPD scan. So that's when it suddenly took off as a diagnostic technique, and that's something that's just going to keep on going up and up. And one of the problems, as I'll come to in terms of drug treatments, is that this is a rare disease. This is not. When we think about what happens with amyloid, like we were talking about, this is where the disease is starting, and before it gets identified. At the moment, this is where we tend to pick things up. The natriuretic peptides are going up, the troponin is going up, the kidney function may be getting a bit worse. Usually the ejection fraction is preserved, but people start to get breathless. And ideally we want to pick people up at this, where things are early on. And these stages here where we use the BNP and renal function. So if your BNP and renal function is good, then you're in stage 1. If your BNP and renal function is not so good, you're in stage 3. And ideally, as you see, what treatment options? I think talk about heart failure first. So what treatment options do we have? The one proven drug for TTR amyloid is tafamidis. When I read this, I thought it was the ATTRACT study, but then it's actually the ATTR ACT study, because I heard the author have to get access to treatment. You had to have proven TTR amyloid, and people were given either 20 or 80 milligrams of tafamidis. And for the first year, there wasn't much change. But after 18 months, the group on the placebo, the sugar pills, started to experience more events. And those events were trips to hospital, but also the death rate started to increase. Or you could say that tafamidis was preventing people from dying. And if we go out to 3 years, tafamidis reduced the death rate by about 10%. So that's a huge change over 3 years. And if you look at this, these are ways we look at, you say to yourself, okay, these are different groups. Which is better, the sugar pill or the active drug? And you can see here, people who are class 1 and class 2, so they're people who are less symptomatic, they're a little bit breathless, they got a huge benefit of being treated. But if you start to become more significant breathless, and class 3 means you can walk about half a K before you get breathless, the tafamidis didn't make too much difference. So it's really important if we're going to be starting treatment to start it early. It didn't make too much difference. The wild type people did better. There were less of the genetically determined ones. So the message from this is tafamidis works. It's best to start it early in that disease pathway I showed you, so when people are minimally or mildly symptomatic. Now, the problem with tafamidis, as one or two of you in the room may be able to attest to, it's prohibitively expensive. It costs $400 for one 20 milligram pill. In this trial, they were getting 80 milligrams. So that's $1,600 a day if you're going to be taking. And that's what it costs in the US as well. So that's the major challenge here. And as I mentioned, cost is driven by rareness of a disease. If you have a rare disease, the drug company can charge the earth for it. Once a disease is recognised as not being rare, the cost has to come down. And as I showed you from that slide from the Amyloid Centre, this is not a rare disease. There are a lot of people who have TTR amyloid who will benefit from the treatment, but the problem is at the moment it's still called a rare disease. But this is what's changing at the moment in terms of international perceptions, and hopefully we'll see the price of tafamidis come down at some point. And this is the busiest slide, and I guess one of the more important ones. What else is out there? So, like we talked about, the liver makes your TTR amyloid, and to make anything, you need DNA. As we talked about, some people carry an abnormality in the DNA, so if you can stop the DNA working or interrupt the way it works, and that's what the RNA silencers do, you can stop yourself producing TTR amyloid, and then it won't go on and cause disease. So these are the RNA silencers, and these are patisiran and inotersen. They've been shown to work with peripheral neuropathy. When the trials have looked at people with heart disease who were in the study for peripheral neuropathy, it looks like the drugs worked, but they've not been proven as yet in patients with TTR cardiomyopathy, but there's trials going on that are enrolling at the moment, or they've completed enrollment, so we'll know about that in the next 2 to 3 years. And if you think tafamidis is expensive, it's cheap compared to these. These are about $500,000 US a year. So cost is a major issue. Anything that has RNA silencer in it, you know it's going to cost the earth. This one's an infusion that you have to have every 3 weeks. This one's an injection that's once a month. There's another one called vutrisiran, which has come out that we were trying to get in a trial, but unfortunately post-COVID sort of enrollment suddenly expanded and costs were a bit too great at our end, I think. There's your tafamidis here. Another agent, we've actually done a trial with this one, is acoramidis, is another TTR stabilizer. So one or two of you may be in the trial looking at that, which is the attribute trial, which hopefully will be released in about a year or two. My observation is it does seem to work. Diflunisal is an anti-inflammatory. So it used to be around 40, 50 years ago called Dolabid, but the earlier generation anti-inflammatories were withdrawn from the market because they tend to cause more issues with kidney upset and bleeding in the gut. However, diflunisal is quite potent at stabilising TTR amyloid. It's actually got approval in Europe for peripheral neuropathy, and it's been used in a trial, but from a cardiac perspective, it's not being put into a trial to see if it works as yet. But it's got off-label approval in Europe to be used for cardiomyopathy, but not in the US. I was reading something on the way here that's suggesting that this is something that gene carriers could actually take because the side effect profile is low enough that if it stops disease progression, it may be a way to go. But these are things that all need exploration and proof, because we like to be able to say we know this works rather than we think this works. But diflunisal is available here through a pharmacist, and you can get hold of it. You just need a friendly pharmacist who won't fleece you too much for the processing costs, because it's not on the New Zealand formulary. As a cardiologist, we tend to worry about drugs that cause fluid retention, because they can make heart failure worse. And often people are on blood thinners as well, so you've got an increased risk of bleeding. Other things that are available, there's doxycycline and TUDCA. So doxycycline for AL cardiomyopathy actually protects against things going wrong when you're getting your chemotherapy. It has a protective effect on the AL light chains on the heart muscle. So it's now given routinely with chemo for AL amyloidosis. But there's a trial going on at the moment looking to see whether doxycycline and TUDCA help clearance of the TTR amyloid from the heart muscle tissue. But as yet, it's not been proven, and the side effect profile is reasonably high. And then there's another thing here, we've got the green tea, because they didn't have green tea in this one. So that's what this is, EGCG, which I can never remember exactly what it means. But it's the active component of green tea extract. The therapeutic dose of this is about 400 to 600 milligrams a day. It's something essentially you purchase online, it's not prescribable, but you need 400 to 600 milligrams of the EGCG. So it's a concentrate of green tea that is the best thing. It can affect the liver function. Now, green tea extract's not been used in a trial, it's not a drug. No one's going to fork out the money to actually see if this works, but it's been used in an MRI study, and the patients treated with the green tea extract, the heart muscle got thick less quickly than people who weren't on it, basically. And nearly at the end. So treatment options are general. We encourage everyone to exercise. If you've got any cardiac condition, exercise is important. Building up muscle strength, independent of everything else, improves your sense of well-being. We keep an eye on fluid intake. As I said, the heart it can't get over full. It just can't get rid of the fluid. So we try and encourage people to limit their fluid to around 1.5 litres. Obviously, if you're tiny, that's probably going to be a bit too much. For your average person, that's okay. And limiting salt intake is much more important. Salt makes you thirsty. If you're taking lots of salt, you drink more. And if you drink more, you swell more. So we try and keep people under 3 grams a day. And general cardiac strategies, they're similar to what Nezar was talking about. We give medications. We're trying to keep people as volume, at euvolemic, so at as steady volume as possible. We use the water pills, diuretics, and the best one I believe is bumetanide. Frusemide is the one that's more commonly used, but the problem with frusemide is anyone who takes it will tell you that if you start to swell up, it doesn't work so well. And the problem is frusemide levels can vary between 5% and 80% in your body from a tablet. So as you get more swollen, the amount of frusemide in your blood drops off. You take more, you get more swollen, you go to hospital, and a junior doctor say, "Are you taking your frusemide?" You say, "Yes." And they say, "Are you sure? Why are you putting on weight?" So, bioavailability, you fool, didn't you, at a medical school? So bumetanide has about a much more stable bioavailability. So if you do start to get a bit more congested, you take an extra one, it works better. So it's a better drug to use. Like I say, that conversation about frusemide I have encountered more than once. We use aldosterone receptor antagonist, that's spironolactone. That helps keep potassium in the body. We use it in other people with heart failure with preserved EF. But the important thing is to avoid drugs that may make you worse. So that's steroids for your gout, anti-inflammatories, apart from diflunisal, but we know that may cause problem. We want to avoid agents that drop the blood pressure. So treatment for high blood pressure can cause issues, and these are things like ACE inhibitors or amlodipine. They relax the blood vessels, and the problem is you can't increase your heart output very much if your blood pressure drops. And that means it causes problems with postural hypotension or dizziness. And some medications actually bind to the amyloid fibrils. So a drug like diltiazem or verapamil, they can actually, if you take a pill, it'll go and bind to all your heart protein, heart muscle, and it can cause problems with heart block, or actually can cause shock by impairing the way the heart works. Drugs like beta blockers as well. Your heart, when you exercise, should speed up, and that's how you increase cardiac output. So your cardiac output is simply your stroke volume, which is the amount you squirt out with each beat, multiplied by your heart rate. Now your stroke volume, as I've said, there's only so much blood you can get in the heart amyloid. So if you limit the speed of your heart by a medication, your problem is you can only get so much blood out. So if you take drugs like beta blockers, often people feel worse because you can't increase your cardiac output to as much you need for your body to keep happy. So that's why we try and avoid those drugs if possible. There. And what else can pop up over the years? You can get irregular rhythms like atrial fibrillation. That happens in about 50% of people with TTR amyloid. It's really important if you have AF to be on blood thinners to protect against stroke, because the risk of that happening is high. And we have to decide whether to keep the heart under control with rhythm pills, but for the reasons I mentioned, they can cause issues, or whether we try and keep the heart regular with a pill called amiodarone, and that is the best drug to use. People can also faint, and that can be because the heart goes too slowly as the amyloid builds up in the heart tissues. It can be because the heart's going too fast, or because the efficiency of the heart's been affected because the blood pressure's low, and that can be heart function, or because of the medications that we give, basically. And if you do have faints, then you often put pacemakers in. And what may arise over the years, we're trying to get clinical trials up and running. As I said, unfortunately the patisiran was closed, but we're in touch with drug companies trying to get other trials. And at the moment we're trying to get an Auckland Regional Cardiac Amyloid Clinic established, because I don't know if you guys know how DHBs work, but essentially they're not very keen on doctors from one place going to another, or patients from one place going to a different DHB. But hopefully with the way things are moving, with there being no longer being DHBs, we'll be able to work at a more regional level, and that means more collaboration at doctor level. And also for patients, it means if Dr. A, DHB A, knows about condition Z, you can go and see them, or you should be able to go and see them without people saying, well, hang on a sec, they're not in your DHB, we're not paying for you to go and see them. So hopefully, I may be dreaming, but hopefully those sort of things will happen. But we're actually trying to get a centrally located regional amyloid clinic where we can try and see people from initially around the Auckland region and Northland, but hopefully around the country. And by doing that, sort of we can link in with the patient support group as well and enhance people's care, and also get access to more clinical trials as well. And you'll have heard Simon talk last night, but he and I have been in touch about tacking into the Australian Amyloid Network as well. I'm not sure they're going to call it the Australia and New Zealand Amyloid Network. It may be the 7th or 8th state or whatever it is from Australia in that viewpoint, but that'll be cool to join in as well.
I take it from what you say that while the causes are completely different sort of the effect on the heart of TTR and AL is essentially the same.
Yeah, it's pretty similar. So the amyloid is what you see under the microscope. So you've got the same thing that you've got there by different processes. The AL, as Nezar said, tends to it's produced by bone marrow, so it's really building up quickly. TTR is slower, and the light chains you produce are toxic to the heart muscle as well. So that's why it presents a bit more aggressively. So the heart muscle tends to be less thickened for the degree of symptoms you have, but also the heart function tends to be a bit lower as well. Therefore, when people with AL amyloid get treated, they often, you can get a very good response in terms of symptoms, and much better than you ever see with TTR amyloid, because TTR is taking years to build up. AL will build up over a year or two. So it's a much more aggressive process.
So I think that a lot of people, from what I understand, who are diagnosed certainly with AL cardiac, the first go round is you've got athlete's heart. What is athlete's heart?
Well, athlete's heart is, so if you're an athlete, the way you adjust to, all these guys who are supreme sports people, their resting heart rates are in the 30s or 40s. And so they have the ability to increase cardiac output hugely. And as I said, your cardiac output is your stroke volume multiplied by your heart rate. Now, an athlete needs the same cardiac output at rest as your average punter with a heart rate of 60. So with a heart rate of 40, the only way it does it is by having a bigger stroke volume, and that just means the heart's bigger. And that's what an athlete's heart is. So they have a dilated heart, so the chambers are bigger. The heart muscle is often a bit thicker as well, depending upon the type of exercise you do. So if you do like cycling, rowing, they often have slightly thickened hearts as well, and that's an athlete's heart. But when you do LV strain on athletes, it's usually supranormal. So there's subtleties on echo that will tell you, this looks like an athlete's heart. So there's all guidelines that give us an idea of what we should be looking for. And when you put someone on a treadmill, of course, they respond normally. But a heart, for someone with amyloid, they'll get pumped, and the pressures inside the heart go up.
We have problems with sore nerve endings, particularly in feet. Can you explain why that's often?
I'm going to do a whole talk about
We're
that.
going to neurologist to talk about
a
it.
minute.
Can you have two types of amyloid? Because there seems to be a big crossover of symptoms.
That's where the biopsy is important. So if you remember that pathway shown, so you can have TTR amyloid, and that is by far the commonest thing people have. But yeah, you can have AL and TTR amyloid. That's why you have to have a biopsy. So if your light chains are normal, you won't have AL amyloid. If your light chains are abnormal, you might have AL, you might have TTR, and that's why a biopsy is important. And you never say never in medicine. Some unfortunate people are going to have both, but that's where the biopsy is so important. I've not encountered anyone who's clearly had both, but once again, you don't see that many people with it, but that's where the biopsy is so important. It's more important so you don't give chemotherapy to someone with TTR amyloid, and that's, if you go back 20 years, there's actually a report in the Medical and Young Journal about that, about how important it is to actually type the amyloid, because it used to be, you saw light chains, you saw myeloma, you saw thick heart, therefore this is amyloid, therefore you need chemotherapy. And that can accidentally cause harm, so that's why the biopsy is so important.
But you can get the carpal tunnel, the breathlessness and neuropathy, the pain in the joints and everything, back pain and everything with ATT, as well as AL?
Oh, AL can affect anything. Yeah, so AL builds up absolutely anywhere. Interestingly, things often improve with chemotherapy. People often improve substantially in terms of all their symptoms. That we don't see AL amyloid very often from a cardiac perspective. It's about 1 in 100,000 people get it. But the people I've seen who responded to the treatment, a lot of their symptoms disappear. It's absolutely amazing. Their heart function improves. They feel a lot better. The neuropathic symptoms have improved as well. I saw one patient who couldn't put her hands together at our claws, and they suddenly, all the amyloid disappeared over time. So that the amyloid does disappear from your body if you have AL. And they've done studies in London looking on MRI, and you can see that cardiac amyloid improves over time as well.
And if your condition gets worse, even though you've had chemo, like neuropathy, that's a neuropathy lady.
Oh, yeah. I think from my understanding from the hematological side of things, I mean, when I was a medical student, and I guess if you go, I don't know if you've got AL, if you go on the internet, I'd advise you against going on the internet and look up anything, because it's full of doom and gloom. And the average survival with AL amyloid, when I was first learning about it, was 3 months. So essentially, if you told someone they've got AL cardiac amyloidosis, it was a death sentence. The treatments that the haematologists have come out with over the years have made a huge difference there. And the average survival has now been pushed out to, I think 50 or 60% of people will survive at least 5 years. And you get your cybernex chemo, your early stuff, and then there's a whole new generation of drugs that have come out. So they've got about 5 levels of treatment for bone marrow disorders. And in the US, the FDA just approved a drug called daratumumab, purely for AL amyloidosis. Now, when I was over there, they were just starting to use it. Once again, new drug, rare condition, prohibitively expensive, $500,000 US a year. But the guy, the haematologist I was talking to about it, said the response you get is absolutely stunning. It just completely switches off light chain production. So that's something that hopefully over time we'll start to see becoming available. I don't know if it's available here, but there are options here. But for the AL, there's multiple levels of treatment that can be considered. People live 5, 10, 15 years now with AL amyloid, having ups and downs, but it's so much better than the 3 months 25 years ago.
Thank you, Tim. We've got a whole of questions there because we've just gone over a little bit. But thank you very, very much. And maybe if anyone's got a question, they can ask Tim after this. I'm not sure how long you're staying around for.
I'm here for lunch, so.
I'll quickly I'll give you your little question now.
Thank you.
Thank you very much. All right, we are going to move on. And as we've all heard, amyloidosis is a multi-system disorder. And we've heard a lot about the heart, but the other really common organ system that's affected is nerves. And I have been trying to get neurologists, who are nerve doctors, interested in amyloidosis in this country, totally without success. And I think Jamie has too. But we are really fortunate to have Antonia Carroll, who's agreed to come over from Sydney. And she's a neurologist, as well as a neurophysiologist, clinical researcher, specific interest in amyloid neuropathies. And welcome. Thank you for coming to talk to us about it.
Thank you very much. Can you guys all hear me okay?
Yep.
Can you hear me without the microphone?
No.
Okay. As you've heard, I'm a neurologist. I also do nerve conduction studies, so I'm a neurophysiologist. And I'm an active researcher looking at the early causes and early diagnostic strategies in amyloid neuropathies is what I'm doing my PhD on. So I work at St Vincent's Hospital in Sydney, but I'm also at the Westmead Amyloidosis Centre. So I'm going to first just start by setting the scene about what exactly is going on here in your nerves. So when you think about neurology, most people think about the brain and the spinal cords. That's what we would call the central nervous system. But actually what gets predominantly affected in amyloid of all different types is this peripheral nervous system. So that's a nervous system that controls the cranial nerves, so how your eyes move, your facial sensation, your swallowing, but then also your peripheral nerves, so going out to your arms and to your legs. So when we think about the peripheral nervous system, you get a signal, say, from your brain going down your spinal cord to say that you want to move your hand. And then with this, I think that's the pointer, you get a signal that comes out, down through the peripheral nerve to the muscle here, and that's how you wave. Similarly, at the same time, if you get touched or if you touch a hot plate, you get a stimulation into the skin, which goes up through this peripheral nerve and into the spinal cord. And then that goes up to the brain, and then that's how we process our sensory information. But we also have the autonomic nervous system. So that's the nervous system that we've heard about a little bit that runs through a slightly different process. It still goes down through the spinal cord, but it's got a separate sympathetic chain, so they're not in the same kind of nerve channel pathways. And this controls all of the involuntary things that you don't really think about. So things like crying, saliva, how your gut moves, your erectile function, how your bladder works, all of those things can be affected in autonomic processes. And then there are also the small nerve fibres. So these are the little loose nerve fibres, like you can see here, that are in the skin, and that similarly travel with the sensory nerves up into the spinal cord. And they have a slightly different process. So when we actually look at a nerve itself, there it is. So this is a nerve. If you actually cut out a nerve specimen, this is kind of what it looks like. And you can see that there are lots of different fibres. So these round things are fibres, and that's what each of these little ones are here. And that each of these fibres carry different types of information. So you've got these larger ones with an insulating coating, which is the black, and they carry information about touch and pressure, but also vibration. And so often, you know, if you're feeling dizzy and you close your eyes and you're not certain where your feet are in space, that's going to make you feel unsteady. So that's carried by those larger fibres there. And then these smaller fibres, and in particular these C fibres, carry information about pain and temperature, okay? And they're quite slow fibres. So what often happens, and why people often get a little bit confused about what's going on with neuropathy, is that often because your beta fibres are affected, you might not be able to feel. But then because your C fibre is affected, you often feel lots of neuropathic pain. So you get this funny combination of numbness, but also not being able to feel and feeling sort of hypersensitive at the same time. And what we can see is that this is sort of a schematic of how fast nerve fibres are. So those bigger fibres, those A beta fibres, are a little bit slower than an aeroplane, but faster than a cheetah. Whereas those C fibres are slower than someone walking, which is why if you put your fingertip on a hot plate, for example, it takes a while for you to recognise that it's hot and need to pull away. So neuropathy means damage to the nerves of any cause. Okay, there's lots and lots of different causes of neuropathy, vitamin deficiencies, B12. For example, lots of different things can do it. And there are two types of neuropathy. One can be that the electrical wire, this is the yellow bit of this nerve, can be affected. And that's what the yellow bit, that electrical wire, is called an axon. So sometimes if your neurologist say you have an axonal neuropathy, that's what it means. It means damage to that electrical wire. But then there's also insulating coating that we saw that was the black of those nerves that are on some of those fibres, and that is called the myelin, or the myelin sheath. And that really just allows signals to be transmitted really quickly along the nerve, and sometimes you can get nerve neuropathies that affect that myelin sheath, and that's what we call a demyelinating neuropathy. So, in amyloid, so we've heard on multiple different talks that you get deposits of these protein in multiple different organs. So in nerves specifically, you can get deposition in the peripheral and the autonomic nerves, and that can be in all layers of the nerve. You can also get it into the blood vessels supplying the nerve, therefore stopping blood flow to the nerve and causing a bit of ischemia or lack of blood flow, causing trouble with the nerves. You can also get deposition in ligaments and tendons, as we've been hearing with carpal tunnel syndrome and spinal canal stenosis, and then of course in other organs. And certainly some of those amyloid proteins can have a direct toxic effect on the nerves itself. Now, with the myelin that we were hearing about before, is that you usually get conduction down the nerves such as this, giving a fast conduction of information from one point to another. But often with these amyloid processes, it interferes with the way that the nerves are being able to transmit this information, and that's why you have impaired function and symptoms. Okay. So, when we actually have a look at that nerve, so this is a different specimen of nerve, stained with that Congo red that you've been hearing about at the moment. And you can see that this is a blood vessel inside the nerve, and it looks a bit thickened and a bit red. And similarly, here you've got sort of a big red, sort of blobby deposit. When you shine with polarized light, this shines up green, showing that that's that amyloidosis within that nerve. So often first goes into the blood vessels and then kind of spills out into the nerve itself. And so this is a normal nerve here, showing lots and lots of these different sizes of fibres that we were showing on that close-up section before. But what happens as amyloid progresses is you can get loss of those nerve fibres, and that's what correlates with the symptoms that people get. Oi! Sorry, that just jumped about 20. I don't think that was me. Sorry, I'm just going. All right, so in terms of pattern of nerve dysfunction in animals, there are lots of different patterns, 5 in particular. So the first is actually this mononeuropathy, so that means one nerve is affected. And the most common version of that is what we see with carpal tunnel syndrome. So what's important to know with carpal tunnel syndrome is that it's not directly a neuropathy per se, in that you're not actually getting deposition of the amyloid in the nerve itself. Instead, what happens, so the yellow here is the median nerve, so the median nerve is the one that comes through and causes the problem with carpal tunnel syndrome. And here you're getting deposition in the purple, which is what we call the transverse carpal ligament or the flexor retinaculum, and that puts downward compression onto the median nerve, causing symptoms. It occurs in over 50% of cases of amyloid. Often it's a presenting symptom, often 5 to 10 years prior to you getting any other symptoms of amyloid. And typically what people get is numbness in these fingers, so the blue fingers here, that wakes you up from sleep. Often you need to shake your hand, hang your hand over the side of the bed, worsened by doing things which causes either flexion of your wrist like this, so riding push bikes, jackhammering, or even at night time, often it gets worse because people sleep like this and you don't recognise that you do it. And that flexion causes trouble with the information getting through. So there are lots of things that we can do for this type of syndrome. So first is that you can, at night time, if you mainly get lots of your symptoms, you can use a splint like this to keep your wrist nice and flat at night. You can do physiotherapy exercises to try and get that nerve and the tendons moving a little bit more smoothly. You can have ergonomic alterations, so particularly if you're doing a lot of work where you're typing and things of the sort where your wrists are flexed, so you can change that position to make it a bit better. But often we need to go a little bit further because the deposition of the amyloid into the nerve itself, into the flexor, doesn't stop, okay, despite you doing those things. So often we need to do the local anaesthetic and steroid injections, which is what you're seeing here. They can put a little local anaesthetic and steroid to reduce any inflammation, or surgical management, which is quite commonly required. So you can have open surgery and you can have actually endoscopic surgery, so with a little camera, and they differ a little bit in terms of how quickly you can get back to using your hands. And this is a really good opportunity that we're trying to encourage our hand surgeon colleagues to send off samples when people are having it for this for histopathology in order to improve early diagnosis. So the second pattern of nerve dysfunction is what we call radiculopathy or plexopathy, and that's when the nerves at the level of the spinal canal are affected. And the most typical version of this is spinal canal stenosis. Okay, so again, this is not direct infiltration of the nerve itself, but it's direct infiltration of the spinal ligament at the back, the ligamentum flavum. And then that causes, again, like the carpal tunnel, compression on the nerves itself. Now, if you're, as you get older, often you've got a bit of osteoarthritis in the back, often you've got a little bit of disc bulges, and all of those combine to put extra pressure on those nerves. So typically, we make a diagnosis based on the typical history, and that is usually back pain that's lower lumbar, radiating pain through the buttock down the side of the leg. With that, because the nerves up here are the ones that supply the nerves down here, you can get numbness on the sole of your feet, numbness up the side of your legs. And so it's important to be able to distinguish between that sort of numbness and actually true nerve involvement. And when we have a look at MRI scans, this is what we typically see. So you can see this is the bony process and the spinous process that you can feel out the back. And you can see that there is this thickened, this black bit V here is the thickened ligamentum flavum. We can actually measure that on MRI scan. So again, things that we can do, conservative management, such as neuropathic pain agents, and I'll talk more about those in a little bit. We can do CT or ultrasound guided steroid injections, which can often help to reduce inflammation and reduce pressure on those nerves. But again, often surgical management is required because the amyloid is still being deposited into that despite you reducing some inflammation. And again, histopathology is a great time for us to try and encourage our orthopaedic and our neurosurgical colleagues to try and send off specimens for that in order to improve early diagnosis. The third pattern is the small fibre neuropathy. So these are when the little C fibres, the ones that we were showing in the skin before, the loose fibres become affected. And so typically people get what we call a length-dependent neuropathy, or otherwise known as a glove and stocking neuropathy. And in this, so that's the typical pattern, but sometimes it can be a bit asymmetrical and patchy, which can sometimes be a little bit tricky. So you can get funny patterns or little patches around the body. And here you get insensitivity to temperature and pain, okay? You also get neuropathic burning pain, stabbing, shooting, prickly, cramping pains. Often you get something that we call allodynia or hypersensitivity, where things that shouldn't be painful become painful, like the touch of a sheet on your feet at night or the weight of a doona. Sometimes socks, sometimes shoes can be quite uncomfortable. Sometimes, even though the C fibres don't really have a role in light touch, sometimes you do feel numbness and tingling. And often this small fibre neuropathy goes along with the autonomic neuropathy. What's important to know about small fibre neuropathy is that when your neurologist or your GP examines you, your vibration sense, your proprioception, and sometimes even your light touch sensation can be completely normal. Your strength can be completely normal, your reflexes can be completely normal, and nerve conduction studies can be completely normal. And so often people feel a bit dismissed because they feel like, you know, nothing is wrong. You know, and that can certainly lead to poor quality of life and sort of debility from that perspective, but it is a true thing, and there are ways that we can diagnose this, but it's often having the suspicion that this is what's going on is really important. The fourth pattern is that of autonomic neuropathy. So as we talked about, these are all the involuntary symptoms and voluntary actions of our body that you don't really think about. So really what becomes involved depends on which nerves are damaged and the severity of that damage, but the most common ones are dizziness on standing, nausea and vomiting after eating, and erectile dysfunction. But you can get a myriad of different things. So alternating constipation, diarrhea, feeling full really early with nausea and feeling like you're going to regurgitate or bloat after eating, poor bladder emptying and then frequent urinary tract infections because you've got urine sitting in your bladder, as well as incontinence can happen. Low blood pressure with dizziness when you stand up, fainting and having trouble exercising can be due to your autonomic nerve dysfunction or can be due to your cardiac dysfunction, as you've heard earlier. Erectile dysfunction, vaginal dryness, you can have dry eyes and dry mouth, difficulty focusing near and far, say if you're driving and changing near and far, or difficulty adjusting to different lighting conditions. So if you go from dark space into a bright space, often it can take a little bit longer to adjust. Or you can have funny abnormal sweating patterns. So you can have no sweating, too much sweating, or even funny patches of sweating. Not working again, sorry. And I guess the thing to say is that this is really, really common. So about 70% of people have blood pressure disturbances, 71% gastrointestinal, 70% of men have erectile dysfunction, lots of sweating changes in about 50%, genitourinary problems in about 40%, so that's more the bladder dysfunction, and then other sort of eye changes and things of the sort. But they're really common symptoms in all different types of amyloidosis. And the last pattern is the pattern that we kind of tend to think of most commonly that we see with amyloidosis, which is the length-dependent club and stocking large fibre neuropathy. So that's when those bigger fibres with the myelin on them become affected. And this is a length-dependent process. So what it usually means is that it starts at the toes and comes back up and sort of spreads towards the knees. And around this time that the knees are involved, then it tends to involve the fingers, and that's just because they're about the same length. Okay, so it's a length-dependent process. And sometimes it can even involve the abdominal wall because these nerves come all the way around, and so these are a length-dependent nerve as well. So usually when you have these sort of symptoms, you get touch, vibration and proprioception loss. And when I say proprioception, that's that sensation of where your feet are in space. You get weaknesses, loss of reflexes, and pain can often go along with this. And so while this is the most common type of large fibre neuropathy, there are a couple of funny groups that often get misdiagnosed, and often that's where people get a little bit of a delay in diagnosis. So sometimes people can get it starting in the upper limb without any involvement in the lower limb. That's not carpal tunnel. Often you can get what we call ataxia, which is unsteadiness of your feet or imbalance. Sometimes that can be because of the sensory fibres, but also it can be from involvement of the brain in one particular type of TTR genetic version. And you can also get a motor predominance, so without the sensory involvement. But all of those things often take a little bit longer to diagnose because they're a bit of a funny pattern and not the norm. So in terms of diagnosis, and this is slightly different order to what I had before, So this length-dependent neuropathy, the entrapment neuropathies and the radiculopathies are basically based on clinical examination, some questionnaires. We can do nerve conduction studies and EMG, and sometimes we can do nerve biopsies for that. And that's how we diagnose those groups. With these small fibre and autonomic neuropathies, often it's the clinical suspicion and the history that's most important. Postural blood pressures are really important, so often we'll do it lying down, standing up immediately, standing up at 1 minute, standing up at 3 minutes to get a good sense of what's going on. But we can also do nuclear medicine scans to see how quickly your gut's transiting, it can often be quite helpful. And then there are fancier things that can only be done at particular places where we can do quantitative sensory testing, heart rate and sweat assessments, and skin and organ biopsies, but often that's not really necessary in order to get to the diagnosis. Often you can make a diagnosis based on the clinical and your blood pressure alone. So when we think about the spectrum of amyloidosis, you've been hearing about lots of different types of amyloidosis, but the major types where you get nerve involvement are in ATTRV, or the mutations of ATTR, and in AL amyloid. And then there's a little bit less in these other different types of amyloid, including wild type. And I'll remind you, I think we just saw this sort of similar slide beforehand, is that even with ATTRV, so the mutant type, there are ones with predominant neurologic features that don't tend to have much cardiac, and there are some with predominant cardiac features without much neuropathy, and then there are a mixed bag. So it doesn't mean that everyone with the same mutant variant or a different mutant variant will have the same pattern as you. But when we actually look at these, so certainly for carpal tunnel syndrome, we see a lot of carpal tunnel syndrome in the ATTR with mutation, the hereditary form, and in wild type TTR, a little bit less in AL, but also in some of the acquired forms, so the rare dialysis associated. We see lumbar stenosis mainly in ATTRV and the wild type TTR with a less in AL. We see autonomic dysfunction mainly in the hereditary form and a little bit in the AA, or the one associated with chronic inflammation, as well as in AL. And the large fibre neuropathy tends to occur in the ATTRV more so than AL. We can see it a little bit in wild type TTR, and recently showed a couple of people with actually true nerve involvement with TTR, but it is pretty rare. And then a couple of these more rare types as well. And as we can see, there's also lots of other involvement. So particularly with ATTRV, you can get ocular manifestations, so you can get cataracts and deposition in the vitreous deposits, as well as vascular changes. Sometimes people get laryngeal changes, both in wild type and ATTRV, so that people notice a change in their voice that becomes what we call dysphonic, or changes a little bit in the quality of their voice. You can get trigger fingers as well, and that's actually from deposition in the joints, as well as the tendon ruptures. And then sometimes you can even get involvement of the muscles itself. And sometimes we can pick that up on DPD scans, which is an interesting new thing that we're looking at. So in terms of management, we've heard a lot about treating the underlying disease, so I'm not going to spend a lot of time on that. What I really wanted to talk to you about is more the supportive management of nerve problems, because certainly it's something that is pretty poorly done in many, many centres, and I think it's something that can make a huge difference to your quality of life. So, with this, it really requires a multidisciplinary approach, because often, one doctor will give you one thing for blood pressure or for your heart, and then your blood pressure is also down. And so it's a matter of really balancing out that and making sure that everyone's on the same page, but also involves our allied health colleagues, so podiatrists, physiotherapists, orthotists, occupational therapists. And really what we want to do is aim for symptom control, maintaining function and improving quality of life. So, as I'm sure you all are very acutely aware of, is that in amyloid there's a considerable impact on your quality of life. And when you talk to patients, these are the major symptoms that really tend to affect people's quality of life. And it's not just physical, there can be mental, emotional, and of course financial. There's also concerns for other family members, and that's often exacerbated in heritable diseases, because there's this sense of guilt of, have I passed this on to somebody else? Have I contributed in some way? And I think this is something that is really often underestimated by doctors, and I think it's really important that we're doing more work in this space. And I think literature is really limited at the moment, but it's gaining a lot of momentum, and I think this is a sort of a space to watch. But I think, in that context, anxiety, depression, and a feeling of isolation is quite common, okay? And so you're not alone in those feelings if you are feeling that way. in regards to nerve pain and sensory symptoms. So often, what people want to know about is the nerve pain agents. So usually first line, and I'm going to talk about this from an Australian perspective. I'm not certain exactly what you can get here, so you can talk to me afterwards if you can't get some of these medications. So usually I'd use pregabalin or gabapentin as a first line. Usually with these medications, we start at low doses and you slowly build it up. And that's because all of these medications, they're working on reducing the abnormal firing of your nerves. And because they work on reducing the abnormal firing of your nerves, they also work a little bit centrally. So often people find that if you go up too quickly, you get a lot of cognitive complaints. And you kind of feel a little bit, confused, a bit spaced out, a bit vague, and people don't like that. So often start low, go slow, and build it up. Sometimes these can contribute a little bit to swelling. We need to watch out if you've got a lot of renal impairment. And I think the thing is, if you're on high doses and you come off too quickly, we're recognising more and more that there is a bit of a withdrawal effect that can happen with this. But that shouldn't be something that you worry about in terms of if you're needing it for treatment, but it's only if you come off it too quickly. Second line, and I feel like this is, what I will say actually about first line is if you've got cramps as well, gabapentin would be the one that I go to. And I think, often with a lot of these medications is, can we do two birds with one stone? From a second line, usually I would use these tricyclic antidepressants, so amitriptyline, nortriptyline, again starting low and then building up. I tend to use amitriptyline particularly if people are having trouble sleeping because of nerve pain at night, because it makes you sleepy. You take it at night and it makes you sleepy. And it can have, so it's an old school antidepressant. And so in that context, it does have positive effects on mood if mood is a little bit low. But one thing we need to recognise with these drugs is that they're a little bit of a dirty drug. Okay, so they've got lots of effects on different neurotransmitters in our body. And in that context, you can get a bit of dry eyes, a bit of dry mouth, some gastrointestinal impairment, and usually that goes away with time. So once your body gets used to it, if you start low and build it up, that tends to go away. But we just need to recognise that can happen. Again, we need to watch out if you've got a lot of cardiac involvement, tachycardia can happen, and again, cognitive complaints as well. A newer medication is a medication called duloxetine, also known as Cymbalta. So that's found very, very positive effects in diabetic neuropathy. And what you'll know about diabetic neuropathy is it's probably the closest thing that we've got to amyloid-associated neuropathy. It's very, very similar. Usually small fibre neuropathy progressing to a large fibre neuropathy. And so in that way, duloxetine can be quite helpful, 30 milligrams daily and increasing up to 60, and it's also an antidepressant, so it can also be helpful if your mood is down a little bit as well. There are lots and lots of other options which I won't go into as much, but if there is a lot of topical pain sensitivity, sometimes we can actually use, particularly in the hands, for example, or the feet, you can use local anaesthetic ointments. A derivative of chili can actually be quite helpful in sort of desensitising the hands. And then there are also compounded topical groups, which are a combination of ketamine, gabapentin, amitriptyline, all sorts of different drugs that can actually be useful as a topical, especially if there's a patch. It's not so good if it's all over your body, but if there's a patch that's particularly uncomfortable, that can be helpful. I know somebody else is going to be talking about cannabis, so I won't talk too much about that. And what I will say is that opioids generally aren't that helpful for nerve pain because they don't dampen down the hyperexcitable firing. But they are good for bony pain and other musculoskeletal pains from that perspective. So it wouldn't be a first line that I would think about in nerve involvement. The other thing that can be helpful in neuropathic pain are supplements. So when I say supplements, usually the most important thing is making certain that your nerves are in the best position. So we want to try and limit diabetes. We want to make certain that you have enough other vitamins that are important for nerve health, like B12. So certainly making certain that your B12 is sufficient, I think, is an important thing to do in all people with nerve involvement. But massage, physiotherapy, acupuncture, meditation can all be helpful. And in some people, transcutaneous electrical nerve stimulation can be helpful. So often women who are pregnant can use this sort of TENS, and often it's a patch that gets put on your skin, as shown here, to give you a little electrical stimuli into the nerves, and sometimes that can be helpful in some people. They're all things that you can do. All these complementary therapies is as long as it's not causing you financial distress by trying to go down these pathways, you can do. Some people get benefits, some people don't. But it's a relative evidence-free zone. And the other thing to say is regular podiatry and nail care is really, really important. So if you can't feel your feet, then if you get a cut on your feet, then you're prone to infections and things of the sort. And so actually getting a podiatrist to have a look at your feet regularly at a high-risk foot clinic, for example, and take care of your nails is really, really important to prevent further complications. In terms of weakness, physiotherapists and occupational therapists are really important. So they can give you compensatory techniques so that you can participate in your regular day-to-day life. They can help you with safety by giving you sort of advice about what orthotics you may need. They can provide assistive devices, say for your upper hands, if you're having trouble opening jars and things of the sort because the sensation in your hand's not there, they can provide you with extra things to help. They can help with fatigue management, and they can guide exercise and stretching. And often if you've got weakness of your feet so that you are not lifting your feet properly, orthotics can be helpful, such as these. So there are hard versions such as ankle foot orthoses, but there are also soft versions that you can buy on the web called foot ups that can just help you with your foot clearance, and that can be quite helpful. In terms of cramps, I get asked about this an awful lot. Simple things: hot baths, stretching before you go to bed, massage, making certain within the relative requirements of your heart, making certain the hydration and your electrolyte levels are manageable. Magnesium supplements can be good. Often you need to have quite high doses, and so in that context, that can worsen diarrhea. So usually we say go up to the point that you get diarrhea and then pull back. But if you've got a lot of autonomic dysfunction with a lot of diarrhea, that can be a little bit tricky. We used to use quinine, but it's not so much available anymore, and it can worsen arrhythmia. But certainly tonic water with quinine in it can be quite helpful for cramps. Gabapentin can be useful, and we tend to say if you get nocturnal cramps, having a larger dose at night time. And then, interestingly, pickle juice can actually be quite helpful. There's actually been a randomised trial of pickle juice, using pickle juice at a milligram per kilogram before you go to bed at night. And sometimes people find that's better than just water alone. We don't know exactly how it works. We think it's an electrolyte associated effect, but certainly I've got lots of patients that swear by it. Give it a try. So exercise, we've been hearing a lot about exercise. Exercise helps your balance, it helps cardiovascular function and fluid in order to get it reabsorbed. It helps your muscle mass, it helps mood, and then recently we've actually shown that it does help nerve function. So this is a skin biopsy sample with those little small fibres that we can see, and this is a person with amyloid actually who has no little small fibres in the skin. And with exercise over a year, we can see that actually this, which is called epithermal nerve fibre density, which is what these are, they do a sample of this and they count how many nerve fibres are in it, can actually increase over a year. Now, this doesn't necessarily mean that you get back all of your sensation. I'm not saying that it's the panacea to all of the other things, but it does just help your general function, and it can help to really encourage those nerves to keep on being active. We aim for 30 minutes, 5 days a week. I'm not saying start with that, but build up slowly and see if you can get to that level. And that could be walking, but if walking's too uncomfortable, hydrotherapy or swimming can be quite helpful, or even a recumbent bike, especially if your feet are quite painful, can be quite helpful as well. In terms of dizziness, so like we've talked about previously, we need to rationalise those blood pressure lowering medications. And that's not only the cardiac meds, but things like Viagra, Cialis can be contribute. Medications for prostate can also contribute. So think about what the blood pressure medications or what medications that can contribute to blood pressure are having an effect. And then I guess there are simple conservative measures. So if your heart allows adequate hydration and salt, slow rising from a lying or seated position, elevating your bed. So if you elevate your bed, it actually gets your muscles working. So your muscles work to push back up the fluid, and so that can just help to maintain that tone within your blood vessels. And pumping your muscles, so standing in lines, what we see is that if you cross your legs like this, that actually pushes the blood flow up. And you can see that, if that's what's happening here at that time naught, that's actually a representation of blood pressure going up with that manoeuvre. Similarly, pumping your muscles at the same time, or even taking a little folding chair, usually the lower is better, is what this here is showing, can actually all increase your blood pressure up a little bit further. We can also use compression garments, so stockings, and generally the higher the better, or abdominal binders can be helpful, but they can be poorly tolerated, and often if you've got a lot of neuropathic pain, sometimes it's hard to have something that compressive on your skin. The other thing is sometimes people get what we call postprandial hypotension, and that's basically after you eat, you can get low blood pressure. So in that context, we say to avoid large volume meals, avoid meals that are rich in carbohydrates, and avoid alcohol with meals. So instead have multiple small meals, low in carbohydrate, but of course we want to make certain your weight stays on. And caffeine after meals can be helpful because it actually constricts the blood vessels that go to your gut, and therefore you get more blood going everywhere else, although it can contribute to diarrhea. So in terms of postural hypotension, it really depends on what other organs are involved. So midodrine is our usual go-to, low dose, increasing up slowly. We can use fludrocortisone, however we tend to use less of this because it is a steroid, and as you've been hearing earlier, steroids can contribute to swelling and things of the sort, and so we tend to use it less. And if you get a lot of that postprandial hypertension, sometimes we use a medication called octreotide, and that's really to constrict these blood vessels and get the blood back out to your peripheries. With these medications though, we need to really be careful that when you lie down flat, that your blood pressure doesn't go too high, okay? Because sometimes what can happen is that your blood pressure is really low in its boots when you're standing up, but when you lie down, it can get too high, and that can put you at risk of stroke, whether or not that is bleeding into the brain, or whether or not it is a clotting stroke. And so things that we can do if you do have supine hypertension, you can have a head-up tilt also can help from that perspective. No nighttime doses of these medications, and actually eating prior to bed can be helpful because we use the fact that the blood goes away to these peripheral, to your gut as a bit of a benefit. But really, you know, with all these medications, one needs to really talk with all of your different players to make certain that everyone's on the same page. I'm not going to talk too much about the digestive tract because Ola's going to be talking about that, but artificial salivas can be helpful, medicating eye drops can be helpful for your eyes, constipation, fluid, exercise, fibre, positioning, so actually having your knees up can be really helpful just in terms of getting you in the right ergonomic position, and then medications for your bowels. For diarrhea, we want to make certain that one, you replace losses so that if you're having constant diarrhea that you've got enough fluid for your blood pressure. Lower fat, higher fibre diets can be useful. Sometimes if you've got really bad constipation, you can get hard stools. That means that you get overflow of liquid. And so we need to make certain that before you start treating your constipation with things that bulk you up, that you make certain that there is no overflow of liquid stools. And then we can use things like gastrostop, codeine can be very helpful, bile salts, again octreotide, and then occasionally actually ondansetron if you've got a lot of nausea, so it's an anti-nausea medication, can also be helpful. Gastroparesis, or that feeling of early fullness and bloating, frequent small volume meals, low fat, low insoluble fibre, no carbonated drinks. We can use medications that are what we call prokinetic antiemetics, so they're medications that cause your gut to move along, can be really helpful, and you take them before meals. We've got to recognise that ondansetron, which is a very potent anti-nausea medication, actually slows down your gut. So if you've got this sort of type of early fullness and nausea, that's not the sort of anti-nausea medication that you want. And then we want to make certain that you maintain your weight, because that's really important for your long-term prognosis. So make certain you see a dietitian and get advice about supplementation if you need to. Bladder and genitals, so avoid drinking in the evening and night, especially caffeinated beverages. Sometimes we can use a medication called desmopressin if it's very severe. Urinary retention, there are some medications such as anticholinergics and alpha blockers, so things that sort of are often used in the context of benign prostatic hypertrophy, large prostates, but often these drop your blood pressure, so it's important to make certain that that's not causing a flow-on effect. Occasionally, if you're getting really big bladder and you're not able to void effectively, sometimes we actually need to put in a catheter in order to make certain that you're not getting too much retention, and that can be intermittent or indwelling. So there all the time, or you can do it as you need to. So in terms of erectile dysfunction, lots of medications have sexual side effects, and often antidepressants and nerve medications can be. So sometimes the medications that you need for your neuropathic pain can sometimes have flow-on effects to libido and things of the sort. But beta blockers and diuretics can also have an effect. It's also affected by stress and mood. So often we'll try things like Viagra and Cialis, recognising that it does lower your blood pressure, so making certain your blood pressure is okay. and also that you can't have it if you need nitrates. But there are also other options like injections, pumps and surgical measures, but that requires a referral to a sexual health clinic. And vaginal lubricants can also be helpful. Last and sweating. So usually this is not so much of an issue for our patients. I think there are bigger fish to fry, but in some people they can have really, really profound sweating effects. So anhydrosis is reduced sweating, so things that can be useful are moisturiser. And I think it's really important that, you know, on really hot days, you need to really avoid exposure and make certain that you're in a cooler area because you can't actually sweat to release your heat. So that's really important, and then that exacerbates blood pressure and cardiac effects and things of the sort. With increased sweating, we can use astringents and aluminium-containing perspirants, not necessarily just in your underarms, but on your skin in general. You can do topical anticholinergic creams. We don't like to give oral if we can because of effects on dropping your blood pressure again. But Botox can be helpful under the arms, palms and face if there is a particular patch that's particularly sweaty. If it's really generalised, sometimes we can really use really low-dose anticholinergics or even amitriptyline, so we can do it 2 birds, 1 stone with the neuropathic pain medications. And there are surgical things, but usually we try and avoid that in this circumstance. But you need to recognise that, especially with, say, Botox and these surgical procedures, is that you can get something that we call compensatory hyperhidrosis. So you just move from one place to another. So I'm not going to talk so much about this because I think we've heard a lot about it so far, except to say that certainly, you know, this is a really great results that we've seen in terms of the Apollo for patisiran and the inotersen results in terms of improvement or stabilisation. What's important to say is that this MNIS7 and this MNIS7 are not the same, so they're not directly comparable. And so we're not certainly certain that patisiran is a lot better than the inotersen in that context, but certainly there are slightly less side effects with patisiran, which is why we have been using a lot of this at the time, and also we've been able to get the trials. But certainly there is improvements in terms of functional outcomes, in terms of walking, sensation, neurophysiology and autonomic dysfunction in both, as well as quality of life. And so certainly it's what we're trying to get most of our TTR patients onto if we can. Easier said than done though. And I guess the other thing to say, and this may kind of touch a little bit on a question that happened earlier, is that, you know, while I won't talk about the regimens or the goal, is that sometimes chemotherapy can cause neuropathy. And that can cause a bit of confusion as to whether something's getting worse. Is it getting worse because of the chemotherapy, or is it because the actual neuropathy and the underlying process is not being controlled? So the history of the timing of the worsening and progression is the most important thing that we can do to really get to the bottom of this. And so often you'll go to a neurologist and they'll be really pestering you for information about when it happened and why and how has it changed now once you've stopped it, you know, what's really the evolution of things. And so don't be annoyed at them for doing that. They're really trying to get to the bottom of exactly what is the contributor. Most chemotherapy causes what we call that axonal neuropathy, so affecting the electrical wire, but Velcade can cause a significant demyelinating neuropathy. And so often it's something that we do see in this circumstance, and we often have to dose reduce in that context and give it in a slightly different way. 2/3 of people improve with cessation after about a year, and 1/3 remain with some neuropathy, but you can continue to improve over the course of years. And in that term, sort of nerve prognosis is really dependent on severity and duration of the neuropathy. Nerves can regenerate, but it's slow, so they tend to grow back at a rate of about 1 millimetre a day in the best possible circumstances. So that's without ongoing effects that can cause irritation on the nerves. Often if there's profound wasting, then sometimes the nerves won't grow back in the same way. And it's important to know that nerve hyperinsensitivity can worsen when the nerves are improving, but that nerve conduction studies are often a bit insensitive to that change. And so we're actually currently looking at biomarkers in order to monitor and see if there is ongoing nerve irritation in that context, and that's sort of the research that we're doing at the moment. So amyloid predominantly affects the large, small and autonomic nerves. It results in sensory changes, pain, weakness and a range of autonomic symptoms. We want to treat that underlying disease, but there's lots that we can do to improve your symptoms, and it's often a bit of trial and error to work out the right combination with you and to make certain that we're not doing too much pushing and pulling. So know your symptoms so that you can feel empowered to discuss it with your doctor and to be able to say, oh, you know, could we try this, could we try that? But that we really need to have coordinated care amongst patients, but also the different specialties involved to make certain that you're not, you know, pushing and one person's pulling at the same time. Thank you.
Thank you, Antonia. I think maybe we'll postpone questions. But thank you very much. Yeah. So Antonia is going to be around, so please, any questions could you ask her after this session? Just simply because we're just a little bit behind and we want to get on with the next one. Oh. Anyway, what we've got now is we've got a talk from Ola Niewiadomski, who is a gastroenterologist and endoscopist who works in Melbourne. And of course, living in Melbourne, she has not been able to come here. So we've got a virtual presentation that she's going to give. And then I think she's going to be available for questions by Zoom. Is that right? Yeah. So shall we get on and we'll do that? Thank you very much.
Good morning, everybody. It's a pity I'm not able to be there with you today. I had been looking forward to the trip to Auckland, but it's good that we're still able to do this in some fashion, and hopefully I'll be available to answer your questions at the end of your presentation. So my name is Ola Niewiadomski. I'm a gastroenterologist and hospitalist in Melbourne, and I have an interest in amyloid in the gastrointestinal tract. But today I've been asked to speak on this topic to you. So as you're all probably already aware, amyloidosis is a disease that comes about from the misfolding or abnormal folding of normal proteins found in the body. And they then take on this new shape, as illustrated here in the bottom on the image. These misfolded proteins can then deposit it anywhere in the body, and that can include the gastrointestinal tract. It can also affect the liver, and it can affect the vessels or nerves supplying the gastrointestinal tract. And any of these, this process of deposition in this area can then lead to abnormal function in the GI tract. So when I refer to the gastrointestinal tract, I'm referring to anywhere from the tongue, or including the esophagus, the stomach, into the small bowel, of which on an average human is about 3 to 4 meters of, and then the large bowel, all the way through to the anus. And amyloidosis is a disease that can in fact affect any part of the GI tract. So I'd just like to spend a couple of minutes looking at the anatomy of the gut in a bit more detail. This is a cross-sectional view of the bowel. It is very similar really between the small bowel and the large bowel. The thick tube in the middle, and with the opening in the middle there is the mucosal layer where the food goes through and is absorbed, and is then propelled through to the large bowel, where in the large bowel the mucosal layer its main function is absorption of water. And so that's one component of the bowel. You have this mucosal layer surrounding that. There are deeper layers with various lymphatic tissues in there, also nerve endings and muscles, and the muscles help propel whatever's in the bowel forward. Importantly, we can also see in yellow are nerve endings. We can have it's normal to have inhibitory or excitatory nerve endings supply the bowel, and they all have a different function. So you can see if someone, for example, in someone the amyloidosis has deposited in excitatory nerve endings, that means there's less stimulus to propel the bowel. That person will suffer from constipation, poor motility issues. Whereas if someone has the reverse, affecting nerve endings really that are more inhibitory, that patient may have rapid transit of the bowel. And amyloidosis is one of those conditions that can affect any of those structures, even within the same type of amyloidosis. There do tend to be patterns to it, and I'll go into that in a little bit more detail, but ultimately the symptoms can really vary in patients even with the same types, and patients can present with a whole lot of different symptoms. So as I alluded to on the previous page, already it can be challenging to diagnose patients who have amyloidosis of the GI tract, especially if that's the initial index presentation with GI symptoms. Added on to that is that it's quite an uncommon condition for a gastroenterologist to come across in general. These images are just here really to illustrate how it can really, even within the same type of amyloidosis, looking inside the bowel, have quite a different appearance. So looking first in the top left-hand corner, we can see that it's affecting more the superficial vessels in those sort of underlying mucosal layers. And this patient may present with bleeding or iron deficiency anemia. Next to that is an image of the stomach, and with a big ulcer there, and that can present with AL amyloidosis or AA occasionally, and that can present again with subtle bleeding or more significant bleeding, but also impact emptying of the stomach because of the size of it and the inflammation associated with it. On the bottom we can see a large bowel, and here the changes are really quite subtle with just a little bit of edema and inflammation, but in fact this may be affecting the mucosal function of the bowel quite significantly, resulting in quite profound diarrhea. Whereas on the bottom right-hand corner there in the large bowel, again this is something found more in AL amyloidosis, there's these submucosal deposits and formation of masses that, if there's enough of, can in fact impact motility. So keeping all of that in mind, we'll move and spend the rest of the talk now really focusing on the different treatments in amyloidosis. Now the treatment of systemic amyloidosis in general will usually result in stabilization or even regression of GI amyloid and therefore improved symptoms. But I'm not going to talk about that aspect of it. I'm going to be focusing now mainly on managing the gastrointestinal symptoms specifically. But what are those symptoms? Well, the most common gastrointestinal symptoms in amyloidosis includes weight loss, diarrhea, abdominal pain, constipation. There can be problems with generalized motility, which can present with heartburn, where the stomach's not emptying properly, so that could be nausea, early fullness and bloating, loss of appetite. And less frequently, there's the presentation of acute gastrointestinal bleeding, whether that's fresh blood or dark black blood as it's passed through the GI tract. Fatigue can be multifactorial but can be due to malabsorption and malnutrition. Now this slide is looking at the different symptom patterns, or which symptoms are more likely to occur in the different types of amyloidosis. I'll just go over this briefly. The main aim is really to point out there is quite a bit of overlap between the different types, but there are certain things seen in one type more than the other. In AL amyloidosis, weight loss, diarrhea, gastric emptying problems, or heartburn, nausea, vomiting are a problem. These patients can also present with abdominal pain either due to constipation, or they are slightly more at risk of this pseudo-obstruction or obstruction because of the potential to cause abnormal deposits in the bowel wall. Bleeding can also occur. In hereditary amyloidosis, the more common symptoms are weight loss, diarrhea, again the gastric emptying problems and heartburn and constipation. Just touching briefly on AA amyloidosis, this is much less common, and it tends to cause this infiltration directly onto the gut mucosa, which can have those subtle features I showed you on those endoscopic images. These patients will present with weight loss. They're more likely to present with bleeding and can also get abdominal pain from obstruction. These patients can also present with protein losing enteropathy, which still overall is quite an uncommon presentation, but it's a very typical clinical presentation of not only profound diarrhea and malnutrition in certain vitamins, in particular fat-soluble vitamins, also presents with significant leg swelling and fluid around the abdomen or lungs. So looking at some of these motility problems and focusing initially really by structure, so when it comes to motility. So firstly, the esophagus, which is where the food goes down into the stomach. The typical symptoms if there's a problem with the esophagus is heartburn, so acid coming up, discomfort, chest pain, and also difficulty swallowing if the muscle layers are affected. So food sticking, or needing to drink a lot of water. The treatment here is trying to optimize everything else, so reducing acid in the stomach by a proton pump inhibitor, or adding on another tablet called the H2 antagonist to really diminish any sort of reflux disease. Also, lifestyle measures can be quite helpful in the heartburn and difficulty of swallowing, and that's having small frequent meals, not overloading the stomach, bed elevation at night, not pillows but the whole bed being lifted up on a little bit of an angle to prevent the gravity impacting the heartburn, and also avoiding late large meals into the night time. The motility issues, so the difficulty with the foods getting stuck, is trickier to manage. On occasion, your doctor may prescribe a calcium channel inhibitor to try and relax some of those muscles, but it's unclear how effective that is in amyloidosis. Motility problems are common involving the stomach, and that means that the stomach most frequently is not emptying as well as it should. So that's called either gastroparesis, or if there's a mass from the amyloid in the stomach stopping the food moving along, it's more of like a gastric outlet obstruction. And you may feel early fullness, have a lack of appetite, get full with only a few bites, have nausea, and as it progresses, or in more severe cases, vomiting as well. Again, the lifestyle changes that are important, having small, frequent meals, up to 5 meals per day, avoiding high-fat foods because they will sit in the stomach naturally for longer, having higher protein meals, but also having some fibre, but really trying to cut down on the insoluble fibres such as nuts, beans and grains, because again they tend to sit in the stomach more. Because having regular meals, if the symptoms are quite severe, can be problematic, it's okay to actually move to more fluid diets and only eating for enjoyment, the small amounts for taste, but supplementing each meal with various supplements, and this can be quite beneficial because the liquid will naturally move through the stomach quicker. Medications in this area are also very helpful, so I'll go over these in a little bit more detail. So domperidone, or Motilium, is a tablet that's used to try and empty out the stomach. We can use quite high doses of this, up to 4 times a day. I usually recommend using this half an hour before each meal and also before going to sleep, and so that will help empty out the stomach overnight. It can relieve the nausea, it can improve the appetite, and can stop vomiting. It's generally pretty well tolerated. A very small percent of people have an increased prolactin level from use of that. I may notice some breast tenderness, but realistically that's quite uncommon. There has been in the past concerns about these cardiac arrhythmias in patients on high doses, but in fact there has been a relatively new study showing that even in patients, and so a lot of patients would have an ECG at the baseline just to make sure they don't already have, we look at what's called the QT interval, make sure naturally someone doesn't already have a prolonged QT interval. But a reasonably recent study has shown that even in those patients, or patients who when they go onto the medications, only about 6% have any prolongation, and it didn't actually seem to increase the risk of cardiac arrhythmias in that study of over 200 patients. So what that means is that I do feel more comfortable pushing up to about 80 milligrams of that medication if there per day, if there is benefit to the patient. The new medication that is available in Australia, it's TGA approved, but it's not on the PBS, meaning there is an out-of-pocket fee. I wasn't able to find what that's like with New Zealand, if that's available to you at a subsidised cost. And possibly there's something up for discussion at question time after this. But this medication, known as prucalopride, with the drug name as Resotrans, has been shown to excite the little neurotransmitters in the muscle wall of the bowel and help propel the bowel. And so its first line of treatment was for constipation, but in fact in recent years it's also been shown to help with motility in the stomach. And there have been a number of studies now that show that it helps to empty the stomach, and there have been benefits in nausea, bloating, and that sensation of fullness. It's still unclear how hard we should push this dose, pending some further studies on this when addressing the gastroparesis or the problems with emptying the stomach specifically. But definitely doses of 2 to 4 milligrams per day have been shown to help. The side effects tend to be mild but can include headache, diarrhea, or abdominal cramping. In Australia, patients out of pocket at $70 a month, roughly, if they are on 1 tablet a day. But occasionally, as symptoms settle, I have been able to wean people to 1 tablet every 2 days. I'm not sure what the cost is in New Zealand. And then the others, occasionally, pharmacies and public health, public hospitals will subsidise this cost. Nortriptyline is an old-fashioned antidepressant at higher doses, but it has been quite useful in the use for abdominal pain for a whole wide range of reasons, but also has shown some benefit in this problem of nausea and vomiting and gastric emptying problems. Again, it can cause side effects, but because we're using low doses, those side effects are much less likely. Occasionally, patients with amyloidosis will require rescue therapy, meaning despite highest doses of those medications and all the lifestyle modifications, the stomach is just not emptying because of the degree of the amyloid deposition, or because there is, especially with AL amyloidosis, a lot of infiltration of the normal stomach wall, and really that's highly impacting the ability to empty the stomach effectively. The first line rescue therapy is admission at home would be a pure liquid diet for 2 to 3 days at a time, using ondansetron along with that, but then being mindful of the a dose of the other prokinetics that were being used, and also potentially using an oral erythromycin as a salvage therapy. If that's still not enough, then admission to hospital may be required for IV hydration, and then using IV intravenous erythromycin, which is an antibiotic, but it has this it has an effect on some of the motilin receptors, so it can be very good at emptying the stomach as a side benefit to this antibiotic. And usually, depending where the patient is in terms of the amyloidosis journey, settling symptoms over about a week period with these strategies may be effective enough to be able to go home. The problem with the antibiotic, it's not a long-term action, it doesn't have long-term benefit because it tends to, there's a fatiguing response, it tends to be less effective after about 4 weeks. In even more severe cases, sometimes a degree of enteral tube or enteral feeds, which means tube feeding, is required, and that means basically bypassing the stomach and using liquid supplements straight into the jejunum. Now that can be done in a short-term basis, as you can see here in this illustration in the bottom, where the tube is inserted through the nose, either through endoscopy, gastroscopy, or in the X-ray department, and then it's lodged into the small bowel, and then the patient is fed completely just through there, and you don't get the nausea, vomiting, or anything, because a lot of that's coming from the stomach. Long-term, and this is quite unusual to need, especially if there's ongoing treatment for amyloidosis in general, but it is also used in other gastrointestinal problems, is this permanent tube, when then it's inserted through the skin into the small bowel, and then either all feeds or 50% of the feeds are put in through this tube here. But this is really only used or suggested for conditions that are thought to be irreversible, and therefore in amyloidosis I'm not aware of it being used quite frequently. So So moving now on to the other motility problems of constipation. In terms of lifestyle modifications, first few things to do: fibre 30 to 40 grams a day. No point going much higher because it causes bloating and distension. Adequate water intake. Adequate physical activity. This is a common problem for patients diagnosed with amyloidosis or any severe disease either, where the physical activity reduces significantly, but that is a trigger for colonic motility, as are regular meals a day, even if they are small. That is quite important to adhere to, because that's a natural physiological stimulus for the colon to propel the stool along. Now, in terms of beyond lifestyle management, I then use a baseline stimulant and bulking agent. So that can be psyllium, or in fact Flow, which is something that's been designed in New Zealand, is a kiwi extract that does the same thing and also has probiotic along with it. So that's sort of like the baseline that would be used every single day. On its own, the benefit of that is minimal, but that forms sort of the basis of then adding on an osmotic laxative, so it would be that Movic or Osmolax, and also on top of that a stimulant laxative, which can be bisacidal or some of the other traditional ones, or prucalopride is very effective in this space as well. So then moving on to the management of diarrhea. Diarrhea is a little bit different in the approach. The first thing that can be useful is to try and determine what the underlying mechanism is of the diarrhea, because that can help tailor the most appropriate treatment. One of the causes is something known as rapid transit due to autonomic neuropathy. So what that basically refers to is, as you would remember, I showed you the picture of the nerve endings going into the gut wall. Some of those nerve endings in their normal function stimulate the bowel, and some of them actually stop the bowel from working too fast. So it's the balance of both of those that helps maintain good bowel function. And so if the nerve endings that are meant to slow down the gut have been affected by the amyloidosis, that can present with a rapid transit. In terms of managing that, we then manage with medications to do the reverse and slow things down. Other causes may be direct damage to the mucosal layers, especially in AA amyloidosis, but also in AL. And so in these patients, sometimes if someone's developed gastrointestinal manifestations, in particular diarrhea, during the course of the amyloidosis, a gastroscopy and colonoscopy can be helpful to document degree of damage to the mucosal layer and ulceration, to have an idea why, what's behind the diarrhea in that case. Fecal calprotectin is a non-invasive marker which wouldn't really, that can be basically used to track that sort of inflammation and give some additional information on that. Small bowel bacterial overgrowth is something I consider in patients who present with diarrhea and quite extensive bloating or distension. That usually is marked in these patients, and treatment can then be tailored down the relevant antibiotic pathway. I've again mentioned protein losing enteropathy. There are quite clear clinical presentation features and also tests that can be done, but ultimately that still remains a relatively uncommon cause of diarrhea and amyloid. Frequently though, in diarrhea it may be a combination of one or two factors at least. So the standard approach to anyone with diarrhea is to slow down the gut, and that can be done with something like gastrostop or loperamide. The key there is not to be shy about it and to keep pushing up the dose, because ultimately it's well tolerated, and you can use doses of 18-20 milligrams per day, and in some small bowel, in short gut syndrome patients we use even higher doses than that. Codeine can also slow down the gut, but it can sedate you. It has a sedating effect. There is some evidence for the use of what are called bile acid sequestrants, so cholestyramine. Initially, the studies showed that in patients with hATTR, there's potentially this process of bile acid malabsorption, and so any excess bile acid that's not reabsorbed in the small bowel, as it should be as part of its normal process, hits the large bowel and irritates the colon. And so we get these sequestrant sachets or cholestyramine sachets that are taken 2 to 3 sachets per day, and it binds up some of that bile acid. needs to be taken at other times to other medications, and it can be a bit gritty to drink in, so dissolving it in juice can help. The key again there is not to just try one sachet per day, but up to 2 or 3. And even though most of the evidence initially came from HATTR, it is a useful tool to use if some of the other strategies are not working. The important thing to consider with diarrhea is the patient malnourished, and that's really with your doctor looking for some of the blood test results there, and oral and IV supplementation. Small bowel bacterial overgrowth is not an uncommon cause, and I won't go into why that is in detail, but it can be due to motility, can be due to medications, can be due to the amyloidosis itself depositing in the bowel. Basically what it presents is with bloating and chronic watery diarrhea. Flatulence can be a problem with this, and it's basically due to too much anaerobic and aerobic bacteria found in the small bowel that usually should live or reside in the colon. It is diagnosed with a special breath test, and there are a few things around that, in that you can't be on, there are a few quite strict rules around how to test for that in terms of being on acid suppression. But what it shows you here, I find it useful to show you this on the left-hand side there. We can see some of the small bacterial overgrowth, and what happens is that the bacteria found in the small bowel will digest this lactulose and produce hydrogen, which get absorbed into the bowel, into the bloodstream quickly, and is expelled in the breath test of the patient who's doing the test. And we see this early sudden rise in the hydrogen production as compared to someone who doesn't have excess small bowel bacteria. There are some limitations in the study, and it's not either, it's about 70 to 80% sensitive and specific. And so we just need to keep that in mind. If the breath test doesn't fit with the clinical picture, sometimes it's useful to treat if there are predisposing conditions thought to be associated with this small bacterial overgrowth, and if the clinical symptoms look very consistent with it. The new changes in treating of this condition is that there is now rifaximin, which is a non-absorbable antibiotic that can be taken 3 times a day for 2 weeks. This is a new medication. It's used on label for other indications. It's also not available through the PBS in Australia, so again it's at a cost, but that cost is subsidised by the gastroenterology units at the public hospitals. Privately, sort of looking at about $60 or $70 a cycle, if done through a compounding pharmacy. The more traditional antibiotics were things like ciprofloxacin, Bactrim, Flagyl, and Augmentin, though I've kind of gone out of favour with Augmentin because it is more, it does increase the risk of certain infections in the gut, like Clostridium difficile. And look, the majority, about 50% of patients have good sustained response after 1 cycle, but some patients need recurrent cycles. And really, if there's no benefit within that first course, the indication is then to change to another antibiotic. Again, there can be treatment-resistant or severe medically refractory diarrhea. In those situations, patients usually present to hospital. There is some evidence for the use of something called octreotide. That's it's a medication that reduces some of the gut and other pancreatic hormones that all impact on the motility of this bowel. So it reduces the motility of the bowel, and it also stops these sort of leaky vascular membranes. And through all of that, it's been shown to slow down the gut and be useful in refractory diarrhea. It can be given as an intravenous infusion or an injection. And again, in Australia it's not on the PBS for this indication, but in conditions such as amyloidosis, because of the rarity and things like that, sometimes it's possible for the hospital to subsidise it. This is very costly. If someone ends up requiring this for a prolonged period of time, you're looking at about $1,500 a month. So I've spent a bit of time on the preceding symptoms. They were the more common ones, and where there's been some change in treatment availability or treatment strategies. Abdominal pain can occur on its own, or usually it's actually in conjunction with severe constipation. So it's always important to consider that as a cause. The treatment tends to be around adequate analgesia and pain relief. In severe abdominal pain that also presents with sudden nausea, vomiting or distension, or even if this is incremental over 2 to 3 weeks, there is a condition known as pseudo-obstruction, and you can see it in this x-ray where all the bowel wall is quite enlarged or distended and with no clear transition point. So one of the causes of something like this that's considered as whether there's something blocking the bowel. This is what's called pseudo-obstruction, where there's no blockage, but through severe autonomic neuropathy or severe infiltration of the bowel due to the amyloid, the bowel becomes very distended and is not functioning properly. This can be quite a problem to treat. It tends to be relatively uncommon, but it requires usually hospitalisation and on some occasion even complete bowel rest, which is the one condition where that may be suggested over sort of ongoing enteral feeds with using intravenous TPN, means intravenous feeds for a short period of time. So one additional issue I'd like to address is the issue of patients being malnourished or weight loss associated with amyloidosis. It is important to address this early. There was a pivotal study out of the UK a number of years ago that showed that up to 60% of patients with AL amyloidosis at the time of diagnosis of their amyloid were already moderately or severely malnourished. And this was also found to be an important prognostic factor in terms of their long-term outcomes. Now, it's important that it's an issue that's identified early. Weight loss may not always travel together with malnutrition, so malnutrition markers need to be performed. Dietitian support is important. High caloric supplements can be used to improve caloric intake, but also any specific malnutrition needs. It's also important to then address the symptoms that have led to the avoidance of foods such as gastric emptying problems or nausea, vomiting and the like. There may need to be alterations made in components of the diet depending on some of these other symptoms. And as a concluding factor to this, if the malnutrition is serious and hospitalisation is required, there is always a preference from a gastrointestinal perspective to do this with enteral feeds where possible. So in conclusion, I'd like to point out again that gastrointestinal symptoms are relatively common in amyloidosis patients. In the vast majority, this is indirect from the impact of disease itself or on other organs, but up to 7 or so to 10% of patients will have direct impact on the gastrointestinal organs themselves or the auxiliary structures that help them function properly. Management is aimed at identifying the cause if possible and also targeting to the most severe symptoms. There are new prokinetic agents and antibiotics used for small bowel bacterial overgrowth, but there are also existing treatments still available that can be very effective at adequate doses. And nutrition is very important to address early. So thank you for your time, and I'm looking forward to some questions.
Thank you very much. Thank you, Ola. I don't know if you can hear us or not. Oh, okay. Thank you, Ola. Can you hear us?
Hello, how are you doing?
We're going well. Thank you very much for your talk. And just to say, we're actually all running quite behind, and we wonder if it would be all right if we get any questions and we can email them to you, and you can answer them that way.
Yeah, that's fine. That's not a problem. Yeah.
Okay.
Did you? Yeah.
Unless there's
So
anyone
do
who
we-
wants to ask 1 or 2 questions just now.
Okay. Great.
Anybody? Okay, Ola, thank you very much, and we'll email you with any questions we have. But we very much appreciate your time and your talk. Thank you.
Okay.
Now, for us at the moment, there's actually a lunch provided, I think, Jamie, is that right? And this is being sponsored by a business called Zion Motorhomes Limited out of Pocono. So they're actually providing lunch today. So thank you very much, Zion Motorhomes. We'll all have to hire a Zion Motorhome next time. And I think we still want to meet at 1 o'clock, don't we? And Professor Ed Gane is going to talk at 1 o'clock. Can we just all make sure we're back here on time by 1 for that next call? And I think, is the lunch going to be downstairs, Jane?
Yes. So all you have to do is head through the door, either down the lift or walk down the stairs. And the lunch is right that area. If you notice, some people eating breakfast this morning, so that's exactly where it is. Sorry to have to rush to eat, but this is the time when you have to eat quick.
Eat fast. Eat fast, and we'll all be back here by 1.
So again, yeah, you can do it.
It's with working with Ed Gane.
Yeah, I work with a functional one of the trials. I'm the study coordinator, which is sort of like a project manager. So the study comes to NZAPA, which is the company name, and basically I try to find patients for the study to try and run the project as a whole, coordinate all departments together to make the study happen. So yeah, I've been I studied pharmacology degrees and just developed design and that science and also most of the skills have been pharmacology background.
Because one of the ladies here is saying, she's done nursing and now she's doing
It's really good. But also, which is good. And I've got to show you. She's here for duration. She's this poor might get to so we'll just change called out again who
I think having awareness and helped my symptoms a lot because we did find out at such a young age. It would have been nice to know what treatments were available and what it really means and what my dad's going through and what to expect in the coming years, because it would have helped to manage the time that we have with him better. So I feel like there was a lot of things that I took for granted when he was still progressing before I kind of spiraled faster, that I didn't utilize well, because to me, when I was say 12, and he was coughing a lot and stuff, it was easier for me to write off as, oh, it's probably just something like a cold, you know, it'll get better, and then having to come to terms with the fact that, oh, it's not going to get better. In fact, there's just going to be things that are going to be added on, like it's just going to get worse. I feel like knowing that beforehand would have helped a lot to prepare myself emotionally.
You know, finding out when I was super young, when I was 10, and I hadn't matured much, I hadn't gone through a lot of experiences. It really changed a lot of dynamics for me, the disease, both in social aspects and at home. When I was growing up, I always had this understanding that I needed to be ashamed of the disease, or I always felt like I couldn't talk about it because I didn't know enough about it, and that leading into me feeling ashamed about it and not telling my friends or people around me what it is or how it affected me and my family is something that I wish I had gotten over or been able to get over before, to talk to other people about it, to share my experiences, because that is how we and us as a family have gotten closer and gotten over it by being able to talk to each other and open up how we feel.
I think a fear that I have right now is that I will spend 5 years studying for something that I wanted to do for him. And for him to not be there in the end. Should I fix up or should I just continue? Okay. All of our experiences of like family members passing away with the disease has always been alone when they're in bed alone. And I think because of that, there's just like this overwhelming fear of it happening while no one is with him. So I think there's another level of like, if we are not spending like every second with him, it's like guilt because we don't want to, you know.
Is that all? This afternoon, our first speaker is Professor Ed Gane, Professor of Medicine, Auckland University, Chief Hepatologist at the New Zealand Liver Transport Unit, proud father of 3 teenage children, daughters. And he's been managing patients with familial amyloidosis for some time. And he got some special training for that at King's College in London in the 1990s. When I brought into general practice 33 years ago in Auckland, one of the partners in the practice was Ed's father, Jim Gane. So that's a long connection, isn't it? And thank you.
Thank you. Okay. First of all, I'm delighted to be here, and I'd just like to thank Jamie and Aubrey and the New Zealand Amyloid Patients Association for putting this together. I think this is long overdue. As we've heard throughout the meeting, this has been a disease which has been largely ignored, and it's time that we try and get together and have a coordinated effort within this country. And I think follow the lead of what happens in Brisbane, New South Wales, Brisbane, Sydney and Melbourne, and have at least a virtual multidisciplinary team here. Now, why am I involved in amyloidosis? In fact, people with amyloid have a normal liver, and as Lou said, I'm a liver specialist. I became involved in a way where I left, after I'd done my medical training here, I went to London to King's College to learn about liver transplantation, because we wanted to open a program in New Zealand. Up until then, all our patients went to Brisbane or Sydney. And whilst I was in King's for 5 years, and we ran the amyloid transplant program, which meant that people from throughout the UK and much of Europe came to King's College for their liver transplants. Because although the liver is normal for hereditary amyloidosis, the liver was a factory which made the abnormal protein. So I ended up looking after dozens of patients who underwent liver transplantation for this condition. And when I came back and we opened the program here in Auckland, I was asked to see patients. But unfortunately, these were patients who were usually very sick. And I think hopefully my presentation will show you that there are better treatments than liver transplantation, which can work early in the disease. I'll try not to duplicate too much of what has been said, so I may skip over a couple of slides. Oops, sorry, I forgot. Yeah. Okay. Next. Yeah, so that you can skip over this, as I say. I've worked in several of the studies, and if you can carry on. So here, I'm going to talk largely about hereditary amyloidosis, but some of the treatments will be equally as effective in wild-type transthyretin amyloidosis. And there are a number of forms of hereditary amyloidosis, depending on which is the abnormal protein. We've talked mainly here about transthyretin. You could click next, or shall I try? Yeah, thank you. But fibrinogen alpha chain is also a type of amyloidosis which is hereditary, autosomal dominant, which means that you only have to carry one copy of the gene to get the disease. Autosomal dominant means that only one of your parents needs to have the condition and half the children will have it. And fibrinogen alpha is a different disease from what we've heard about up until today. It affects, but I think it's important to talk about it. I think some people in the room have this type of hereditary amyloidosis. And it's probably more common than the transthyretin amyloidosis here in New Zealand. We have two very large families, or what we call kindreds, who suffer from this mutation in the North Island. Unlike transthyretins, there's only really one mutation. There's another rare one, but this is the mutation which almost everybody has, and certainly everyone in this country. There's often not a family history of it, the onset is late in life. And many people with this mutation don't get the disease, but the disease is quite different. We've heard all today about the neuropathy and the cardiomyopathy. In fact, this hereditary amyloidosis causes kidney disease. Initially, the kidneys get leaky because the amyloid builds up in the kidneys and they lose protein in the kidney. And then once the protein is developed, then that person will develop kidney failure within the next 5 to 10 years. And it runs true in the families. In that family, if somebody develops kidney failure, the other affected brothers and sisters will also develop kidney failure at some stage. It's also associated with premature coronary artery disease. And we haven't heard much about this in Tim's talk, but I think Nezar's. If you have any type of amyloidosis, it can be laid down in the coronary arteries. So it is the reason why people can get coronary artery disease or heart attacks earlier in life if they have hereditary amyloidosis. What I'm going to talk about is the newer types of treatment to treat transthyretin amyloidosis. They have not yet been applied to alpha-fibrinogen amyloidosis, and I hope that over the next decade we will see the same science, which is fantastic, being applied to this condition as well, because it is important for New Zealand. And the only treatment currently is liver-kidney, that's combined transplant. That's the only way to prevent it happening again, but we tend to offer in this country just kidney transplant because of the lack of donors. So we'll turn now to what we've heard a bit about already, and this is hereditary transthyretin amyloidosis. There are many mutations. They keep on being discovered. In fact, we had one patient, and I'll just point out, I see these patients purely because I'm a liver transplant physician, and the doctors around the country think this patient would benefit from a liver transplant, but we think that's the tip of the iceberg. I don't think we see many of the patients living in this country with hereditary amyloidosis. And one patient, anecdotally, I bumped into when I was at the Hepatitis Foundation in Whakatane for a day meeting, and this woman walked in and she was talking to me, and she said how she had problems with her breathing and her heart, and it became clear to me that this woman had an infiltrative amyloid. In fact, she turned up having had a new mutation, transthyretin, and she had a combined heart and liver transplant and has done exceptionally well almost 10 years later. So I think we need to have better referral processes, better pathways for people to get into care, certainly with the new treatments. These are the mutations which we have in this country, so we have quite a lot of different types. Every mutation is a different family, if you think about that. And they're all autosomal dominant, which means one parent will have it and half the kids will have it. And half of their kids will have it. So that pertains to the next talk on the genetics of this and genetic counselling. So all of these mutations have been reported in New Zealanders. And not all the New Zealanders live in New Zealand. As we know, many of them travel to the lucky country. A few of them come back. But we know that of my patients, many of them have cousins, aunties and uncles who live on the eastern seaboard largely of Australia. Okay, yeah, I think you've seen this sort of thing. You know what causes amyloidosis. What I'm going to talk about today, because we've had wonderful presentations over the last day and a bit, and in particular last night from our two Australian speakers, we talked about the different therapies. But today, I'm going to talk about how you reduce the abnormal proteins. I'm not going to talk about these neat ways to prevent the abnormal folding of the amyloid. I'm going to talk about how you prevent the building block for the amyloid, that is, you stop the production of the abnormal transthyretin. And here, there are three approaches. They are all genetic, if you say. One is liver transplant. You're taking out the abnormal factory and giving that person a normal factory, which makes normal transthyretin. The other is gene silencing and then gene editing. I'll talk about those in a minute because I think they're going to revolutionise this disease management. Liver transplant is, this is Prometheus. Does anyone know the Greek mythology of Prometheus? Prometheus stole fire from Zeus and gave it to humankind, and as his punishment, Zeus tied him to a rock and asked the eagle to eat out his liver. And this was the first real recognition that the liver regenerates. And the liver keeps on regenerating. And that's really what has made you. And so the eagle came back every day, and every time it came back, the liver had grown back to its normal shape. And we know that now. We utilise this in liver transplantation, where we can take part of the liver and give of a healthy person, give it to someone else, and both livers grow to the normal size in 4 weeks. So it's a remarkable organ. And that's really facilitated liver transplantation. I'm sorry, this is after lunch, perhaps I should skip over this. But this is a beautiful liver. And so we as I said, I learned about this in King's, and we managed to apply it here. And as you'll see, we've transplanted a number of Kiwis with this condition. I call it gene therapy for dummies, but we're supposed to call it gene therapy for surgeons, and my surgeons forgive me for saying that. So as I said, you're taking out the liver, which makes the abnormal protein, and put in a liver which makes normal protein. And you stop immediately the production of the amyloid, the production of the abnormal amyloid. And it stops progression of the neuropathy, which we've heard about from Antonia. This should stop progression of the neuropathy, preventing the laying down of the abnormal amyloid inside the blood supply to the nerves. But it does not always stop the progression of the heart disease, the cardiomyopathy. And that's because if patients from the families where they already have abnormal amyloid in the heart, and not all families get that, that becomes a focus for the normal transthyretin to bind to after the liver transplant. And that is an issue. So if somebody already has cardiomyopathy before the liver transplant, that can progress after the liver transplant, and therefore there may be a need for combined heart-liver transplant, or using treatments after the liver transplant. So far we've transplanted 7 Kiwis, 6 here, one in Sydney. 4 have had isolated liver transplants, and 3 have had combined heart-liver transplants. We initially did these at Green Lane Hospital, and we went to the new hospital. The next 2 were done at Auckland Public. Optimally, you should transplant the liver and heart early before the disease is severe, but waiting for a suitable donor, in particular somebody who's died of the same blood group or deceased donor, can be very long in this country because we have one of the lowest organ donation rates in the world, unfortunately. So people can wait for years. And therefore, liver transplantation sounds great because it stops the disease, but it is a very limited resource. But the outcomes are good. This is the World Registry from Ericsson in Sweden, because Sweden has most of the keeps the databases for the world for this type of amyloid. And just to say that 10 years you have around 70% survival, and people have retained quality of life. So this is very good compared to other indications for liver transplant. Things have changed. It used to be you had to have a certain type of inherited amyloid to do well after liver transplant. And in fact, most of the patients I looked after in London had what we call the Portuguese variant, Val met 30, and they presented at a much younger age, and they were transplanted usually in their 20s or 30s. And they, as you can see in the blue line, this is survival percentage with years from transplant. They have a much higher survival. And that was when I was involved in the ARC from 90 to 95. But things have changed for liver transplantation across the board. With improvements in operating techniques, our surgeons use very skilled cutting devices. We have expert anaesthetists and intensive care, and much better ways to prevent rejection. The outcomes for both are getting up very well, and in fact, the outcomes for people with the other types of familial amyloid are almost as good as amyloid. We're expecting around 90% 5-year survival. Okay, one way to increase the supply of organs is to do what we call domino transplants. And we've done one in Auckland, and we did several in the UK. That is where you have one donor, and here it's a deceased donor, somebody who's died and the family's made it a gift of life, to donate the liver or heart or kidneys. And that person who is healthy before they die can donate their liver to somebody with amyloid. And that, remember I started off by saying the liver is actually normal. It's a normal liver, except it makes one abnormal protein. And for most people with amyloid, it takes 30, 40 years for that protein to build up enough to cause the disease we know as hereditary amyloidosis. And therefore, it makes sense that person can donate their liver to someone else. So it's called a domino. So the amyloid liver from the person with amyloidosis can go normally into an older recipient, somebody in their 50s or 60s who's waiting for liver transplantation. And they will have a perfectly normal life expectancy before they get old enough to get significant amyloid disease. And this has become common practice around the world now, is that if you have somebody having a liver transplant for hereditary amyloidosis, and they agree, when they receive a liver, they donate their liver to an older person on the waiting list. And this is a great way to double the numbers of organs out there. So this, to me, is a great reason why people with hereditary amyloidosis should get prioritised on the waiting list. Okay, and this shows that if you have a domino transplant for amyloid, then you've received the amyloid liver, okay, so you're the person without amyloidosis who gets the liver from a person with amyloid, your survival rate is superb, with well over 90% 5 and 10 years survival. But look at this is also from that database from Sweden, and they collect everyone who has had a liver transplant for amyloidosis in, I think it's the Europe, UK registry, and the US. I'm not sure if Australia or New Zealand contributes to this. But the one thing to note is it's become, obviously there was a time when it went up and up and up and up, and then after 2010 it's really fallen dramatically. And this really coincides into the starting off, and this is what their Ericsson's conclusion was during recent years there's been a decline in reported transplants And this is probably because of the introduction of new medications. And we've heard about the new medications already last night and this morning, how they are changing the lives of people with hereditary amyloidosis as well as other types of amyloidosis. And I think they will remove the need for liver transplantation entirely eventually. So this is what gene silencing is. So gene silencing is, this is your DNA, which has your genes in it. On your chromosome, I think 18, there's a gene which makes abnormal transthyretin. So that the DNA, which is your template, your genome, that codes for something called RNA, and that codes off the DNA. The RNA is made in your nuclei, it goes out into your cells in the liver. This is only in hepatocytes that the RNA is made, and it codes for a protein. So the DNA codes for an RNA. The DNA is the template, that's permanent. The RNA is made each day, it comes out and it makes a protein each day. And that protein, the disease-causing protein, and for amyloidosis, that's transthyretin. So if you're looking at gene silencing, it means you're not getting rid of the gene, that's gene editing, you're getting rid of this messenger. mRNA means the messenger. It's the messenger from the gene which makes the liver cell make the abnormal protein. So gene silencing means you're getting rid of the mRNA, and that's what we're doing. We won't talk about those, we're talking about these things. Translation inhibitors. So they silence the mRNA, and they bind to it and kill it, or disrupt it. So gene silencers are these things here. They bind to that and they block the protein. And because you're making this all the time, because that's not affected, you have to give these, we call them translation inhibitors, you give them regularly, lifelong, to knock down the abnormal protein. To knock down the messenger and prevent the protein. So it's very effective, but you have to give it lifelong. And there are two types of gene silencers. I won't go into some data, but called antisense, opposite to that, or small interfering RNAs. And they've been used not just for amyloid, they've been used for many diseases at the moment, and it's revolutionising medicine. So medicine is undergoing, I think, a huge paradigm shift in the way we treat most inherited diseases. And the first paradigm shift is these gene silencers, and you give them for all types of diseases, inherited or infectious, and all of these trials are underway. You can use it for people with high cholesterol, you can use it for people with cystic fibrosis, you can use it for people with inherited liver diseases which cause cirrhosis, and now they're starting to use it for people with obesity to prevent insulin resistance. The potential of gene silencing is just unlimited. But it's, sorry, this is the hepatocyte cell, that's nucleus, and the two things work in different ways. The patisserin, which you've heard about, the RNA, chops up the messenger inside the nucleus. The inotersen, which is an siRNA, the other type, chops up the messenger inside the cytoplasm. So they work in two different ways, the two approved drugs, gene silencers. They work in different, so they could be complementary, but they work in different ways. I'll skip over that, just how they work. So we've heard about patisiran. I won't go on this because it's not head-to-head studies, but patisiran is, that's the placebo. This is the amount of the abnormal protein in the blood. It's an indirect measure of how it's working in the liver. You can see it knocks it down by about 80%. Very, very effective. Patisiran is, and prevents the progression, you've seen this slide so many times, but going down is good. That's progression of neuropathy with time, and people who get the dummy drug, placebo. That's what happens if people get the active drug, patisiran. It gets better whilst it gets worse in the people who are not on active treatment. Patisiran is great, but it is intravenous. I think it's three weekly intravenous injection. And you can get some reactions to the injection, so you need to have a pre-med, usually. So it's good, but it's not obviously, I don't think, the best thing in terms of patient tolerability. But the company who make patisiran, Alnylam, are making a new form of this, which can be given as an injection under the skin every 3 months. And I think that's really fantastic. You can do it at home. It's like having a little vaccine. You put it under your skin, tiny injection once every 3 months. So that will be, although patisiran, I guess I'd say this is a proof of concept, that this works really well. But their next drug is going to be, I think, really, really convenient and well tolerated for the patients. So that's patisiran. The next one I mentioned was, and that's approved by the FDA, it's not yet, I don't think it's on the, approved by MedSafe, and it's not funded in New Zealand. What about the other one, what called the antisense? These are slightly different graphs, and you've seen this many times. Again, blue is people who got the active drug, black is people who got the dummy drug or placebo, and this is changes in neurology, worsening, or you have to say is that if you got inotersen, you did much, much better than if you got the dummy drug. It's a different molecule, and it's, it has to be given weekly, but it can be given subcutaneously, but it has to be given weekly. And that's not great either, to have to dose yourself every week. So this company also have seen the light, and they've got a second generation drug, which is currently in development. We have one patient on the trial in Auckland, where it's given, again, under the skin, but it lasts much longer. It can be given monthly. So the new drug for inotersen can be given monthly under the skin. And the advantage of that also is it won't have some of the side effects, low platelet counts, which you have with the previous thing. So I think both companies are making much, much better formulations, which will make this far more acceptable and easy to administer. The issue always, though, will be having this funded in New Zealand and Australia, and I think we should talk about that. It's also approved by the FDA. So that's gene silencing, right? I've talked about how gene silencing works. Abnormal gene making an abnormal messenger, which makes an abnormal protein. So that's a DNA messenger RNA protein. And gene silencing gets rid of the abnormal messenger. Right. Oops. Now, let's have a look now at gene editing. That's gene silencing. Now, how does gene editing work? Gene editing goes beyond getting rid of that, a pair of scissors which cuts out the abnormal gene and lets the DNA form again without the abnormal gene in it. It's a pair of genetic scissors. And there are many types of gene editing under development. Some of them put something else back in its place, some of them just remove the abnormal gene. And the one we're going to talk about for the next few minutes is a thing called CRISPR. So CRISPR cuts out the abnormal gene, therefore you don't make the messenger, you don't make the abnormal protein, and it's permanent. So one shot, permanent treatment for this condition. And this is obviously just entering clinical trials now. And gene editing is changing your DNA. It's changing your DNA forever. It is here. There are two types. I'm going to talk about CRISPR. And it's been used for many different types of diseases. It's already been used in a number of blood disorders and that we call it ex vivo. By ex vivo I mean you take the bone marrow out, you treat it, take out the abnormal gene which is causing the thalassemia or the sickle cell anemia, these are diseases found in different parts of the world, or is causing the leukemia, and you make them normal and then you put it back into the person's bone marrow and they have a normal marrow, they stop having that disease. That's ex vivo, out of the body. In vivo is where you give the treatment to the person, sitting in the bed or lying in the bed, you give them an infusion or an injection, and that gets rid of the abnormal gene. And that is new, and that is what I'm going to talk about. There are a number of trials in development, including a lot of these lethal diseases, and a number of trials for diseases associated not with death but with severe reduction in quality of life. And there are 3 of these trials are currently about to start here in Auckland. So the one I'm going to talk to you about, of course, is the one to do with familial amyloid, or hereditary amyloid. And we have to thank these two women who received the Nobel Prize last year for biochemistry. Emmanuel Carpentier from Paris and Jennifer Doudna, from Boston. And they, for the first time, showed that CRISPR, I won't confuse you, but CRISPR is a natural process bacteria have when they get infected by viruses to get rid of the virus. And CRISPR is a natural process. They found a way to use CRISPR to do gene editing in people, in humans. Of course, there's a lot of animal trials, so this is something which could be potentially safe and effective in humans. All their trials have been in animals to date. And so they received this for developing CRISPR as the first potential gene editing therapy for humans. And the importance of this photograph is Jennifer Doudna on the right. She's a woman who set up a company called Intellia. And Intellia is a company who is now running the first ever gene editing study in hereditary transthyretin amyloidosis. And it received a lot of press, a lot of it, as you know, controversial press. There have been some things about how can you change someone's DNA? Is that ethical? Is it not? So I've talked about the two types. Ex vivo, you take the marrow out, you change it, you put it back. In vivo is you give it to the person. Now there's something you need to know. In vivo, we're not just giving them an infusion of a treatment which will go everywhere. Remember, this is a disease where the problem is in the liver. None of the transthyretin, or virtually no transthyretin is made in the eye or outside the liver, a small amount, less than 10%. So if you can find a way to deliver this pair of scissors just to the liver cells, then you are sparing that person of having any potential changing of their DNA outside the liver. In particular, you're not going to be affecting their reproductive organs. You won't be potentially passing on any mutations to their children if they have childbearing potential. And there are two ways to do that. One is what we call lentiviral delivery, and the other, which has been used by Intellia, is nanoparticle delivery. And nanoparticle, I think we've got on the next slide, is shown here. CRISPR is really neat. This is Cas9, that's a bacterial nuclease, a pair of scissors, and you join it to what we call a guide RNA, which matches the gene for transthyretin. And then you put it in these lipid nanoparticles. And we've used lipid nanoparticles in our research unit to treat hepatitis B with some of the new genetic therapies. These are safe. You need to give patients a pre-med, but they are well safe. And lipid nanoparticles have lipid on them, so they're taken up by the liver cells, which have a receptor on it called the LDL receptor. And that takes up these lipid nanoparticles so they can get inside the liver cells. It is very, very clever. And it goes inside the liver cells and it matches and chops up that abnormal gene and removes it forever. So, does it work? This is the work which won the Nobel Prize, so I'll show it to you because it's important. Here, this is a proportion of cells inside the liver, we're only interested in the liver, doesn't affect other cells, where the abnormal gene is removed from. Of course you want 100%, but you don't need 100%, you need about 80%. And here you can see this is different doses. Low dose in yellow, medium dose in red, high dose in blue. So the higher the dose, the more of the liver cells lose that gene. And you get up to 70%, which is all you need to have a long-term benefit to the mouse or to the human. And over here, so that's the number of the percentage of cells in the liver which are effectively silenced or edited. And this is the effect on what happens in the serum. And you can see that even on the low dose, you're getting a significant reduction in this abnormal protein. But in the high dose, shown in blue, the transthyretin goes down to about 1 to 2% of the pre-dose level and remains there. And it remains there for as long as you follow up that animal in the trial. And they followed up these animals, they weren't killed, they were just followed and had blood tests. And the animals never had a rebound. So it was a single treatment, no rebound. And so 99% reduction in the plasma transthyretin. And the next studies they did were in non-human primates, and they showed the same thing. So they only needed 60% of protein knockdown actually to achieve a benefit with what we think in humans. But you can see with a single shot in monkeys, they were getting reduction to just a few percent of protein. And that lasted, again, for as long as you followed up these monkeys. And they're still being followed up, and they remain cured of their amyloidosis. What about in humans? Now this is the first study in the world where gene editing has been done in vivo, in patients. So it's a very important study for a number of reasons. And I'll talk about how that could be done anywhere, let alone here in Auckland. It is, the person comes into the ward, and I should just say I've got Shruti in the back. Shruti is our study coordinator who does all the work. She talks to the patients, and she has been approaching patients and arranging for them to come in, and we're keen to have any patients with this condition considered for this. So the patients come into the unit, they have a single injection for about half an hour, and then they stay in the unit for about 3 days, and then they go out, and then we bring them back and see how they are. And it's been, I can't tell you the results, but it's, all I can say is it's very well tolerated. It's a phase 1 study, which means it has to be done in a special unit where there's very careful observation during and after the treatment. And it's what we call a dose escalation study. You only ever have a single dose of this treatment. There's only one dose is needed. We start low dose, we go higher doses, and then we choose the dose to go into part 2. Now this study is being run by the National Amyloidosis Centre in London, by Julian Gilmore, who I know many of the doctors in this room work with and collaborate with. And Julian is running this. We were fortunate enough to be asked to participate, largely because I've done a lot of early phase work in my viral hepatitis interest, and we had a ready-to-go centre, and I already had patients I knew who would benefit from this. And so we're involved in this. And currently we're the only 2 sites. The COVID, and I'll talk about this at the end, I think COVID pandemic has actually provided opportunities for both Australia and New Zealand in terms of being able to do really groundbreaking clinical trials. So we're here, okay, we're here, and I can't give you the results in humans, but what I can say is that the results will be released for the first 2 cohorts in about 2 weeks' time, when Julian, as a primary principal investigator, will discuss the results. And these are safety results as well as effectiveness on transthyretin. He will present those to the European Neurology Conference in Europe. I'm not sure if it's virtual, I presume this. And then it will be out there in public for you to see. And then once we've done that, we're going to finish the study, and then we're going to move into an expansion cohort. And we're hoping by that stage, in August, September, the rest of the world will have recovered enough from the incredible restrictions they've had in place in clinical trials because of the COVID pandemic to be able to join the study. And there are a number of sites in Europe and Canada and hopefully Australia. We're hoping that we'll get sites in Australia that will join the study. That is, to be able to do a study like this, you have to obviously go through a number of certain hurdles. You have to show that it's a safe and ethical study to do. And that's been quite a process for us to go through. I'll just say that we have to have a phase 1 unit. We have a new regulatory committee called the GTAC, Gene Therapy Advisory Committee, set up by the Ministry of Health. And we were their first study ever. They had to evaluate. We followed on a very thorough evaluation by the United Kingdom. They have their own Gene Therapy Advisory Committee to make sure what we were doing was ethically and morally and justified and carried out in the safest possible manner. And we have to have patience. And we have patience, but we have to have patience. And I think we have to offer this to every patient who would suit entry. It is currently for hereditary transthyretin amyloidosis. There's a press release overnight, which you can look if you want to, by Antonia. This is the company set up by the Nobel Prize winner, and to say that the results are coming out 2 weeks' time and how you can get them. This will change, I think, the way we look at managing not just hereditary transthyretin amyloidosis, but also wild-type transthyretin amyloidosis forever. So I'll just finish. This is a rare condition, hereditary transthyretin amyloidosis, but it is associated, as we know, with significant illness and shortened life expectancy. Different families will have different what we call phenotypes. They will present at different ages, and they may have slightly different diseases. We heard some people get carpal tunnel syndrome, some people get more heart involvement, some people get mainly autonomic neuropathy. But it tends to hold true within that family, within that wider kindred. But the specific mutation determines what sort of treatment we use. As we know, we're a team of 5 million. New Zealand is smaller than Melbourne. We're smaller than Sydney. I guess I'm not sure the size of Queensland, but we should have a multidisciplinary approach to this disease. I think what I see, I'm as a transplant physician, I'm the ambulance at the bottom of the cliff. I see people who have never been seen or been worked up until a late stage. I think we need to use our links to Australia. I mean, personally, Australia has helped with our liver transplant program from the very inception. When we took back the workload they did for us and set up Northern, they helped us and really stimulated our growth. And I think we need to collaborate with our Australians. I think we already do. I think we've got strong links to the National Amyloidosis Centre in London. I think Julian Gilmore and Philip Hawkins have been fantastically supportive and have trained many of our experts over there. We're getting better gene silencing therapies. They will improve outcomes. They should remove entirely the need for liver transplantation or heart transplantation. But these are lifelong treatments, and currently they are not really affordable by the patient. And unless Pharmac change their approach to rare diseases, I think we will be waiting for cheaper versions of the same treatments to come up. But we need to lobby the drug companies and see what sort of cost sharing they will come into. And perhaps we can talk about that at the end. I believe that if this new gene therapy study, that's the name of the drug, is shown to be safe and effective, then that could provide a one-shot cure for patients both with hereditary and wild-type transthyretin amyloidosis. Whoops. And I already mentioned the need for timely diagnosis and treatment. We don't want to see people when they're at the very advanced stages of their diseases, so that they can have the maximal benefits. And this is just one, really just for thought. I think what we need to understand, I'd like for Peter and Simon who's on, to comment. I think we have never been, New Zealand is 0.1% of the world's population, so we've never been a popular choice for late phase drug development, because many drug companies don't see us as a source of revenue for marketing expensive drugs. And you know, there are some delayed fundings of our high cost treatments for rare diseases by our funding agencies. So that's been a problem for us. I think where we can really make a difference is we are regarded now as a very attractive part of the world in which to do early phase research, including first-in-man studies, such as this gene editing study. I think both Australia and New Zealand have very high quality early phase centres which can work with the clinicians to provide a venue to do this type of research. And I do think that that's thanks to, we have excellent expedited ethics and regulatory pathways in both Australia and New Zealand. So I think that is a way for us to get hold of these new groundbreaking therapies for both Australia and New Zealand. And I think, unfortunately for the rest of the world, but it's true that we have become very much a sought after place to do research with the terrible effects of the pandemic on clinical research in the rest of the world. And I've already said this, we all need to work together to ensure that we represent a united research group. And that way I think we can bring future trials of novel amyloid therapies. Not just for transthyretin neuropathy, but for transthyretin cardiomyopathy, we need the cardiologists and the neurologists and the hematologists to all get together in this field. So, thank you.
Any questions?
I've got 2 questions online, Prof. Gane, if you don't mind answering.
I was wondering whether Kim and I should answer the questions together, because
Sure.
they're probably going to overlap a bit. Is that okay?
That's fine, I'm quite flexible.
Yep.
Okay, can we have Kim? Very good. Kimberley Gamet is a senior genetic counsellor, team leader at the Northern Hub of the Genetic Health Service in New Zealand. She's been trained in the UK, I think, and she's been working in Australia. She's been working as a genetic counsellor for quite a long time, and as we can see, genetics plays an important part in amyloidosis for a lot of people. So thank you very much.
Thank you, and thank you to Jamie and the Association for asking me to talk today. As you can hear, I am from the UK, but I have lived in New Zealand for 15 years, and my girls have grown up here, so we consider ourselves very well established here now. So my talk is complementary, I think, to Ed's, but it's he's talked about therapies and things like that, and I'm going to talk more about the family implications and what genetic services role can have for working with families. I think as far as amyloidosis goes, genetic services don't seem to have been that involved with some of the families. And I think this is about getting the fact that we are there and we're publicly funded out to the association, and that we're here to kind of help. So Jamie asked me to talk a bit about what genetic services were, what a genetic test was, what role we play, what genetic counsellors do, and really why a genetic test is important. And I think that is evident from Ed's talk. So we are a national service. We have 3 hubs, one here in Auckland Hospital, Wellington and Christchurch, so that provides cover for the country. We're a small service, obviously. There are only about, I think last count was about 16 genetic counsellors in the country, so there's not many of us to cover the population. And we've been a national service since about 2012 now. And we go out and do outreach clinics across New Zealand. When Northern Hub covers Gisborne up to the top of the North Island, so we're quite stretched, basically. Okay, technology. We're even at it, and it's not. Oh, there we go. So, just to say who works in a genetic service, we've got the clinical geneticists, that are the doctors that specialise in genetics, and they normally the ones that make the diagnoses. And in this context, we see everything from preconceptual care to death. So they will often be seeing a lot of paediatric cases, which leaves the genetic counsellors who are very well trained, with a lot of background and process to get to be a qualified genetic counsellor. We're normally the ones that meet after a diagnosis and meet with the extended family and organise what we call predictive testing, and I'll go into sort of the differences of those. So in the context of amyloidosis, you'd probably be meeting a genetic counsellor, as your diagnosis would happen outside of genetic services. Ed's already talked about this, but I think about it probably a lot more simply than CRISPR and things like that. That when we're talking about what we test, so genes are building blocks of what makes us unique and us. Your genes are amino acids that are always in, I consider them your instruction manual, that are all built with 3-letter words. And those are stored within your chromosomes. You inherit one set of your genes from your mum and one set from your father. So you have 2 copies of each gene, essentially. Okay. And when we talk about gene mutations, we call them pathogenic variants, and there are subtle differences now according to what a gene mutation or a gene variant is. Okay, not all gene variants will cause a disease. So what we look for in any inherited genetic condition is a gene fault that actually causes disruption to what the gene does. It stops it making the right protein, it stops it functioning. Well, we all carry gene variants because we're all unique, and some of those variants don't matter. They're tolerated by the body. So what we need to have in a family where we've got a inherited genetic condition, we need to know what the specific pathogenic variant is in that family before we can do anything else. Because we do know, and we find more and more now, the more genetic tests we do, the more the improving in sort of genetic technology means we detect far more than we can actually interpret appropriately at this point. So we'll find gene faults that are variants of uncertain significance, and we can't interpret those, and we certainly can't do anything else for the family on the basis of a variant we don't know if it causes the problem or not. There are different, basically disease is a genetic thing, and we acquire changes to our genes as we age, but also we are born with those changes, and what we do in genetics is mainly hereditary, so germline genetics, rather than the acquired somatic genetics, that is actually becoming more and more important in how we diagnose and treat. Thanks. So that's the difference really between what is a diagnostic test, that is doing a test on someone that's affected with a condition, and more now those things are being pushed out into the kind of specialist area, the diagnostic area, and it's part of the diagnostic workup. And when we've got an identified pathogenic variant, that's when we can consider doing testing for families. So the predictive test is dependent on there being a pathogenic variant identified in the family. So when you will see a genetic counsellor, it would be to do a predictive test for an at-risk relative. And that's usually before they've had any clinical symptoms of the condition. So you're in a situation where they're deciding whether you want to know you're going to, or be at risk, or will develop the condition, or not. And having a diagnostic result matters because we need to know what we're looking for in an unaffected individual. If we didn't know what we were looking for, we couldn't be certain whether we would find it or not. So it's like having a needle in a haystack, but you know where the needle is. There are obviously over 130 different mutations with amyloidosis, so actually knowing what's specific to that family is important, and as Ed said, you can think about each different family in New Zealand having a different mutation, so we need to know which family it is and what we're actually looking for. I was actually going to take that one out and I forgot to, but that's just really describing a little bit what Ed was talking about, so I'll skip over that. So we also know that the different gene mutations cause different types of amyloidosis. And we also know that our pickup rate for detecting any pathogenic variants of amyloidosis is really good now. The sequence analysis will pick up at least 99%, which is probably, you can interpret as being 100% almost. There are always going to be some things we can't detect with genetic testing. That can be from a technological perspective, or it can be because it's a gene we just don't know about yet. As Ed said, we know that amyloidosis has variable expressivity, so not everyone who has the gene fault will develop all of the manifestations of the condition. We also know that different subtypes have different ways it shows itself, and also family history is still important even when you've got the gene variant, because we still can interpret what may happen to that family on the basis of what's already gone on in it. And also, looking into an ethnic or geographical group seems to make a difference as to how penetrant it might be. So for the Portuguese population with that specific mutation, 80% have the condition by age 50, but only 11% by that age in Sweden. So there are subtle differences across it that we need to be aware of as well. So going back to what we call genotype phenotype, so the specific gene causes the condition and the manifestations of it are the phenotype. And so we see how differently it is and how important it is for us to know what the specific mutation is, so you know what the spectrum of disease is for the condition. And each of those is different, causing the different CNS or cardiac forms of the condition. So genetic counselling is a process, and that's how we always describe it. It's a way of communicating to help individuals cope with the condition. It's not counselling in the traditional way you may expect a counsellor or a psychologist to be. It is about information giving and supporting someone through a decision-making process and supporting them with the outcome of that. So it is greatly about really information strong with counselling bit on the side, if you like. Okay. So when I was talking about genetic counselling, I said, well, we often will see people who have had a condition diagnosed during a pregnancy, through to adult onset conditions. Cancer makes up a huge part of our role now. So many times when we're seeing people, the kind of questions they come to us with will be, well, why has this happened? Why has this happened to me? What's the recurrence risk? Will it happen again? What can I do for my children? Can I prevent it? Can I prevent passing it on to the children? And those are the sorts of questions we are often face in a clinic appointment. And so they're the ones that we aim to help people understand and interpret and support them through those processes, because sometimes we can't actually answer those questions either. As Ed said, it's a dominant condition, so 50-50 risk of inheritance. And as this kind of made up family history, I wanted to show what we would do with a family if we were referred someone. So if we have the men are square and women are circles, so the man who was diagnosed with amyloidosis at 60 and is found to have a gene mutation within that, with no apparent family history of the condition, we can interpret that in some different ways. We can think, is this a de novo gene fault, and that means it's a new mutation in that individual that's occurred for the first time, or we can't be certain of that, so we would offer to test parents in the first instance if they are available for testing. And then if one of them has the condition, we know it has been inherited and we know which side of the family to consider the testing for. We also need to think, well, could there have been a germline mosaicism risk, and that's when the gene fault occurs within the egg or the sperm. So where it's not caused the condition in that individual, they have passed it on in effect. Now that's a theoretical risk for amyloidosis, because we don't know we've got any figures about if that may be the case or not. Genetic testing in New Zealand, if it is needed, clinically indicated, is obviously publicly funded. When we test for an adult onset condition, we need to test an adult for it. We don't test children for adult onset conditions because we want to ensure their autonomy and their informed consent, so they understand what it really means and what it may mean for their future and what decisions they would want to make on the basis of that information. So ideally we test at 50% risk because that makes the most sense. You want to test the next in line for inheritance, but obviously we will test at 25% risk. There are some kind of caution to be taken with that, because if the intervening individual did not want to be tested and had actually made that conscious decision not to know their genetic status, then obviously testing their child could reveal their genetic status, so we need to tread carefully in those situations. and how carefully we tread would really depend on the severity of the condition as well. Informed consent's a big deal, so autonomy and understanding what the outcomes may mean and what you can do about them all happens before you do the test. One of the things we do there as well is consider the psychological outcomes of knowing you're going to develop a severe condition and the knowledge that you may pass it on to your children. We also need to think about the people who don't inherit the condition within a family that has got something like amyloidosis, because there's a thing called survivor guilt that no one ever thinks they're going to feel, or say they're going to feel very relieved if they don't have it, but in the context of a family with sick siblings or parents, it can be quite a difficult adjustment not to have the condition, because actually it's like the absence of worry for yourself, but actually also seeing family members and the why me, why not me. So those are the kind of things we spend some time talking to individuals within families about. Although we often see an individual that very much is a family area of medicine, we always think about families, we always think about the impact on the wider family when we do these tests and what it may mean, and encourage that communication. Would be awful to do a genetic test or a diagnostic test on an individual who refused to share that information with family members. And from our perspective, wouldn't be one we really want to engage in. Except that's now obviously challenged when the treatment implications are so much more important. So one of the things Jamie asked me to say is, why have a predictive test? I said they're publicly funded. Diagnostic tests can take, depending on the lab involved, can take about 10 to 12 weeks to get a result back. Predictive tests are a little bit shorter, but again, lab dependent. If it's overseas, it takes longer. All of those issues about sending things around, particularly now during COVID, some labs won't even accept overseas samples. So turnaround times we can't get any shorter than that at the moment, but I'm sure they will continue to reduce as technology improves. But the importance of a predictive test in this context really is thinking about the therapeutic value. We know, as Ed's been talking about, there are more therapies that are becoming more effective, and also the potential of future treatment and the expansion of the treatments that are already being researched and being expanded into the other types of amyloidosis. Also, considering in the family setting, knowing that you will develop the condition, can't stop that happening, but we certainly can't determine how it may happen, when it may happen. Age of onset can be incredibly variable in all families. But what we can do is make sure people are being screened effectively, and that's where family history comes back into it as well, because you want to start screening younger than the youngest onset in the family member. And so we can make that plan going forward with those people. So the earlier the diagnosis and the more effective the treatment effectively. We also can think about other options for families too. So reproductive options are increasing requests that people want to have more information about. Now, whilst we can't always test for a condition when we've got a gene fault in a family, doing a prenatal test is a little bit controversial in the context of an adult onset disorder, where there is treatment and where that treatment is becoming more effective and certainly less invasive. So with adult, really there are two reasons anyone would do a prenatal test: is to end a pregnancy if it's affected, or to be able to plan and adjust to the information. In the context of an adult onset disorder, if you are intending to continue with the pregnancy, you're actually just done a predictive test on an unborn. And we don't test children, so it wouldn't really be a wise idea to do that, because there are many reasons why you wouldn't want to do that around worry, fear for the child, and maybe missed opportunities for the child as they grow up, knowing they're going to develop a condition. So there are many ethical considerations we would discuss with the couple if that were the case. It's not necessarily something you could refuse to do, but I think the support for it from a medical perspective would not be very strong. Also, pre-implantation genetic diagnosis, or genetic testing as it's called now, is offered in New Zealand. There is public funding for serious genetic conditions. There are 40 cycles a year. Okay, done it. Yeah, so the public funded in New Zealand for 40 cycles a year, but this is for all serious genetic conditions. So anyone wanting to do that, and within Auckland there are 20 a year. So there are waiting lists for this because it covers everything. This is a method of basically taking an embryo prior to implantation in the uterus and testing it to see whether it has or has not got the condition. It's IVF, so you have to go through all of the IVF, assisted reproductive technology meds, but also there are other rules around IVF, around BMI, age, how likely you are to produce enough eggs to get some kind of favourable outcome. In doing that, the reason for doing that is because you don't know how many eggs you're going to produce, you don't know how many embryos they're going to result, you don't know how many embryos would continue to develop past the biopsy stage of day 5. So in some respects it actually reduces the chances of having a pregnancy, but it does mean you are avoiding passing on if that was your choice to do so. There are different types of pre-implantation genetic testing. This is for Mendelian disorders, and there are others that are around now, not all publicly funded. The rules around PGT may well change as well if it's the more people wanting it and the cost of $1,000, they tend to really review the criteria for eligibility. So that's just sort of picture your biopsy on day 5 and look at one cell from that embryo. Just going back to prenatal diagnosis, they always would, the lab always recommend prenatal diagnosis to confirm any good result during any pregnancy. And that's just totally up to the couple and how the certainty they want. PGT normally has about 95 to 98% certainty that it's okay. And these diagnostic tests are the only ways of checking that. Insurance implications really have been changing over the last few years, and the fact that Australia put a moratorium on insurers up to certain levels of life or health insurance for asking for genetic information or family history information. New Zealand have not done that yet, and they will ask for genetic test results or if there have been any genetic tests in a family. It has proved to be some of a deterrent to genetic testing, but having said that, if you balance that against the successes around treatment or surveillance for conditions, I think still genetic testing wins on that one. They have reviewed this recently in the insurance companies here, but it's not been a transparent process, so I'm not quite sure what their decision making is or if we'll be able to get any moratorium. So, you go, taking that. Oh, thanks. So just really to summarise, we can do predictive testing if there's a diagnostic mutation in the family. We can't tell you how it may happen, what manifestations may occur, what age that may occur at. We can certainly make a plan for what treatment or screening is useful for the family, depending on the type of amyloidosis. And the point of genetic counselling really is to help an individual consider if they are making the right decision for themselves, to determine what plan would work for them. and also to consider what other options they may want to make on the basis of their result. And that's kind of what genetic counselling, genetic testing does here. So it's quite, talk's been quite generic after Ed, so yeah, I'm seeing there were some questions for Ed already, so.
Can I ask you, Kim, how do you get your referrals? Because I imagine there's an enormous number of people with genetic disease that would actually never be referred to or seen by your service. Is that right?
Yeah, so sometimes having the diagnosis in an individual is very focused on their treatment, and the treating doctor may forget about the family in that situation. So I think that the empowerment to the patient to ask for that referral, or if it's necessary, is one way of doing it. I think the use of genetic testing is becoming so much more important in so many areas around treatments. There's just been the recent report about PARP inhibitors and breast cancer use with BRCA patients. So it's becoming so much more important to have that information now as well. It's becoming much more on the agenda. And also when we have a known family, like we know obviously some of the families here, that they can contact us directly if they want to. If we have on call, so if anyone's got a question, they can, medical professionals can contact us and give us a ring to say, is this something you need to see? What do you think?
I was fascinated to hear about the transplant of TTR wild-type livers, and because I naturally assumed that livers and hearts and organs from us would be best binned. So, are you still going to use? Would you use TTR livers in transplants, and what other organs from a TTR patient would be suitable for transplantation?
I was talking more about the hereditary TTR, but whether it would apply to wild type, it probably would. I think the numbers of these domino transplants have been limited to people undergoing transplant themselves. Obviously, if somebody with hereditary TTR amyloidosis died, and the family or that person said that they wanted to be an organ donor, and the family wanted that to go ahead, that would have to be discussed. I think it would depend on which organs were involved, and that would depend, as Kim said, on the genetic mutation in that family as to whether the organ would be involved. It's not just the organ; it's also the blood vessels which supply that organ. Because there's no point, for example, donating your kidney if the blood supply to the kidney, because they do use your artery is very effective. But I think yes, I think the theoretical reason why it could be used. I think the liver, in particular, because the liver will transmit the disease tendency, so you'd have to look at a person, a recipient who needed the transplant, who was not young. So the recipient would have to be at least 50 years old, I would have thought. But I would have thought, certainly in that situation, you should at least have that discussion. This is more than I know, but we have a very good organ procurement network, or single network in New Zealand, and they always discuss any particular donor issues with people who know about that condition. So that's certainly, I would not discount organ donation. But it would depend on which organs were affected by that particular type of TTR amyloid. Does that answer? Yeah.
How can a person that's been diagnosed with wild-type amyloidosis be assured that it's wild-type and not hereditary?
I presume that would be through mutational analysis. I'm not sure Peter, whether you wanted to add to that? Or?
Look, it's the only way to be sure, because the phenotypes,
Yes.
how someone present can overlap, and TTR in its hereditary versions can sometimes be quite late onset. So some places in the world, for example, don't test the elderly for mutations, but we've had 3 families over 75 where the proband was, over 75. So, I don't. That is the only way you can tell. Well, that's not true. With mass spectrometry analysis, if you've got a sufficiently sophisticated system, which is probably really only the Mayo Clinic at the moment, you can diagnose hereditary variants on the basis of that, but that would still need genetic testing to confirm it.
Antonia, did you?
No, I completely agree. You need the genetic testing.
I think my understanding is now, because what they call sequencing of genes is becoming more and more high-tech, quicker throughput. Because recently we had to send, for example, there's a condition called Wilson's disease, where we always had to send the patient's DNA to the University of Vienna. There's one man there who used to do our testing and send it back, but now it's done at our hospital. So that now, I think most large reference hospitals have sequences which can do this reasonably quickly. Now, are we doing, for example, TTR mutation analysis at that plus? I think we could. I think we have the
What you also find as well is that there are so many labs, and not all of them can do everything. So there are specialty labs that will take on certain conditions, and Lapless is doing that. I could go on for ages about this, but yeah, the best way of doing testing it. Also, you never really get 100% when you say, oh, the pickup rate's 100%. We're a bit too cautious to say that. So, but you would far more likely pick up a mutation than not.
Now, Jamie, with some questions
yes,
online.
there's 2 questions online. One is CRISPR a cure? The second one is, how do you measure the efficacy of patisiran once a patient gets it?
I think the second question is probably a question for Antonia. So how do you measure the efficacy? You can measure prealbumin or transthyretin proteins in the blood to see that they have been reduced. Some of those studies of patisiran and artemisinin, where they showed in the studies the drop-off, you can measure that to show that it's working. But what you really want to know is that patient benefiting, and for that you need to have follow-up by the neurologist.
Yeah, no, I mean, I guess we look at things like the M7, which looks at sensory and motor function, neurophysiology, autonomic blood pressure recording, that sort of thing. But there are newer biomarkers as well that we're using in those clinical trials. So there's a protein called neurofilament light chain, which is in the plasma, which is a good marker of axonal breakdown, so breakdown of the electrical wire. And so we're using that as a monitoring tool as well. But with a lot of the clinical factors is the major thing that we look at. That's still research at the moment, but will become mainstream.
So the first question is CRISPR a cure? This is a study. It's the first study in patients, and we would be extrapolating from what we know from preclinical studies in animals, where the animals have a mutation associated with this disease, where it appears to be knockdown of the abnormal protein for as long as you follow them, and that would suggest that it is a cure. If you compare it, for example, to the patisiran type studies, you always get a rebound, although that can be delayed. I think it's likely to be a cure, but this is a study. We need to show that it's not only effective, but that it's safe long term. And there will be a long-term follow-up. There's the GTAC committees and these similar committees around the world. This is many years follow-up of these patients. Just like I get to say that we are recruiting at the moment. You have to have a hereditary ATTR. Currently, we're the only site in Australasia is in Auckland, but we're looking at until opening sites in Australia. we have had relatives from New Zealand living in Australia who are interested in one who's currently being assessed, who's a Kiwi who's moved. And I think this is the first study. There will be an expansion phase, and then there will be other studies. And the other studies, I'm sure, will give us the opportunity to recruit more patients, but also I think they will then move on to wild type ATTR. Yes.
In that regard, Ed, I can understand with the hereditary disease, it's a gene mutation, so you clip the bad bit out and throw it away or whatever. With wild type, there is no gene mutation, I believe. So how does it...
You're removing the gene which makes the protein. So you're moving it whether it's wild type or mutated. So you're knocking down transthyretin, and that's the permanent thing. So the question is, why do we evolve to make transthyretin if we can just get rid of it? And so the question is, what happens if you don't have transthyretin? Well, one of the things you need to know is transthyretin is the carrier protein for vitamin A. Vitamin A is what, how we eat carrots so we can see at night. It's vitamin A is really important for rods, yes. Thank you, friendly neurologist. So if you have this treatment, you do need to take vitamin A tablets. That's correct.
And what about
Thyroxine,
thyroxine?
in fact, there is a theoretical reason. Most thyroxine, as you know, is carried in other proteins, thyroglobulin, and there's really no, although that's being tested in the study, I can't give you the results, but all I can say is that there is no concern at the moment that it will alter thyroid functions or even the monitoring tests we use. Yeah.
The gene silencers to affect that.
Okay. Yeah. Can I ask, just in the gene silencers, how specific are they for just knocking off the production of transthyretin? Or do they actually overlap and knock off other protein formation as well? Or are they just very specific?
So gene silencers, I'm involved in many other gene silencing studies, mainly for viral hepatitis.
Yeah.
And they're highly specific.
Okay.
They're being used, for example, they're being developed to cure hepatitis B, not long-term therapy, but to cure it. And how gene silencers work is that they're complementary to the RNA either of made by that gene or made by that virus that they're using to treat infection. But you're absolutely correct. The biggest concern in the development of these gene silencing, this is the patisiran, inotersen, is that they may silence off-treatment genes. So you may have a gene on another chromosome which has the same sequence of nucleotides, so it would bind to that as well. And that could be an important gene for some other protein. But in fact, these are highly specific. They get enough length of sequence that the chance of off-treatment targeting, off-target targeting is negligible. And these development programs look at millions and millions of screens of potential off-treatment targets to make sure there are none. And certainly for Intellia, the amount of work they've had to do before they've submitted their dossier to the European and the FDA and then our various local authorities is huge, to show that they've done thorough testing of every other human genetic sequence. Thanks.
Thank you very much. There's some more presents here, so we better hand these out. And I think we're going to meet back at 2:45. Is that right? So we have a cup of tea now, or we stay here?
Yes, that's
have a cup of
wonderful.
tea, and there's a presentation from Simon Gibbs at 2:45.
Yes. So help yourself to more food. We're trying to fatten everybody up during the conference. So every tea and coffee.
No, we don't have it on just because it's 10% of our workload, so they wouldn't. It's not worth that. Yeah, so I mean that was one of the things I was just going to think because it's one of the good thing about the amyloid clinic is you have pathways of doing things because you've done it once, And one of our problems is that families members diagnosed somewhere, and the specialist, the daughter's at the consultation or whatever, and wants testing now, and so he just writes them a blood test, and it causes disaster sometimes. And so that's one good thing is that because the referrals for you guys, well at least for our genetics, they come from anywhere. Sometimes patient directed, and so they've got. So there's not always knowledge about what's going on from the genetic counselor's point of view, but then when they get a positive result, having an amyloid clinic is good for our genetic service. They say, right at last we know where to steer the patient. So they will, if most of the tests would come from us anyway nowadays, but if not, they know who to tell the referring physician to send them to, you know what I mean? Because you worry that you've got a result and is something appropriate going to be done, like is appropriate screening going to be started?
It's an awkward. Like, they don't want to take so why are you bothering?
Yes, yeah, you got to have.
It's very stressful.
Yeah, no, you got to have somewhere with it. Particularly 53 is a nightmare. That's a different. This is a microscopic problem compared to that one.
Well, yeah, but it's
There's
nowhere to go. And also, I kind of like, yeah. Don't go.
Yes.
Now I took to the clinic and known about it for a few years, but no one thought.
Yeah, no, well, you know, I find that in our clinic is that. So our clinic is good or bad. It's for good, really. We always have registrars in the clinics. It's just very important. Because they're going to be specialists in a few years. But they don't, you can't expect them or have them know everything about amyloid when they come to a clinic for the first time. So they sometimes see a patient. And the issue of genetic testing gets lost. And it's not picked up our multidisciplinary meetings actually 2 weeks after. And so, you would come across this issue, it really gets caught up, but it would have been nice to have dealt with it while the patient was there, to tell them, you're going to have to tell your family, this is how we're going to organise it. But then it's 2 weeks later, and it's not that bad, you can do it at home. You've got to have a process to make sure it's not missed. It does get missed.
Sometimes that's what we like small and not well resourced as many other medical professions are, but actually seeing people holding diagnostic questions is hard for us to do. So we feel like they're being taken care of, but actually some of them need So what are you talking on? What's your...
I've talked. I was last night.
Oh, okay.
Just hanging around.
Hanging around. And you feel
Just need another day, no COVID in Auckland, and then I'll be able to sort of sneak back into the country without any trouble.
You'll be okay.
I was reading in the paper this morning that 1,080 border force people have still not been vaccinated in New Zealand.
I don't think we've been done at the hospital. It's still only like 85%. Either some people hesitate still, or I think the rollout of the vaccine is not done.
Well, we've noticed.
People would like to think
and you can get quite a reaction to it. I got a cracker of a local, it's not local reaction, but just tired, rigors, and that thing spread very quickly amongst the whole hospital. And so a little gossip next week at the hospital, and so it rapidly turns into some bigger concern than it is.
Is it a side effect not it's just a normal reaction, really, isn't it?
It's a side effect of having a very potent imaging stuck into you, but it's not a dangerous side effect.
That's what I felt the same, because we had
my wife had AstraZeneca, got no reaction at all, but she points out that I got the land flu, as she referred to it. Although it is true, there is it is. So in fact, I was really disappointed. I thought it would be that I'm going to be more immune or something, but one of my colleagues who actually knows about this stuff said that the reaction's not, it's to the adjuvant, the thing they put in there to boost your immune system, not to the acute, fever, rigors, things. It's got nothing to do with how well protected you are.
I thought the same, and I definitely felt
Anyway, your talk was very good. Particularly the stuff about screening, family members, which is where all the difficulty is. I mean, we get enormous pressure from family members sometimes. It's a very emotional time for them, and they just cannot understand why you can't do the test and why you're recommending they see someone. They just want it done.
Welcome to my world.
Yeah, well, but you're trained to deal with it. Whereas for me, it's like that's a good thing about the clinic. We've got a rule, and you don't break it. So and our genetic services are very good. They're not quick, but it's not an urgent thing. You just have to try and talk to people about why they have to wait and all that's not going to alter their life. Yeah, they do. Yeah, but I can tell you, I remember one person who, we sent them through genetic counselling, and still, when they found they were positive, just completely broke down. But at least they broke down in contact with the genetic counselling service. I mean, they were suicidal and had to seek help and all sorts of things. And then the funny thing was, another 6 months went past, and all the symptoms that she developed, which were all amyloids and all disappeared. And it was all psychosomatic in the context of. So it's a good note, but I mean, it just brought home to me how distressing a time it can be for someone. They can get themselves that worked up. So it was. Anyway, you guys do a very good job. Well, at least my guys in Queensland do a very good job. Take away part of the job.
All right. Will that suffice? Yeah, I'll just see if I can without the screen falling over.
And do you have many other things besides TTR that you've seen?
Okay, sounds good. All right, Simon, I'll jump off the phone. I'm going to mute you so no one can hear anything in the background. And just perfect. Thanks, mate. Bye.
We've got pretty similar populations. 8 or 9 for Bridget families, probably 12 transthyretin families, and we've got 8 ones, so they're all there. Yes, well that is the you find that all the time. And you find it completely different between, look at this one family where there are 3 daughters with hereditary lysozyme, the mum's got it. And two of the daughters were tested years ago, like they're all in their late 20s and 30s now. But one of them just refuses to even see a counsellor to talk about the possibility. Look, I think TTR Amyloid. I don't have any hesitancy telling people they should be screened from that point of view. That is, by the time they get into trouble, which is going to be for most of 10, 20 years time, these treatments will be 5 years. Probably not because of their expense, but 10 years, 20 years, they'll be in routine practice.
Just making hang about suicidal things you kind of go when there isn't treatment.
Yes. Yeah, well, this was a few years ago when she had that, so that would have been before these wonderful. I mean, transthyretin's changed completely in the last 3 years from a. You can say much since Australia against basically people from your life, but these young families. That's one Kindred at the moment. She's had a liver transplant when she was only
only 26.
I could put a few things on the small table
here.
Yours is which one? Am I copying over?
Oh, is there a whole lot of stuff? Have you gone to a
Oh.
Yeah, don't go too old. Brilliant. Okay, thank you.
Some of these CRISPR, I mean, some of probably in my field, haemophilia trial would probably be the most advanced in that because I think these CRISPR changed.
Long time no see.
Yes, hello, Ed.
I get around to it.
Infusion
I've
every week.
seen you around.
HIV and hepatitis C and operations to just being fixed up. I mean, it's...
Yeah, I think so. Yeah, good. A long time ago. And that's when you were really good.
I think these monogenic diseases will be that'll just
the
be
subspecialty of cannabis medicine.
Right.
Well, that's sort of expanded.
I believe it was from P53 to fix it.
I think it's a look. Well, that's excellent. I enjoyed your talk on opioids for
Right.
I think it was at one of the GP. I've always when somebody is dying of cancer, it's been a long time to stay and not to read about but there's a lot of people
I've just unmuted you, Simon, so you can hear what's going on. We should be back into it shortly.
Over and over that they can't cope with numbers at the moment in this
This is Graham. This is my partner Tracy.
Hi, Graham. Grandson Luke's doing cannabis medicine.
Is that what you're doing exclusively now?
Well, I've got a few old faithful GP patients, and actually I do addiction work too. Where I trained as
My son works at the house. Look, I've got a present for you. I better wait.
Thank you. I asked Matt because I have the table, and then I thought, oh, my name's on the table.
Not just a name tag, there's something up there.
I've come to the right place. Well, you don't always get thanked for your work, so we appreciate it.
This has actually been a very useful meeting.
Yeah.
I've been a GP for years and years, and I got a diagnosis of amyloidosis 3 years ago, and on that basis I actually solved and I had to change but it actually has been good, hasn't it? I've enjoyed it.
To get to the other side of the desk.
I'll tell you what I can do. And most of the
doctors are not doing cannabis. Half are retiring. Sort of looking forward to a time where just slow down and loving work.
This feels good. And actually doing something like that, and actually just narrowing down what you actually do can be quite good as a job practitioner. Because as a GP, you're dealing with everything, absolutely everything. And actually just to narrow down and you can actually get a bit more excited or involved I do, but it's all looking after the shed, garden, painting the house, sitting with the sun, you know. That's the important thing. Yeah.
Now, where will I find a seat? Oh, hi.
Yeah, Ed's the one that put us on TV.
Yeah, good.
Yeah, I mentioned that somebody else that trying it out. I don't think he's one of yours, but when into the conference and have a conversation. So I haven't met Jamie yet, but running around. Yeah, right. Yes, he did.
Oh, okay. Okay, I'll grab it and find a seat.
Yes. Speakers to come on the street. It's a lot of species of stuff. So glad you could make it. And Anne speaks highly of you. And I would follow up later on as well. But again, the website was and I can mine's just all the same. Yeah, so grab coffee, grab as much and then watch the session and then.
Okay, thanks for the welcome.
So we can
Okay, all right. Simon, we are going to
everybody,
bring you in.
We are now going to have another video link with Simon Gibbs. He's going to talk more about, I think, treatment options for amyloidosis, and I think he's standing by and ready to go, so let's do it.
Hi everyone, can you hear me?
Yes, we can hear you.
Great, good. I hope you've had a good morning. It looked like a great program. Again, I'm still very sorry I couldn't be there. Let me just share my screen. So Matt has stopped me from sharing my screen. Again, he doesn't like me showing my slides. I don't know why. There we go. That looks better. Now, can people see that?
Yeah. Yep.
Yeah?
Yep.
Whoop. Don't know if you can still see that? Yeah? Yep.
Can he just hear us, or do I have to?
Oh yeah, there we go. There we go. Okay, so
better turn this off.
I've been given 45 minutes to talk about all treatments in amyloidosis, which is an unenviable task, and I apologise that there will be some things I'll talk more about than others, but I'm happy to take questions afterwards. So I thought I'd talk just very, very briefly about whether you need treatment for amyloidosis, that it's really important when we start off by distinguishing whether patients have localised or systemic disease, and then talking about predominantly AL versus ATTR, but again in the questions I'm happy to talk about other sorts of treatments for other types of amyloid. Obviously I'll be talking about some off-label use of some old drugs, what's licensed and reimbursed, what's possibly coming up, and clinical trials. So just a brief mention about localised. So I've had a number of patients who have been referred to me who have had amyloid at the back of their throat, or amyloid in their bladder, or amyloid in their gut, or amyloid in their lungs. And they just want to check that it was okay that we go on and give Velcade and a stem cell transplant, maybe radiotherapy to those patients. And I've had to say, stop, don't treat. This is localised. So we know that those sorts of places, the trachea the lungs, the bladder. They're areas that usually it's only ever in one spot and usually doesn't require treatment. And the same goes for sometimes we can have gut involvement where it's just found incidentally on a biopsy. It doesn't necessarily mean that we need treatment. So we have to work up patients right from the start to see, do they have truly localized just in one little spot and it's been made locally, or is it systemic? Is it through the body? Then we have to work out whether it's hereditary and acquired and confirm that we have the right type, because that's going to determine what treatment we will use. I showed this screen yesterday just to remind everyone that it's the protein that's pinned to misfolded that will determine the amyloid type, with the two main, most common types being AL and wild type or non-hereditary TTR. Again, I showed this yesterday that whenever we talk about treatments, we need to work as a team and communicate, and the goal is to decrease how much amyloid-forming protein is actually available, manage the symptoms to support patients' quality of life and function, and educate patients and carers so that they understand, enhance compliance, and help a sense of control. So let's start with AL amyloidosis. So Peter spoke about this yesterday. We know that the bone marrow, which is the factory that makes all the blood cells in the body, they produce these immune cells called plasma cells. And the plasma cells release free light chains, and it's those light chains that can misfold, and they stick together and make amyloid deposits. And if you look in that right-hand corner, I've put a little dot saying SAP, and that's important because all amyloid deposits have SAP on them, which is a serum amyloid P component protein, which has been a target of various therapies. But really what we've been doing with AL amyloidosis is learning from myeloma, so the related condition where there's a cancer of the plasma cells. And so we've been using myeloma type treatments to kill the plasma cells, and there's lots of different treatments that have been used and are available, and these continue to increase. But we've also looked at whether we can disrupt the formation of the amyloid fibrils by using old drugs like doxycycline, an antibiotic, or green tea extract. And really the holy grail is to see whether we can remove amyloid deposits that are in the organs, and I'll be talking about some of the trials that are currently underway or have been performed in this sphere. So there's been a lot of different treatments that have come under investigation over the last 10 years. Before then we were very limited, and really our major treatment since the early 90s was autologous stem cell transplantation, which is effective but highly toxic. I quite like this slide. This is a photograph I took at an amyloid conference several years ago. That's Maury Gertz, the head of hematology at the Mayo Clinic in the US, talking about the evolution of therapy. And on the top you can see TTR amyloidosis, that really we've had nothing except diflunisal since 2011. Before then we just had liver transplantation. But this has really changed in the last few years, and again just to highlight that we've got a lot of different treatments for AL amyloidosis that we can discuss. So getting back to autologous stem cell transplantation, the limits of this treatment has been the toxicity, and we really weren't very good at working out which patients would benefit the most. And what we saw was that 1 in 5 of our patients were dying during or very soon after a transplant. But with careful patient selection and greater understanding of the disease, we're now managing to get mortality rates when we use stem cell transplantation to as low as 1 or 2%. I won't go through thalidomide and some of the other earlier treatments which we don't use as much these days. Suffice to say that, and Peter presented this last night, that really a bortezomib containing regimen has now been seen as the standard of care because patients were in remission for longer. That's the PFS, means progression-free survival. The disease doesn't progress as quickly as if you just treat with melphalan and dexamethasone. And there was a significant difference in overall survival, with the authors saying that this is really the new standard of care. So I think we've all been using Velcade or bortezomib as upfront treatment. Myself and Haseeb Siddiqui in Perth have recently looked at our experience over a 4-year period recently, seeing what we do for newly diagnosed AL amyloidosis. I was interested to see that we had almost 100 patients over that 4-year period. And we saw that most patients were aged about 65, but there was a reasonable age range. Most patients were male, 3/4 had cardiac disease, half had kidney involvement, and about a third had more than 2 organs involved. And what we saw was that in 3/4 of our patients, we were using Velcade, cyclophosphamide, and dexamethasone. Some patients elected not to have treatment, and those that had significant nerve problems, where Velcade can cause damage to the nerves, if they've already had significant involvement, then in rare cases we elected not to go for Velcade. One of the problems with accessing Velcade, although it's improving, is that you have to call, in Australia at least, we have to call our patients that they have myeloma in order to access novel treatment such as Velcade. So for some of these patients, we had to use melphalan or cyclophosphamide, older style treatments, because we couldn't access the Velcade. What we saw was that about half of our patients had what we consider to be a good response to this treatment, what a VGPR, very good partial response or better. A very good partial response is defined as when the light chains, the kappa and the lambda, are less than 40, the difference between the two, the DFLC. The difference between the kappa and the lambda light chains are less than 40. We saw that about 85% of patients, however, did get some response, but we feel that the best response is when you can get those light chains to less than 40. We followed it, overall on average it was about 28 months of follow-up. We saw that a third of our patients have unfortunately passed away, and the average time in remission is about 18 months. Unfortunately, about 1 in 8 patients still die within 6 months of diagnosis, and so we still have the challenge of having effective therapy that works rapidly. Interestingly, about 1 in 5 of our patients were able to go on and have an autologous stem cell transplant. So we've spoken about Velcade up front, we've spoken about stem cell transplantation. What about those? Are there any other forms of treatment? We know that thalidomide and lenalidomide, the immunomodulatory treatments, are available in myeloma and can be available in AL amyloidosis also, but are really quite poorly tolerated. Thalidomide can cause a lot of neuropathy, nerve damage, and lenalidomide is really difficult to take in standard doses, so we often have to dose reduce, and we wouldn't recommend using lenalidomide up front. And in actual fact, in myeloma, we're starting to use lenalidomide and Velcade up front, and this is the first time that myeloma treatment's really deviating from AL amyloidosis treatment, but the recommendation is that we stick with VCD. We feel that in this group of drugs that pomalidomide is probably the best tolerated and has the most amount of efficacy. You can see here in patients with relapse or refractory AL amyloidosis that only about half of our patients actually respond, and only a third actually achieve what we consider to be a good response. So we need to be able to do better. The other problem with these types of drugs is that they can increase the values of the heart tests that we monitor to look for heart damage, and we don't know why this is the case. But whether it's thalidomide or lenalidomide or pomalidomide, we see that the NT-proBNP, the cardiac stress test, is increased in most all patients. So we know that something funny is going on. There have been now a number of studies, mainly retrospective, looking at this. There are 2 American, an Italian and an English one. And again, they all pretty much say that the overall response is about 50%. but only about 1 in 8 to 1 in 4 patients really achieve doses and responses that we consider to be adequate. So the new kid on the block, which has really been very exciting, is this drug called daratumumab, and that helps to, it uses the immune system to clear the plasma cells that are making the light chains that make the amyloid. So this is a French study that was run by Muriel Roussel, who is a good friend of Australia and New Zealand. This was also had some Italian involvement as well. And the great thing about daratumumab is that the responses were seen in more than half of patients after only 1 dose. And so we thought that this was particularly impressive. In this trial, they looked at 40 patients. Patients were given this IV formulation every week for the first couple of months and then fortnightly. We found that most patients were going to respond after 4 doses. If they didn't respond after 4 doses, it was very unlikely that they were going to respond. And we saw that 3/4 of patients were still alive after 2 years. So these are patients who have relapsed, so they've already gone through their first line of treatment. They had, compared to pomalidomide, we saw that 50% of the patients achieved what we consider to be a good response of VGPR, the very good partial response, with the difference being less than 40. So we've recently had a look in Melbourne about what we've done using daratumumab. So daratumumab has recently been listed as a treatment for relapse or refractory disease, so if you don't get a good enough response. We've treated 11 patients now, 10 for what we call a suboptimal response, not achieving a VGPR, and 1 for relapse disease. 8 patients received a second line, 2 patients third line, 1 fourth line, and again, the sort of typical median age of about 63. And what we saw was really impressive clonal responses. So we got those light chains down very quickly. And in fact, our VGPR rate was seen in about 3/4 of patients. We did have 1 patient die. He was already responding, and we don't feel it was due to the daratumumab. He had very advanced disease. And this really supports the idea that daratumumab is generally highly effective, rapidly effective, and well tolerated. So this led on to adding daratumumab to VCD. The Andromeda study has been the biggest thing in AL amyloidosis for quite some time, where daratumumab was added to VCD for the first 6 months. And then patients got daratumumab, and this was given not intravenously through a drip, but with a little injection in the tummy, and it was incredibly well tolerated. Patients complained that the Velcade hurt more than the daratumumab. And so really we're looking at daratumumab being subcutaneous, a little injection under the surface of the skin from now on. And really the results were very encouraging. We saw that when this is a very large study, about 380 patients globally, and we saw that both arms were very well balanced, and we saw that the complete response rates, the CR rates, that's where the bad light chains are, we can't detect any of the bad light chains at all, 100% knockdown. We saw that half of our patients achieved that after 12 months, and then slightly improved again after about 20 months. And so you can see that there's a massive increase in the response rates. And the VGPR rates, that rate that I said would be what we consider to be the minimum response that's really going to affect and improve survival. We saw significant increases, and the response rates were really quick, like 2 weeks when patients were achieving that knockdown. So we feel that this is a really great treatment. And this equated practically to improvements in the heart response. So the heart started to work better, as well as the kidneys as well. Double the organ response rates as well. And I mentioned it's very well tolerated. The major toxicity that we saw was that there was a slight increase in the rates of pneumonias in our patients treated with daratumumab. But once you get through the initial treatment, severe side effects occurred in less than 5% of patients, very well tolerated. So what about using the immune system to target the amyloid deposits? We've spoken about using these monoclonal antibodies to target the plasma cells that make the amyloid. What about targeting the actual amyloid deposits themselves? Well, the ones that have been in the biggest study was that's been completed now is this monoclonal antibody called NEIL-1 or lecanemab. And that was one where VCD, patients are treated with VCD, but they either receive lecanemab or dummy drug, or placebo. And that targeted the AL amyloid deposits. And we were very hopeful with this study, but unfortunately it just didn't work. It was terminated early due to futility. Now, interestingly, they went back and had a look at all the different stages, all the different patients, and said, surely there must be some indication of some benefit somewhere because it looked so good with the early phase studies. And interestingly, they found that the most advanced patients, the ones with the worst disease, the worst cardiac involvement, actually survived longer than those who didn't. So there is going to be a study of the lecanemab again in patients with very advanced upfront disease. So I think that this is NEIL-1 is not over yet. This is one to watch. I think the real hope at the side in this is this drug called SEAL-101. So SEAL-101 is another monoclonal antibody that's looking at trying to remove the amyloid itself from the target organs. And so this is one patient. You can see that the amount of the NT-proBNP, that heart stress hormone that's released in the blood, that significantly decreased just with the SEAL-101, which would suggest that the inflammation and the amount of amyloid in the heart is significantly decreased. And likewise on that bottom graph there, that's the indication that that's a graph of 24-hour urine protein, the amount of good protein that's been leaked out into the urine, and that's significantly decreased as well, just with the SEAL-101. So looking at, this was a trial of 12 patients, and what we saw was significant decreases in that heart stress test in 11 of the 12 patients. So it was really quite impressive. I know that Peter Millay has already opened this study in Brisbane, and we're going to be opening it soon as well. This is unfortunately just for upfront treatment, and it's only for advanced patients, so patients who have got significant heart involvement. But our hope would be that if this works, that we will be able to extend this to other stages of AL amyloidosis, whether for relapse disease or for non-cardiac disease. But we need to do the trials first, but I think that this is the most promising at this time point. What about, are there any other daratumumab-like treatments? Well, there are. There's one called isatuximab. And this was a study done in the States using 35 patients, and a lot of these patients had been treated with previous therapies. So almost all of them had had Velcade, about half of them had had a stem cell transplant, a quarter had had immunomodulatory therapy, and even 6% had had daratumumab. 2/3 of them had significant cardiac involvement, and what we saw was similar sort of rates to daratumumab. So the VGPR rate was seen in about half of our patients, and so really quite promising that isatuximab could be an alternative to daratumumab. So I mentioned pomalidomide, and now I've mentioned isatuximab, and we're quite excited by the idea of trying to combine these two. So we're looking at working in two different areas to try and knock down the plasma cells that make the AL amyloidosis. And the reason for this is we know that in test tubes and in mice, if you combine these two together, they seem to work together at really knocking things down. So that graph on the left-hand side, you can see that there is a significant knockdown of tumour if we combine those two, and that's been repeated in trials in multiple myeloma. So Peter Millay and I, together with the French who did that trial of daratumumab, are looking at, well, we are going to run a trial of isatuximab with pomalidomide with relapse and refractory disease, and we're hoping that that's going to open in about 6 months' time. Very limited spots for this, and obviously we need patients to relapse, which we don't want to see. But this is a really important study, I think, because we spoke last night about access to drugs, and I think that we need, in this part of the world, to work with European or US colleagues to run these trials and get access to these therapies. Venetoclax is also a really important new drug. So this is a graph showing response rates of this drug called venetoclax in multiple myeloma. And one of the things that they noticed was that if patients had a particular mutation, that meant that they made abnormal plasma cells, and that mutation is when part of chromosome 11 breaks off and swaps with parts of chromosome 14. We call that the 11-14 translocation. We found that patients who had that particular mutation, which is seen in about 1 in 8 patients with myeloma, they actually had pretty good responses. These are very heavily pre-treated patients. They had pretty good responses to this drug called venetoclax, and we've used venetoclax in lymphomas and in leukemias, and so it was tried in multiple myeloma, and there was a bit of a, wow, okay, well, 10% of patients who are heavily pre-treated will get a complete response. 4%, well, you know, we won't even be able to see any abnormal cells on the bone marrow, and that VGPR rate, which we spoke about, is seen in 27%. So 1 in 4 patients are achieving this. So that looked pretty impressive. And as I said, it's 1 in 8 patients have this mutation in myeloma. But when we talk about AL amyloidosis, it's seen in half of our patients. And we know that if you have this mutation, that you're less likely to respond to VTD. So we think that venetoclax is going to be a really important drug to use in AL amyloidosis. And Peter and I are working very, very hard with the drug companies to try and get access to this drug. There's been no actual clinical trials of venetoclax in AL amyloidosis yet, but there's lots of case series and case reports of experience where we've essentially experimented with venetoclax in our patients, and we've seen some impressive results. So access to venetoclax is still not available for this indication. You can buy venetoclax, at least in Australia. I'm not sure about New Zealand, and we can combine this drug with an antifungal medication. And that antifungal medication bumps up the levels of venetoclax in the body and makes venetoclax a little bit more affordable. So it's about 9,000 Australian dollars for a 6-month supply. So this is one of the things that we're doing now, is looking for the 11-14 translocation in all of our AL amyloidosis patients, just to see whether they may actually benefit from venetoclax later on down the track with their treatments. Now, I'm going to just mention very briefly about some of the other medications that can be accessed in AL amyloidosis. There was a test tube and some mouse model work that suggested that an old antibiotic called doxycycline might benefit even in AL amyloidosis. We know that there probably is a signal in ATTR, but there was a signal in AL amyloidosis. So the team at the Mayo Clinic, and they used doxycycline after stem cell transplants for AL amyloidosis, and they went back and had a look at those that received doxycycline as opposed to penicillin after their transplants for AL amyloidosis. And they found that those patients on the doxycycline did much better. And so we found that to be really interesting. And then the British went and had a look at their group, and they found that those that received doxycycline also seemed to do better. So especially if there was heart involvement. So I tend to use doxycycline now, as it's a good antibiotic, but it does have problems with sunburn and reflux, heartburn type symptoms. But there probably is some benefit from being on doxycycline. Green tea likewise, or EGCG is its other name. There was some very weak evidence it might be beneficial. However, the Germans did a study on that at various levels and doses, and really the outcomes were quite disappointing. So if green tea extract doesn't work, it will have a very weak effect, I think. So I'm not using it routinely in this sphere. Ixazomib was also, ixazomib is very similar to bortezomib or Velcade, and ixazomib is a once a week oral tablet, so very, very convenient to take. There was a trial looking at that in relapse and refractory AL amyloidosis, but it didn't meet what we call its primary endpoint. So the thing that they wanted to prove, they couldn't actually prove in the study. But there's no doubt that ixazomib is effective. It's weakly effective, but definitely effective, and it doesn't cause the neuropathy that Velcade does. So I'm not sure about New Zealand, but Takeda, who make ixazomib, do make ixazomib available for AL amyloidosis patients via compassionate access. So that would be something. I don't know if any of you can comment later on whether that is the case in New Zealand, but certainly we can get that as a potential treatment. I'm happy to take questions about that afterwards. So moving on to ATTR, again, it's we sort of work out where we, how do we treat this. We need to have a look about how TTR is made. Now, I mentioned yesterday about the four-leaf clover, or the tetramer, that the TTR likes this sit as a four-leaf clover. So we can use medications sort of as scaffolding to try to stop the four-leaf clover from falling apart into individual units that can kink and misfold and make amyloid. So the oldest is diflunisal, which I mentioned briefly last night, and then tafamidis and acoramidis, or AG10. We can also use gene silencers. The originals were patisiran and inotersen, but there are new kids on the block, so they've taken this patisiran and inotersen and they've changed them around to make them easier to administer and possibly more powerful. So that's patisiran, and the Ionis TTR LRX, which I think needs a new name. And we can also talk about the fibril disruptors again, so doxycycline and green tea. And last but not least, there is a monoclonal antibody called PRX004, which the people who made the NEO1, the Prothena drug company, have been talking about doing a trial on this for a very long time, and it hasn't happened, which makes me think it doesn't work. So I just wanted to talk about that we do have various ways in which we can slow down the formation of TTR amyloidosis, and I think that the future is going to be targeting at various stages, so silencing how much TTR is actually produced, stabilising the TTR that is produced, and then disrupting the fibrils that are made from the misfolded TTR. And maybe in the future we'll have monoclonal antibodies that can actually remove the amyloid that's already there. So I mentioned this last night, diflunisal I think is a very underrated and underused drug. It's certainly effective if you have hereditary amyloidosis with neuropathy. We saw that there's definitely a slowing down of deterioration, better quality of life, etc. And there's a suggestion also that it's beneficial in patients with many cardiac disease. I've probably treated about 80 to 90 patients on diflunisal, and probably about a quarter will have to come off because the major problems with diflunisal is the gastric irritation or some kidney problems. So we do need to make sure that patients are on an antacid to prevent stomach irritation and to check the kidneys. But there's no question that those that are on a stabiliser seem to do better than those who are not. Now, the problem is, again, you need to be able to tolerate the diflunisal, and the other stabilisers such as tafamidis and acoramidis are currently not available. So it's really diflunisal nothing at the moment, which is very disappointing. We have been working extremely hard with IDOS and Pfizer to try and get access to other stabilisers beside diflunisal. And this is because of the ATTRACT study, which demonstrated that tafamidis had a survival advantage for those who had isolated cardiac disease or wild-type disease. Interestingly, with tafamidis, when we looked at the tafamidis in those with hereditary neuropathy, it did not meet its primary endpoint. So remember I talked about primary endpoints about this is why we do a trial, is to try and prove something. Well, tafamidis could not be proven to be beneficial compared to placebo, significantly better compared to placebo in those with neuropathy. I had one patient who was on diflunisal. We managed to get compassionate tafamidis for it, and I switched him over to tafamidis, and he said he preferred the diflunisal. Diflunisal is $1 a day. Tafamidis is about $1,200 a day. So I think that their current pricing is difficult to justify. And the reason why I go on about this is really to go and say I've had a lot of patients get very upset that they can't access tafamidis. And what I would say is, have you tried diflunisal? Always try that first before getting access. But tafamidis, there's a little bit more data, and there's certainly a lot more money behind pushing tafamidis than diflunisal, because diflunisal is an old anti-inflammatory which is off patent. And again, I mentioned this last night that in a test tube there's a suggestion that diflunisal is stronger, and that AG10 or acoramidis is even stronger again. I know Australia and New Zealand have been involved in a study that has looked at AG10, and this was the initial study which demonstrated benefit, and now the study of about 300 patients globally in wild-type ATTR amyloidosis and variant disease is ongoing. We await those results with great interest. Some of my patients have been on study now for about 18 months, and I'm hoping that about this time next year we might start to see a readout of some of those results. Hopefully it'll be more affordable than tafamidis. In terms of gene silencers, we know that patisiran will reduce the amount of TTR that's produced and available in the bloodstream by about 88%, so it's highly effective. And inotersen ran about the same, so that 75 to 79% reduction. We know that patisiran works in terms of neurological function. It stops deterioration, and after 18 months there's a very marginal improvement in neuropathy as opposed to not being on a gene silencer. But the quality of life has certainly improved being on the real drug. And then we have to remember these are controlled double-blind studies. So the investigators, the doctors looking after you, these are independent. We don't know what you're on, and these are the results. So it's really quite impressive. And that further went on to have a look at patients with cardiac disease, and again in a double-blind fashion, with the doctors not knowing which medication you're on, we saw a significant stabilisation of cardiac function. Very well tolerated in general, so some patients do get some side effects, but generally not significantly worse than placebo. Again, inotersen, similar sort of results, possibly not quite as impressive as patisiran. So this one has a look at neuropathy, so we can see that with patisiran there was actually an improvement. This one had a very slight deterioration. How significant that is very difficult to say. Quality of life, again, was much the same. It benefited a little bit with patisiran. It's pretty much stayed the same on inotersen. I thought I'd finish off very briefly talking about doxycycline and TTR and ursodeoxycholic acid and green tea. So these are cheap, they're available. I must admit, so a lot of people talk about doxycycline with TTR, which is ursodeoxycholic acid, which is very difficult to say after a few pints. But that's not the reason why I don't prescribe TTR routinely. I just don't think it adds very much. So again, these are small numbers of studies, a small number of patients. And what we saw, so that top one, which had the most amount of patients, 40 patients, we saw that 2/3 of patients, their heart stabilised in terms of their blood tests after 12 months, but there's a lot of TTR patients whose heart sort of stabilise, don't progress after 12 months. But there was a suggestion that maybe their heart did improve a little bit. But what's interesting is that 1/3 of patients had to drop out because of drug-related side effects. And that was seen, with all the other studies as well. So I use doxycycline, and I would agree that probably about 1/3 of patients can't take it because of rash or gastric upset or sunburn. It was always important to take it with some food and avoid the sun. But the addition of TTR, very difficult to argue that it's worth it. It's not the cheapest drug in the world. I think TTR is about $400 a month. Doxycycline is cheap as chips. So I tend not to prescribe it, but again, happy to discuss afterwards. Green tea, again, the Germans love it. Very small numbers of reports. We tend to use it, and we really do need to analyse our data with this because we've treated over 80 patients with it. I actually tend to find that green tea works particularly well in patients over the age of 80. So I always hesitate about using diflunisal in older patients. So I find that green tea is generally very well tolerated, and that those who are over 80 actually say, oh, it gives me a bit of a boost. But I don't sort of push it up to the sort of maximum dose because of concerns about liver function. The fact we've got no prospective data that shows that this is definitely beneficial. So first, do no harm is the golden rule of medicine, and I just don't think we have enough data at the moment to really push the high doses. But it seems to be well tolerated in mice. And it's cheap. Last but not least, I just wanted to very, very quickly talk about anti-SAP monoclonal antibodies. And the reason why I brought this up is because this was such a big hope for the site. So we know that if we stop the production, we know that with amyloidosis that SAP is found on all of the deposits. So this here, I don't know if you can see my cursor, but the blobs in the middle are actually SAP scans. Now, it's only available in London, these scans, but why these scans are important is that they actually inject SAP, the protein that's found on all amyloid fibrils. They inject pooled SAP from blood donors into patients that is labelled with a dye. And it shows where the amyloidosis is very expensive and you're injecting a blood product into patients, so it's very difficult to sort of extrapolate that to other countries. You can see that with effective therapy, this patient on the top had significant hepatic liver and spleen involvement. And with effective therapy for AL amyloidosis and AA amyloidosis down below, we saw that there was a reduction in the amount of amyloid there. So the guys in London thought, well, actually, if we can label it with a dye, what about if we can label it with a monoclonal antibody that can actually chew up the amyloid? And it was seen to be highly effective and worked in all forms of amyloidosis, all hereditary forms. Very, very exciting. But they found that in TTR amyloidosis, it didn't seem to work very well. I just questioned whether they got the dose wrong. But also, SAP is also found in parts of the bowel vasculature, the blood vessels, and also in the basement membranes in the kidneys. So there was a concern that patients were starting to get significant bowel and kidney issues. in a small percentage, and so the drug companies decided not to proceed with furthering this treatment. Now, I know that Mark Pepys, who actually essentially invented this medication, is still trying to buy this back, because I think that this is probably the best treatment for patients who have no other options, and I think patients are big enough to be able to say, I can wear the risk of that. And so I think that we still need to push to try and see if we can get this drug at some stage, or modify it so that it's more tolerable. Trials are always a big thing to access drugs. So this is just looking again at TTR. The Apollo B study is just closed. That's again a patisiran looking just at patients with cardiac disease. The Helios B has also closed. That's using vutrisiran, which is the sort of second, it's taken patisiran and made it easier to tolerate, or at least more convenient, because it's an injection every 3 months. Ionis make inotersen, they have second generation medications as well, which are still in trials. And I'm not going to go on about CRISPR technology, because I know that Ed Gane spoke earlier on today, and that looks particularly exciting, but not available, at least not in Australia. Their study is open in New Zealand, which is wonderful. So, lastly, there are treatments that are free, like don't have salt, diuretics, exercise, meditation, which I sort of mentioned yesterday, and just focusing on the symptoms. So I think I'm running over time, so I won't go over what I mentioned yesterday, just to say that domperidone is the most underused drug on the planet when it comes to treating patients with amyloidosis. If you are feeling full, poor appetite, losing weight, I think domperidone works a treat. You have to take it regularly before meals. Midodrine's fantastic for low blood pressure, and you can try various therapies to address diarrhea and neuropathy. So with that, I just want to thank you for your attention. I'm happy to answer any questions.
Thank you, Simon. We'll just see if there's any questions for you here. Nobody has any questions, Simon.
I've bamboozled them all. It's after lunch, so everyone's asleep.
Yeah, I think everyone's asleep.
I don't have a question, but I'd like to say something.
Yeah, you're right.
I don't have a question, Simon, but this is, I think, the 3rd or 4th time I've seen you giving your time to the New Zealand Patients Association via Zoom, and I just want to say how much it's appreciated.
That's very nice of you.
I would certainly second that. I think you've been very useful to very many people who've seen you or spoken to you or heard you by Zoom. And so thank you very much, and thank you for your support of us people over the ditch from you. Okay? And you're very welcome to come and see us sometime. I hope that will happen soon.
Look, I would love to if they let me. I would have been there now. I had my tickets booked and my hotel booked, and I had my my guidebook how to speak Kiwi, the whole thing.
Okay, thank you very, very much.
Thank you.
Okay, what have we got now?
Will you bring me back in, or?
We've now got a presentation from the Pharmaceutical Patient Advocacy team, which I think we'll just have online.
Hello to everyone in New Zealand. I hope you're doing well and preparing for winter. Thank you for the opportunity to take a few minutes today to give you an introduction to Intellia. My name is Jeff Sahelski. I'm the Vice President of Development Operations here at Intellia, And I would like to take a few minutes today to walk you through our CRISPR-Cas9 technology, where it can be applied to human diseases such as TTR amyloidosis, and give you a little bit of a fundamental background on CRISPR-Cas9 technology itself. I'm the lucky one to be able to give you this message today, but here at Intellia, as you can see, we ride on the shoulders of giants. One of our founders, Jennifer Duwadna, received the Nobel Prize in Medicine in 2020 because of her fundamental work at CRISPR-Cas9 and the acknowledgement that this CRISPR-Cas9 technology may have a significant impact on human health and treatment of diseases. What I'd like to do now over the next few slides is give you a little bit more information on what CRISPR-Cas9 can do and some aspects of what CRISPR-Cas9 does not do. As we see here, CRISPR-Cas9 that Intellia is harnessing in the 2001 program is something where we go in and edit specific cells within the body. These cells are called somatic cells, or cells that are not transferred onto the next generation. Somatic cells that we are going to be targeting in the human body for 2001 are the hepatocytes, or the key somatic cells of the liver itself. Now when we look at the aspect of what does CRISPR-Cas9 do, let's think of CRISPR-Cas9 as a very specific pair of scissors that once it finds the cell of interest in the body, and for TTR amyloidosis, that cell of interest is the hepatocyte within the liver. Once we enter that liver cell, we get into the nucleus, this specific scissors cut a specific section of that genome that will then have potential impact on TTR amyloidosis. That permanent edit of that hepatocyte will reduce the production of TTR protein, and we're optimistic that that potential therapy will have an impact on TTR amyloidosis. Although this slide is visually simple, I think it's quite important because it provides a link to several of our videos that we have on our webpage explaining CRISPR-Cas9. In addition, there's other resources on our webpage with fundamental glossary about the terminology used to describe CRISPR-Cas9 that I highly recommend you take a look at. I mentioned earlier that our CRISPR-Cas9 technology of 2001 is specifically delivered to the liver hepatocyte. It is done through IV infusion, and the delivery mechanism is a molecule itself that carries the CRISPR-Cas9 as a cargo to the hepatocyte. Let's take a minute and review some aspects of what we've just discussed. As I mentioned earlier, the CRISPR-Cas9 technology that Intellia is harnessing in 2001 is delivered specifically to the hepatocytes in the liver, where the CRISPR-Cas9 scissors, once in the nucleus, explicitly cut a very specific section of the genome. That leads to a reduction in TTR protein and potential clinical benefit by prevention of amyloid deposits in the body. Here I'd like to review with you some fundamental preclinical or work in monkeys that led us to the belief that this compound, 2001, will have an impact in humans. Let's orient you to the slide. If we look across the horizontal axis, we're looking at time. And if we look across the vertical axis, we're looking at percent of TTR reduction in the circulation, so or in other words, in the blood. And what you can see here is with dose 1 and dose 2 of 2001, as compared to a non-dose or a control dose, you see a significant reduction in the circulating serum TTR by week 2 that is withstood over time through the year of follow-up in this study. These monkeys were only followed for 1 year, but it is believed that this single dose, as you note on day 0, is sufficient enough to lead to this significant reduction in TTR that will be prolonged through the life of the monkey. We expect the same in humans, which means a single dose leading to significant, meaningful, sustained TTR reduction for the lifetime of the subject. Now let's take a look at our first-in-man-human study that is currently being run in Auckland and London and soon to be open in other study centers around the world. It is a study of 2001 as a single IV infusion in patients with ATTR polyneuropathy. It is a two-part study, and as you can see here, some of the aspects of what we're trying to gather are safety and tolerability of the IV infusion, along with pharmacokinetic measures, listed here as PK. That includes absorption, distribution, metabolism, and excretion of our product, along with PD markers or pharmacodynamic markers such as circulating serum TTR. As it is anticipated that the single dose of 2001 will lead to sustained, meaningful knockdown of serum TTR, we are also looking at longer-term measures of the neuropathy itself by measuring NIS, mNIS+7, and some other neurological impairment scores. We are looking to run this study in 18 to 80-year-old subjects with additional entry criteria being found on our clinicaltrial.gov posting. Please take the time and check it out or ask questions of Jamie and team as they may have some additional information they can share with you. As I mentioned earlier, it is a single IV infusion, so we're very excited to be able to take a look at this study and soon understand if the monkey data or the non-human primate data predicted what we will see in man. As I said earlier, I ride on the shoulders of greatness here. Not only Jennifer Duana and the founders of the company, the day-to-day researchers that have taken the concept of CRISPR-Cas9 all the way through to where we can now be studying it in subjects with polyneuropathy. Thank you again for giving me the time to provide you some background information on Intellia and our CRISPR-Cas9 technology and our 2001 program. I'd also like to thank those patients and families that have participated in past clinical trials in TTR amyloidosis, those patients and families that are currently participating in clinical trials, and those that are seeking out information to understand should they volunteer to participate in a clinical trial. Have a great day down under, and I hope that you have a wonderful meeting as well. Take care.
Hello and welcome. My name is Teodora Weiss. I'm Head of Patient Advocacy and Public Affairs at Ionis Pharmaceuticals. Thank you, Jamie, for the invitation of this precious event. I would like to share some of my thoughts about patient centricity, how do we value patients, and how do we act, how do we put patient centricity from theory into action, into reality. Patient advocacy is a very important role within the industry. It's a strategic function within the company that serves as a bridge to establish relationship between the patient community and the industry, serving to inform research, development, and regulatory strategies, support market access processes. The role of patient advocacy is not only helping single patients and patient communities to understand their condition and manage their disease, but we would like to support them in order to have patients to be able to be connected to other patients, to share the burden of the disease and to support each other. We generate awareness about the disease together with the medical societies, and I would like to also put some more weights on the voice of patients, which can make a huge difference and impact quality of life, and of course, the accessibility to treatment. I said before, one of the most important things is how do we make really a difference in patients' life. I think what we can do is to put the current and future patients and advocates in the center in everything what we do. And I think we also need to start from the beginning. We always need to start and end with the patients. This partnership provides unique value not only for the companies who are developing medications and putting together the clinical trials and the clinical research programs, they are also benefiting for patients. I think the patient advocacy and involving patients early enough is really impacting every part of the pharmaceutical industry. If we involve patients early enough, for example, in research programs, we can make sure that it has developed more effective and efficient trials for the future. We can also think of patients' involvement in the drug development and incorporate strategies, as well as have economic data, research, and also the data collection, which is important for the future of the science of the medication that patients can get. Some of the cases in my past were helping us as a company to receive a positive decision in several markets in Europe to have access to the patient's medication. And that could only happen by involvement of patients. In Germany, for example, we got invitation that patient advocates from a certain disease area could go to an oral hearing where the decision makers are not only reading lab values and other documents, but also listening to the patients. And this is what we really think it could be important for the future, not only for Europe, but also for other countries. We should start and end with the patients. We should focus on issues that are critical to patients and incorporate them into the internal decision-making process. We should identify aspects of health affected by the disease that patients care most about and integrate patients' voice in the clinical trials, in criteria design, in the clinical trial design, and in any other aspects which can make a difference in the future. We should also develop additional mechanisms to capture symptoms. Therefore, we are organizing advisory boards where we are listening to patients not only about their symptoms, but also about their emotional burdens. And these advisory boards or webinars are not organized only for patients, but we are focusing also on caregivers. I think that caregivers, since they are the ones who are taking care of the loved ones, sometimes, many times, they are the ones who are the stronger part. They are the ones who are going after finding solutions for their loved ones. And therefore it's important that we listen to caregivers and involve them also early enough. We should harmonize the partnership with the advocacy community. We should maintain open and direct communications in both of the directions. And we should transparently and collaboratively having partnerships and trustful relationships. What I also think is important in the future is to empower patient advocates and communities to increase their ability to serve members through growth and independence and strengthen their belief that their voice matters. Many patients and patient advocates are weak due to their disease, but their voice matters. And I think if we empower them, they will be able to stand up for themselves. We should harness the patient voice and encourage patients to participate in public affairs projects. We should merge scientific knowledge with burden of disease to create innovative programs that carve a clear development path. And of course, we should find also common ways to access service provisions and governmental support. We as an industry, we would like to make a difference. We would like to have a larger number of patients suffering from underdiagnosed and misunderstood conditions with little or access or no access to service provisions. And that's why we put in the patient voice into the healthcare journey. I would like to thank you for your attention. Remain healthy and happy, and try to be, as you can, helping for patients. Thank you.
Hi, my name is Jocelyn Ashford, and I'm the head of Global Patient Advocacy at Eidos Therapeutics, a BridgeBio company. I am so grateful to be here, and I was thrilled when Jamie asked me to come and share a little bit about what's been going on behind the scenes at BridgeBio and Eidos. But before we get there, I have a couple of disclaimers. The first is that the information I'm going to share today is for discussion purposes only, and it's only meant to be shared in the context of this meeting. The second is a reminder that acoramidis is an investigational drug whose safety and efficacy have not been established. What that means is that acoramidis is not available to anyone around the world outside of a clinical trial. With that, I want to tell you a little bit about Eidos' parent company, BridgeBio. BridgeBio is based in California in the United States. and is a commercial stage biopharmaceutical company that's focused on genetic diseases and cancers with genetic drivers. But what I want you to take away here are our values, because our values are why I really love being a BridgeBio employee. The first value that we have is to put patients first, and that's not just lip service. You know, one example I can share with you that's meaningful to me is that patient advocacy, or my function, is one of the early jobs that's hired for at each of our affiliates. And that speaks to our commitment to the community. And we'll talk a little bit more about that later. The other core values are that we think independently. We love looking at different perspectives and having different people with different backgrounds having a seat at the table. We seek to be radically transparent in all that we do. We believe that every minute counts in order for us to really bring these transformative medicines to those who might be impacted by the diseases that we're studying. And we let science speak. And that category, that value alone, can be its own talk. So we'll save that for another day. But while you're here, it's because you're interested in the work that Eidos Therapeutics is doing. So Eidos is exclusively focused on transthyretin amyloidosis, either wild type or hereditary. It doesn't matter. This is all we do, and we've been working since 2016 in order to advance the development of acoramidis. There are two key studies that you may have heard about. But before I share with you what those studies are, I want to be very transparent and remind you that neither of these studies are currently recruiting here in New Zealand. What I'm sharing with you is just a little bit of background about them. So the first study, which you've been hearing about probably for the longest, is our phase 3 study evaluating acoramidis efficacy and safety for the cardiomyopathy associated with ATTR for those with wild type or hereditary disease. Now this is a really large study. It's already fully enrolled with over 600 participants, and we expect top-line results in early 2022. So really there's no news. We are just allowing those participants to go through the course of the trial, and we'll have more information for you early next year. The second is evaluating the efficacy and safety of acoramidis in treating the polyneuropathy associated with ATTR for those with hereditary disease. And this study is currently available on clinicaltrials.gov if you're interested in learning more information, but it is not yet recruiting. And again, there are no active sites here in New Zealand at this time. If you have any questions about either of these studies, you can feel free to contact us at medinfo@eidos.com. Now, the last thing I want to share with you before my time is up today is I want to share, I mentioned to you that putting patients first is our first value at BridgeBio. In my role, I get to focus on building relationships with patient associations and getting to know your experiences. And I do that for a couple of reasons. One is that having the insight and having those relationships allows me to understand what's going on well enough to bring some of those insights back to our team. And we do that in lots of different ways. Sometimes we get insights directly from you, where you're providing input on a clinical trial protocol or on some other activity or educational material that we're looking to provide. And then I'm also seeking to find ways to partner with the community in addressing some of your unmet needs that are outside of the drug development process. So I get to work with patient associations around the world, and part of that is obviously sharing what we're doing, similar to what we're doing today, but it's also around finding ways to partner to make sure that they have the ability to meet your unmet needs, whatever that looks like, wherever you live. So that concludes just a really brief overview of who we are and what we're looking to do across the ATTR space from the perspective of Eidos and BridgeBio. Again, if you have any questions, please feel free to reach out at medinfo at idosepx.com. Thank you so much for having me today, and I hope the rest of your meeting is fantastic. Bye.
Kia ora, New Zealand. We are Aiko Miura at Teresa Lane from the Untitled Patient Advocacy and Engagement International Team.
There are 7 of us in the Patient Advocacy and Engagement team.
And we are grateful to work alongside patient advocacy groups all around the world.
We have 2 main roles.
The first is outward facing, raising awareness and addressing the needs of the patient communities we serve. Through collaboration and partnership, we provide information, education, and support to empower individuals and their families affected by rare genetic diseases.
The second is inward-facing, actively listening to patients and patient advocates and integrating their perspectives across our business. We do this in different ways, for example, by holding patient panels and advisory boards. We have really enjoyed working closely with the New Zealand Amyloidosis Patient Association over the past year. Well, sort of closely.
And we look forward to visiting you in beautiful Aotearoa in the near future.
As soon as we can.
Thank you.
And bye for now.
We're going to, what did you say?
Yes, I just wanted to thank the pharmaceutical companies for that presentation. Thank you very much for sharing a little bit of what the company does with us. So right now we would like to also thank the online viewers for participating with us. The online viewing will conclude here. And again, thank you for joining us.
Very good. And now we're going to break up. Patients and caregivers are going to stay here.